Thank you, Dr. Radhika ma'am, and thank you, chairpersons.
We now move to our next session focusing on governance of ethics and responsible AI adoption by Dr. Sudha MJ ma'am.
To preside over this session, we warmly invite our chairpersons, Dr. Asha KR, Professor and Head Department of Anatomy, Siddhganga Medical College and Research Institute, Tumkur, Dr. Jayanti MK, Professor Department of Pharmacology, SIMS and RH, Tumkur, to kindly take the chair.
I now request Mr. Sai Kumar sir to introduce our speaker.
So good morning all of you. It's my pleasure to introduce Dr. Sudha MJ ma'am. I did MBBS, MD Pharmacology and DNB Pharmacology, PhD Diploma in the Bioethics and ACME. She is a medical and regulatory advisor at Heliomed, Bangalore, with over 20 years of experience in academic, pharmaceutical governance, medical devices, and digital health and clinical research. She has served as the Global Medical Advisor at Novo Nordisk Global Headquarters, contributing to regulatory strategy, clinical evidence, and medical affairs. She is a national level trainer in medical device regulators and research ethics. She actively mentors medtech and health tech startups and has authored more than 40 publications. With her extensive expertise in healthcare, medical technology, and regulatory sciences, we are privileged to have her with us today. Ma'am, warmly welcoming here, please.
A very good morning to all of you. Glitches with AI. So, I'm happy to be here today. Thank you so much, Dr. Shivlila and team, for inviting me over. And I'm happy to see some of my colleagues here in the audience. So, before this starts off, let's get started. Because as I always mention, the PowerPoint should not power us. We should power the PowerPoint, right? So this has been a statement since the time I've started using PowerPoint presentations, not a fan. But I still have it because that's one of the easiest and best ways to present concepts to students and easiest way as well. So yeah, before that gets started, we'll get started. So this session or conversation that we are going to have is not about how anti or how pro AI you are, right? So how many of you are actually using AI in teaching, in practice? All of us are using, right? Like Dr. Shivlila mentioned, in one way or the other, we all are using AI in our daily lives as well. But this conversation for the next 30 minutes is going to be like, how do we use this responsibly? What are the governance frameworks or what are the important questions that we need to ask as doctors? Even for students, like sir was asking, do students need this? Is there a need for competency? Absolutely. PCI, Pharmacy Council of India, has already incorporated. They changed their curriculum. Unfortunately, it has not yet happened in NMC. We would be looking forward for that, but probably they have taken it for granted as students are already using, faculty are already using. So competency development could be maybe for us as faculty because we are slow learners. So today's topic of discussion for me is responsible use of AI. So I'm not going to the intricacies of what AI is all about. Dr. Shivlila has introduced you to various types of AI. Again, there are multiple layers of AI. When I say AI, it's not like one single thing, right? It has different ways or varieties to what you are using. What are the tools that you are using? Is it truly AI? Is it just simple machine learning that you're using? Or is it AI? Irrespective of all those, we have this practice of using. How many of us here actually practice clinical practice? Do any of you practice? No? Most of you are faculty? Do you use it in medical education, teaching? Right? We develop certain case histories, scenarios when we want to teach, right? So for generating that, we may use some data which is already available, or we can ask the AI to completely generate it. But it becomes our responsibility to see to it that whether it has generated appropriately or not. Our skill still remains. As a doctor, our responsibility still remains whether you are using it for medical education or for clinical practice. In clinical practice, most of the doctors as of today are using mainly for summarization, to generate a summary. Okay? But it can also be used in different ways and formats. Whenever we have in hospitals, most hospitals have hospital social media platforms, right? Like WhatsApp, Insta, or other social media platforms. How good or easy is it to use as a medical doctor? Is it okay to use the social media platform to share patient data? How many of you say yes, we can share on social media platforms? How many of you say no? Do all of you agree? No, you cannot share. Okay. Ma'am, may I ask why? Why can't we share? WhatsApp has an end-to-end encryption, right? This is just a conversation. Yes, ma'am? Absolutely. There is no governance, meaning there is no guardrail put. It is free for circulation. It can move very rapidly. If it's a closed hospital group, everybody has signed a confidentiality privacy statement, and your hospital agrees or approves that policy, you have an institutional policy for it, then it's okay. It's still somewhere okay. Again, it's not like completely yes, right? So it again boils down to how are we using the technology, what tools are we using, and how well is it acceptable as per law and regulation. Okay? So let's see today in this session what are the important questions that we need to ask before we use patient data, before we use any AI tool, and how easy or difficult is it to adapt. Okay? Adoption of AI is not very easy. Nowadays we see AI tools, AI devices, AI platforms for clinical data management and generation. That does not make us or stop using AI. We cannot do that either. We need to adapt, but responsibly, right? For prescription, okay. Can you name some tools that you use on a regular basis? ChatGPT is the most commonly used generative AI tool, but that is not the all and end all. That's just a beginning, which is pretty good. What can we upload and what we cannot upload to ChatGPT? So if I say, I want as a clinical doctor, as a clinician, I want a differential diagnosis. I'll upload a patient history. Patient comes in. I have used a note-taking assist, okay, AI tool, a note-taking assist, and I have uploaded this entire data to ChatGPT. I can do that, right? I mean, it is easy. It's the fastest way to get the answers and response. No. So now, is it acceptable if I give the entire history of the patient, details, examination details, their blood investigations, their images, their pathology, radiology reports, everything I have uploaded. And I've asked, please give me differential diagnosis. It has given me 5 differential diagnoses. What are the problems you see here? What are the issues that you notice here with this? What are all the problems? Can you tell me what the issues here are? One is privacy of the patient is gone. We are not anonymized, okay? Then, what else is the problem? Is AI always correct? Has it always given the 5? How did it arrive to this top 5 responses of differential diagnosis? Is it always right? What was the data that was fed previously? How the AI tool has been trained? Based on that, it will shortlist the 5 responses, okay? The responses I get and the responses you get may differ. Even though you use the same prompt, it differs because it has memory of its own. It would have seen what all I have been using this tool for, and when I ask, it gives a regulatory framework in a different pattern than when you ask the same. So the problems here are, first, privacy of the patient is gone, confidentiality is gone. I am biased now, okay, because I always feel, okay, the computer has said it, so maybe it knows more. There is a bias, cognitive bias. We always have this. Even without the computer, sometimes we doubt ourselves, right? As a clinician, we have our doubts. Okay, so it confirms. Sometimes it is confirmation bias as well. It gives rise to confirmation bias. It may not always be the right answer, but it could be the right answer also. So that ultimate clinical judgment when we have to make, it should be our judgment. Now, if I say, in the same scenario, I have removed the patient name, hospital name, okay, and I have uploaded the rest of the details. Do you say I have sorted the problem because patient privacy is maintained? I have anonymized the data. Have I? Have I anonymized the data here? I have removed the patient name. I have removed the hospital ID number. I have removed the hospital name. Okay, I have put the patient details. All details about the patient with images and pathology report without name and hospital name. Lab name is not there. So do you consider this anonymization? Is it acceptable now? You all said anonymity is the problem. Privacy is getting affected. Now I have removed that problem. Have I solved it? What do you say? How many of you say, yes, I have solved it? Absolutely. But apart from that, the problem that I'm asking is of the privacy. Okay? So some of you actually said, yes, you have solved the problem. No, I have not. Because images can be DICOM images, which have metadata. You can easily trace it back to the patient. Okay? So we as doctors should be aware of what data we are using, what data is going into the public generative AI system, and how that AI is utilizing that data. That AI tool is not only giving you the clinical diagnosis that you are looking at, it is also training itself. They train AI, and there is no consent from the patient for all this. Nowhere we are talking about the autonomy of the patient. There could be personal data of the patient, like age, with certain rare diseases. It could be traced back to the patient. Okay? So these are all issues that we face with using generative AI public, like say, for example, ChatGPT. But does it mean I should not use ChatGPT at all? How many of you say, no, as a doctor, you should not use it? Can I have a show of hands who will say, no, I don't like AI? Any anti-AI people in the hall? I don't know online, I cannot interact, sorry. But at least in the hall. Any anti-AI people? I was initially. Okay, because the systems were not enough evolved. I did not have enough awareness. I did not know what the right questions were. I was. But now I'm pro-AI. But with all the safeguards that are necessary, that are required. If today somebody brings me an AI tool, maybe a medical device, okay, they say, use this to diagnose some X tool to diagnose a Y disease. If a sponsor or a company brings me this tool and asks me, okay, would you use this in your everyday practice? Would you use this in your everyday practice? I would say my questions towards them, what are the questions that should be? What are the things I should ask them before I can adopt? Because responsible adoption is important. I cannot always say, no, I'm not going to adopt. I'm never going to use any tool. So if I'm going to use a device or a tool, what or how? What are the questions that I should be asking? Can you give me some questions that I should ask this sponsor? They have a AI diagnostic tool to diagnose a Y disease. Okay? What will be the most common question? For any device, what is that we are going to ask? Forget AI. What is, if a device is presented to you, it is a diagnostic device, what is a common question that you ask? Absolutely. What is the accuracy? What is the sensitivity? What is the specificity? How accurate is it? All right? If AI layer is added to this device, what are the additional questions that you need to ask? What do you want to ask? Say the person who has brought this device is telling, this device gives 95% accuracy. How many of you will say, okay, I'll go ahead and use it because it has 95% accuracy? No, sir says, no, I'm not going to use it. Sir, why? Sir, no device is 100%. Sir, I would disagree with you on that. Even without AI, with AI, no device is 100%. But other than that, do you have any other response? That is acceptable. 98 to 99 is acceptable. Okay, now I'll change the scenario for you. I'll say it is 90. Yes, ma'am? Confirmed. In this particular population, it is confirmed. Madam is getting there. She is a fellow pharmacologist. She knows what I'm talking. Like in any other drug development, we have to ask similar questions with this AI tool as well. How was this tested? What is the clinical validation for this? Have you done a clinical validation? What data sets have you used? Have you done a real world evidence study? Have you used this tool in different population? Maybe it was tested in US. Like drug also, when we have drug tested in different geographic location, different population, we have testing in India as well, right? In our location, in our geography. Similarly, AI also has similar issues, meaning to say, we have to ask the question, what data sets were used? How you said accuracy. In what population is it accurate? When I translate it, have you translated it? Have you done a clinical validation for this? Have you done a real world evidence study for this? Where are the publications for this? Publications again is another issue. I'll come to it a little later. Okay? So what are the evidence? What is the evidence that you can show? Right? So for device development, for you to call it a medical device, a device should be helping in either diagnosis, treatment, or therapy. Okay? In any of these areas, if any tool is utilized, then it becomes a medical device. In medical device, again, we have software as a medical device, right? We have pure software as a medical device. This is not the ones that I'm talking, which is embedded in the hardware, like in MRI machines or a CT scan machine. There is a software. That is different. That's not what I'm talking. I'm talking about software as a medical device, which will help or support clinical decision making, okay, or in treatment, or in therapy, like say insulin infusion pumps. Very simple example I'll give you. Now it is AI-based release, okay. AI will assess what is the insulin level, based on which sensors will be this. AI will study that and it will tell how much insulin to be released. Earlier we used to manually do it. in the pump. And pump, we added sensors. It would do it by itself. But now it is even more advanced, more accuracy we have brought in. Again, when we are doing all this, and when we are adopting any AI, whether it is in daily practice or whether it is in a device, we have to ensure that there are various layers of safeguards that we have put in. So the common questions I have already mentioned. What are they? What were the data sets that were used? How is the algorithm? Is there any bias in the algorithm? How are we going to prevent hallucination? AI hallucinates. It will give results which you are not anticipating, or it has hallucinations by itself, and you have to be able to identify those hallucinations and put a safety safeguard or safety checkpoint which will ensure that the AI is not hallucinating, or you are preventing that in one way or the other. Okay, so these are all the common questions that you need to ask when you are adopting a AI tool. So as I mentioned, this session is about responsible use of AI. I'm not entering the space of what are the types of AI or how you are going to, I'm not an AI engineer. I'm a medical doctor who is specialized in medical device and AI utility, digital health. So now what are the rules and regulations that we need to follow? First and foremost, you should have an institutional policy. How many of us in our institutions have an institutional policy for AI? Most of us don't have it, but we should develop one, okay? We have recently, do we have an AI law in India which talks about AI, how it should be used, how it should not be used? Do we have one single law? No, we do not have yet, okay? So what do we use? What are the laws or regulations that come into play? What are the guidelines that come into play? When we use AI in healthcare, what are the things that come to your mind? Do we have any policy, guidelines, statements? Anything that you are aware of? We have, no, for ethical practice, NMC guidelines are there, right? We have biomedical health research guidelines by ICMR for general practice, for research. Likewise, for AI, do we have any guidelines? We do have AI guidelines are there. AI healthcare guidelines are there. It was released very recently in 2026. There is also strategy, it's called SAHI, Strategy for AI in Healthcare in India, okay? Which gives a framework for governance, how it should be, what should be the layers of when you adopt AI tools in clinical practice or in healthcare, what are the various layers that you should have as safeguards, okay? We also have something called BOTH, which is an open source platform validation by Government of India, by NHA and IIT Kanpur together. They have launched BOTH. It's called a sandbox, where what are we most worried about when we train an AI? We are concerned about data getting leaked or data getting out, privacy of the patient getting affected. So when we use this Government of India provided sandbox, what happens is data sets remain there only. Your data will be utilized in a way that it is basically federated platform where you can test or validate AI tools, okay? So there is a sandbox provided by NHA and IIT Kanpur together, which is called BOTH, which developers can use this sandbox to develop safely a federated outcome, okay, a governed outcome. Whatever data sets you feed into this remains there. You have again how to use, what to do and all that. So the question that you need to ask to someone who's presenting you as a medical doctor a tool, whether for diagnosis, screening, or for therapy, or as a device, if they're providing you a tool, you need to ask, I'm coming back to the same questions again. What are the questions that we need to ask them? What is the AI algorithm used? How have you prevented the bias? How have you prevented hallucination? In what patients was this tested? Was it tested only on clinical data sets? Was there an actual clinical validation of this? How did you arrive at the accuracy? If after having answers to all this, you should still have your own responsible analysis of how to use this tool, because even if you get the right answers for all this question, again, who is accountable for patient safety when you're using AI? You have a third-party vendor, okay, who's providing you a software, which is a clinical decision support system, which helps you make decisions, okay, for your clinical outcome. I'm giving you a scenario. There is a third-party vendor who's providing you a clinical decision support system, which is a closed system. It is not OpenAI. Yeah, it is not an OpenAI, okay. Still, you have uploaded all your data on it, and it has provided you a clinical outcome. Whatever diagnosis you are looking for, it has given you the diagnosis. Do you directly go ahead and treat based on that? Because it is a clinical decision support system which is developed for this only. So do you right away go and use that system? No, because ultimately it is, as a clinician, your responsibility, you are accountable. We talk about doctor in the loop, human in the loop whenever we talk about AI, right? But this human should not be just like sitting and clicking approve, okay. He or she should be able to make those clinical decisions by themselves and see whatever outcome that clinical decision support system has provided, is it in alignment with the patient in front of you, and have you understood that appropriately, and is it in alignment with whatever training you have undergone. So ultimately it is you who is making the decision. So if I have to say responsible use of AI, who is responsible? It is a clinician who is using these tools is responsible. Okay, this is one part of the problem where I'm addressing the role or responsibility of the clinician. Now, we are using this to treat the patients. We always we train our students to involve patients in decision making, right? Now that is the latest thing that we are doing. We want joint discussions, and then we arrive at a decision of how the management should be. Diagnosis we make, but the treatment part, therapy, how they should continue with it, we give them choices, we give them options, we consider them in decision making, right? So when we are using AI for the same, when do you have to actually tell the patient that we are using AI? Is it important that patient knows that we are using AI in decision making, in providing treatment? Is it important? Is it necessary? No? Someone says no. Yes? Some of you are saying yes. So is it a yes or a no? I want a unanimous answer from the hall. Should the patient be aware that we are using AI in any aspect, whether it is, for the initial summarization of the data, or for analysis of the lab reports, or radiology report, or a pathology report, or to arrive at a conclusion or a clinical decision support or outcome? Should we inform the patient? Does the patient has a right to know? But will you tell them actually? No. Some of them are very skeptical. They don't want to mention. It is a very tricky question, because see, as a doctor, if I'm seeing a patient, when I finished my MBBS and I became an intern, I wouldn't go to my patient and say, you're my first patient, okay, allow me to do this procedure. Would I do that? No. But at the same time, will I not tell the patient that I'm not very experienced? Will you allow me to do this? That is the right way of approach. Do you agree with me? Similarly, when you are giving that information to the patient, that communication becomes very important as to how you communicate. Patient has the right to know that we have used AI tools. For what you have used, if it is very simple, like maybe you are using a voice AI to generate the summary, or you are using a summarization tool, okay, simply to summarize whatever you have input, then it's not that of a big deal. You can just mention that, okay, we do use AI in our systems. But when you are using AI for specific clinical decision making or outcomes, when it matters to the patient's long-term treatment, then you should mention about it in a very effective way. Okay? So consent becomes important. Not only the patient should be aware of it and how we are delivering it to the patient. So I'll quickly just go back. I'll just quickly run through to see if I covered everything. I think I covered everything I wanted to say. My talk starts here with this question. AI gives me the answer, who is responsible for the decision? I just want to reiterate here, who is responsible here? Who's responsible? But ma'am, if I give you a scenario where the hospital is using for in pathology department a digital path tool, AI tool for diagnosis, and that's managed by a third party. I am just looking at the report. Am I still responsible? But I don't know if the hospital or lab is using the AI. Am I still responsible? Absolutely, I'm still responsible because it is my responsibility to know what or how the input is being generated. At the same time, they should have validated the software. That is the institution's responsibility as well. So every stakeholder has a responsibility. We cannot just not have that responsibility. We use AI for multiple things. For research, we do have ICMR AI guidelines. There is a framework. Whenever we are doing research in healthcare, there is an AI guideline or a framework for how it should be or what should be done. Okay? So, as I was mentioning, not all AI is the same. If you're using for simple voice inputs, even simple voice inputs can get complicated. That I think Dr. Girish will be able to tell us more about AI. But simple things can get complicated, but that's very simple. And initial for generating a summary document, that is okay. As long as you're using an enterprise version, the DPDP Act and rules are in mind. That is Digital Personal Data Privacy Act and rules. That is applicable. We don't have a single AI law as of now. So we have multiple layers of regulation or governance. One of them is when personal data of the patient is involved, you go with DPDP Act. There is also IT Act. If you're using a EMR or a hospital management system, hospital information management system, HMIS, then it is IT Act also comes into play. Okay? So it becomes, if you're using an AI-enabled medical device, the safeguards that you need to put or the awareness that we need to have when we use that will differ. We need to have more awareness regarding the same. So India's AI governance landscape is it's still evolving. As of now, we do have in February AI governance guidelines 2026 was released. Then came the strategy for AI in healthcare. We also have another layer, as I mentioned, whenever we have personal data, Digital Personal Data Protection Act and rules. Of course, we have the NMC professional ethics. That is the final bottom line, with or without AI. That is our clinical judgment that we need to follow. If we are doing some studies, research, then ICMR AI guidelines come into play. For development of medical device, we do have Indian medical device regulation by CDSCO. As of now, we do not have, we only have a draft guidelines for AI or SAMD, but very soon we will have a full legal law or rules released by CDSCO for India for SAMD. Okay, so these principles keep coming back again and again and again. Whenever we are using AI in our daily practice, whether it is for medical education, whether it is as a doctor, as a clinician, the very same principles keep repeating. It is the same principles if you are in engineering or in any other branch, but what we need to consider is how is this applicable to me as a clinician? That is what we need to consider. Okay? So we spoke about this. This is what I was talking about. When we remove just the name, there will still be metadata left out or it can be traced back. So it's not completely fine. So AI generated diagnosis, who's responsible? You all have already told, it's a clinician who's still responsible. The towards moving to the next part, human in the loop. That is the most common statement that they do. They develop all the tools necessary. They will say have a human in the loop that is required. So we just don't go there and click approve. Okay, we have to go through all the important parameters, see if it is appropriate, and then only we say okay. What are the problems that can happen? We have discussed this. If AI missed the diagnosis, what happens? Who is responsible? Again, it is clinician who is responsible. We cannot blame a system for accountability has to be there. It is us who is responsible. So when does AI become a medical device? As I mentioned, software as a medical device it can be, or AI as a medical device we can use it. If you're using generative AI just for drafting or discharge summary, it is not a device, medical device. As per the definition of medical device by CDSCO, if it is being used for predictive analysis or for prognosis or for diagnosis or for treatment, then it becomes medical device. Nowadays, we have something called health tech and med tech also. There is a clear distinction by CDSCO between health tech and med tech devices. Many of us are familiar with the health tech devices, no? We have those watches. We have that device called Temple, which you put on. We have earables. Have you heard of earables, which you put in your ears and that records some parameters, physiological parameters? You have the Ray-Ban Meta, which is widely available. It records and registers so many things, right? So there is a distinction by the regulatory between health tech and med tech. So when does a health tech become med tech is a big question that we need to answer before we start using it as a medical device. If anybody is further interested, please reach out to me later. I'll give you the complete framework of how to develop a device, medical device. So if it is a health tech device, we are not very concerned, because how CDSCO differentiates this is on two parameters. One is intended use. What is the purpose or what is the outcome that we are using that for? And the second part is risk. How much risk it will cause when we consider that outcome in our practice. Okay, based on these two, it differentiates into health tech and med tech. So if it is in health tech data, it is not regulated as of now in India. Only if it is in med tech space, CDSCO, that is Center for Drug Standard Control Organization, which takes care of the drug development and management, also manages medical device development. Okay. So these are all the various parameters. We have been coming back to these questions again and again. How was it validated? Where was it validated? How was the external validation done? Was there a real world performance done? What is the sensitivity, specificity? These are the questions as clinicians we need to ask whenever we start using a new technology or AI, right? If we know the answers for all this, at least the credibility that we can give to this tool will be much more than without having known all these responses. Okay. Bias and hallucinations are very common. So throughout the life cycle of this AI, we have to put some safeguards or quality checks which will prevent any of the bias or hallucination. Okay. AI in research, this is a little more well evolved. Whenever we are using AI in research, the guidelines are a little more evolved as of today. Okay, so every time you use an AI tool for your medical education, for clinical practice, for anything else, take a 30-second check. Have these questions on your mind. Get those answers for yourself. Just 30 seconds spend on it. If you get all the answers right, should I say go ahead and use it? No. Very well. Thank you, ma'am. That makes my talk, really successful, because after having all those responses, correlate it with the patient who is sitting in front of you. And if you, based on your clinical judgment, think that is right, go ahead with it. Then you might be asking me, why should we use AI then? Because it is faster, it helps, it gives you a variety of things which probably sometimes you may miss. It helps you, it speeds up the process, it thinks the way sometimes you won't be thinking, okay, but is it appropriate or not? Is for you to make that clinical judgment, okay? So I end this conversation with this. This is the governance structure that we use. It depends on whether we are using it for medical education, we are using it for clinical practice, whether we are using it for as a medical device for any of the purposes that I mentioned. So thank you so much for actively participating in this conversation. I keep telling always that, PowerPoint should not power us, and today it really mattered. So thank you so much. Thank you. If you have any questions, I'll be happy to respond. I haven't gone into details of it. If any of you need regulatory frameworks or anything in particular, please do feel free to reach out to me. Thank you so much.
I'm Dr. Jayanti, Professor of Pharmacology. I would like to express my sincere gratitude to the institution and Dr. Shivleela, Organizing Chairperson, Professor and Head, Department of Anatomy, and Vivek, Organizing Secretary, for giving me an opportunity to chair a session on this topic which is so complicated, that is responsible AI adoption, governance and ethics. This is relatively a new and emerging topic, and I was particularly interested to learn more about AI and its application in the healthcare. I sincerely thank our guest speaker, Dr. Sudha, for sharing her valuable insights, helping to understand the importance of this particular topic, what she has spoken. And one important message I take from the session is that AI adoption cannot be separated from governance and ethics, if I am correct. And AI should augment our knowledge and decision making, but it should never replace human judgment, empathy and professional responsibility. In healthcare, the take-home message, AI should be a tool to assist the healthcare professional, not a replacement for professional judgment. So this is what I have learned today. Thank you, ma'am. Thank you.
Congratulations, Dr. Sudha, for overpowering all the PowerPoint glitches. You did a commendable job. It was a very insightful session. And one thing I wanted to ask, some sir asked about including the AI sessions in the UG curriculum. Actually, we have in the foundation course of first year UG students, we have dedicated hours for computer and IT learning. Maybe we can include in that. It is not limited only for 15 days. It's a longitudinal program which runs throughout the course of first year MBBS. Maybe we can plan along with the medical education unit. And also, as ma'am said, the institutional policy is very important, because we can't tell the postgraduates don't use AI. Definitely they'll use it. Maybe that institutional policy, I think Dr. Tejasvi will tell about that in his session, research. Yeah, it was overall, AI should be used as adjuvant, not one whole main course. That's it. Thank you so much.
Good morning. So, madam, will you list which AI can be used now in India officially? Means we can use this AI in health. Is there any list?
That is a very broad ask.
Because the 12 lead ECG with software that is used, it is giving bradycardia, it is giving obliteration, that is used. But any AI tool, it can be used in India. Is this list available now?
Sir, I wouldn't say we have a list, but if you're asking for, are you asking for
any health device, it is under
medical device you are asking? All the medical device with the software embedded or AI tools, you can find us, you need to look for CDSCO approval for that. there is a whole
That means
process.
with purchasing that machine or
Yes,
anything, we should
yes,
find out
yes,
the CDSO.
Yes.
They have
You
completed
need to
or
ask them, please provide me your license, marketing authorization for use of this, because that will be provided only based on all this quality checks and validations. Again, there is a
but health devices, like you said, medical device and health, like is a band,
Health
Apple
tech.
band,
Sir,
that not
tech,
required.
Health tech, no limitation. We do not regulate it. In India, we do not regulate health tech. All are open for use.
Yeah,
But we cannot input patient data on it.
yeah.
Patients
is
can use it themselves.
Personal data, that is personal.
Yes, patients can use it for themselves. See, when the same software is used on Apple,
That for blood glucose level, they
the devices that you are talking about, they are medical devices, sir, because that provides you a diagnostic, that becomes a
that is
diagnostic
24-hour
device.
blood glucose that is
Yes,
monitoring.
Yes, it becomes a diagnostic device, so it becomes a medical device. As of today, we do not have a separate SAMD guideline, so we follow the Indian medical device regulation for that. And there are listed devices on SEDESCO website, what are regulated.
And
And every time you use or ask, somebody comes to sell you that, you can ask the sponsor, the company, to provide you those licenses.
okay, there is two things, madam. I am asking another question. One is means college side, that is means studying students, and one is clinical side.
Correct.
The students are using the AI and they are writing nice notes, everything. So we'll take a faith on that one, whether it is he's knowledgeable person or he's used AI. How you will differentiate it?
Very interesting question. Thank you for that. That is a common problem we encounter most often. But there are softwares which will tell you whether the student has used AI or not, how much percentage of AI has, they have, like in that draft, how much of it is AI. There are software tools which will screen, especially with dissertation and all, we have software tools which will tell you whether the student has used AI or not. But is AI making the students a little dull? I feel partly yes, because while learning, I think I feel like Dr. Vivek usually keeps telling, he has a way of learning from AI. He makes my 5-year-old, 10-year-old, 5th grade kid learn from ChatGPT. But my thought differs a little. First, I want him to learn a little, then use ChatGPT for bettering those responses. But it becomes difficult because we have taken Sanskrit as a first language for him, and we both don't know how to read and write. So that time it comes handy. So there are things which it can do. Again, it boils down to the basic principles and ask those questions. What am I using it for? But if you're asking me, can we curb utility in medical students? No, we cannot. But what we can do, train them so that they use it in the right way and a responsible way. And how not to, see, we all have to have this digital detox. So we have to train our students also to do that. Without AI, can you come to the same clinical judgment, which will be very difficult for them as of today. So that is something, that competency we have to enhance. Thank you for that question, sir. Thank you so much.
No, one last question. Last question. No, is there a rule or a system to restrict generative AI and Meditech for a licensed practitioners only?
No, sir, nothing like that.
So anybody can use.
Yes.
So that will add up to the number of quacks and general people using. So how do you prevent that?
So
No,
we don't
in
know-
that aspect, you need to inform the government to make some rules.
Yes, I think that's a good question. We do not have anything like that as of today, but there are some softwares that the developers sell it only to licensed registered practitioners. That again depends on who's developing it, right? So that is a possibility, that there could be misuse of it as well. Yes. Thank you.
Okay, thank you.
Done, sir. I'll share it with them. The organizers will share it with you. I'll share it with you. In India, as of today, we do not have.
Capacity will not be there only.
Many countries have put a law that at least social media utility has been banned,
Yeah.
but in India as of now we don't have anything. But they say age restriction is there. When they log in, it will ask, are you 18 and above? But every child will put yes.
So there has to be some restrictions on that.
Sure.
And one more thing is, what I learned is use of HI to apply or use the information given by AI. What I mean is HI is human intelligence. So our own brain will have to use. So to use that brain, first you have to develop your brain.
Absolutely.
So for that, we have to restrict the children from using, what I feel.
No doubts about it, sir. Thank you so much.
Thank you, Dr. Sudha ma'am, for sharing your valuable insights.
I request our chairperson to kindly present a token of appreciation to Dr. Sudha ma'am.
Professor Siddhartha
Recording
Institute
in
of Medical
progress.
Science, T. Begur, to felicitate the chairpersons. Thank you, chairpersons.
We now move to our next session focusing on multimodal Gen AI in clinical workflow by Dr. Girish L. Sir.
To preside over this session, we warmly invite our chairpersons, Dr. Anupama D., Professor, Department of Anatomy, Sri Siddhartha Institute of Medical Sciences, T. Begur, Bengaluru. Dr. Puneet K. Nagendra, Associate Professor, Department of Respiratory Medicine, CDSIMER, Dayanand Sagar University, to kindly take the chair.
I now request Dr. Krishna Kishore to introduce our speaker.
Good morning. It's my pleasure to introduce Dr. Girish, an academician, researcher, and technology leader with 15 years of experience in teaching, research, industry collaboration, and skill development. So he currently serves as Director of Skill Training and Placement, Head Department of AI and Data Science, Sridevi Institute of Engineering, Technology, Tumkuru. He is also an academic thesis supervisor in AI and machine learning at Liverpool John Morris University, UK, and his achievements include more than 25 research publications and multiple patents, and currently serving more than 5 PhD scholars. So please join us.
Recording in progress.
To welcome Dr. Girish.
So very good morning to one and all. Today I am talking about multimodal Gen AI. It is like advanced generative AI concepts. Like I'll talk about more on engineering aspects maybe more on AI and how AI can be used in healthcare and clinical workflow. So nowadays the data is very enormous. We are getting a data from most of the clinics, most of the hospitals. The data, maybe 5 years back, the data is very challenging to get the data. Now, getting the data is not a big deal. We have a huge amount of data. That is why we call it as big data. So when we talk about the data, it is coming from connected devices, especially radiology, clinical workflows, and all the data we are getting. And using this data, now people are moving a lot of, good automated things, which AI is, helping doctors, helping physicians to achieve some, good accuracy and also improving the results in terms of times. So a lot of time is reducing, and also as Sudha Madam mentioning, there are ethics and responsible AI is also come in picture. We should focus on restricting AIs and understanding AIs, how to adopt AI in clinical workflows. That is also most important. So Government of India is now taking a lot of initiation to adopt AI in most of the healthcare applications. In the same way, they are also bringing up some guidelines on what way and what rules which should use to adopt AI. Especially the most challenging aspects of AI is hallucination. Hallucination is the most challenging thing what we have seen now. Now, with the advance of some GPTs like Gemini, now we are reducing the hallucination, but still, as Sir asked one question, how do we control the AI adoption? Now, every students, every teachers, every common people now, they go to ChatGPT and they're asking, prescription about fever or thing. So it is not correct. So we have to bring a rule to avoid such things. Then only we can effectively use AI in healthcare. So even everybody now becomes doctor. They're trying to become doctors. That is not possible. So whatever the AI it comes, the outline of my presentation is whatever the AI it may comes or it may in future also, it is not going to replace any healthcare experts. It is going to an add-on tool for healthcare experts, maybe doctor or physicians, to take the decisions quickly and also to improvising their accuracy. That's it. So they are not going to, AI is not going to replace anybody. That is the outline of my presentation. So the topic which I given is multimodal generative AI. So I'll just take you what exactly multimodal, the importance of multimodal. So as we know, the data is coming from various parts, like types of data. I'll give you one scenario. So they may be tier 1 hospitals or tier 2 hospitals. These things will be having in one place. But in some places still, if you go to the places where radiology will be done in separate place, or even blood test is going to happen in separate place and X-ray is going to happen in a separate place. Though it is in separate place, but physician has to integrate all the things and he has to take some decisions. Okay, when we brought so many reports to the doctors, collectively he'll check all the details, history of the patients, radiology reports and pathology reports, and he used to check all the records and he's trying to integrate the things. That is where we are facing a lot of issue, and also time is taking a lot of, we are taking a lot of time to radiology. I think everybody knows, right? So now, for example, if I want to do radiology, it takes 20 minutes. If I use efficient AI, it will reduce in 5 minutes or 6 minutes. It will give you one picture about the image, and based on that picture, radiology specialist or doctor is going to take decisions. Ultimately, the decision maker is physician. Yeah, the patient is one, the data is fragmented. This is the challenge, as I told you. So though we have all the data, whatever the patient is needed, or doctor is needed, but it is in a different formats or different places where we have to take in. Ultimately, as a doctor, we have to collect it everything, and we have to fragment it, and we have to take the decisions. The problem at present we have, though, this fragmentation creates information overhead, repeated searching, and also risk of missing relevant information. Sometimes as a human, we may do some mistake. AI will also do mistake, and also human also do mistake because of repetitive works, and also high load or high workload, they definitely will do mistakes. So this is the challenging thing we are facing now. To overcome this, we have a concept called multimodal. Multimodal means the AI will take the data from various aspects, various sources, and integrate into one platform. It is giving you summary. So this is what most of the tier 1 hospitals now are integrating these things. Especially Government of India is funding a lot of money, especially in cancers, oncology, or even anemia and NAFLD. They're funding a lot of money in multimodal applications, because the data is, we will get an enormous of data, that too from different sources. How do we integrate and how do we correlate? As Sudha Madam rightly mentioned, the correlation is very important nowadays. The correlation plays a very important role. So how do I correlate? As a human, as a doctor, I correlate my data based on my experience. I may have seen 500 patients in my back history. Based on the 500 patient details which I have in my mind, I'll do correlate. I'll do correlate with X-ray machine and also pathology. But there is a chance of overhead time, and also there is a chance of misaccuracy or less accuracy. That is why now coming up with the mathematical algorithms. So AI is about mathematics. Mathematics will not do any mistakes. But the usage now, when we introduce GPT in 2023, there is a lot of hallucination, lot of bias comes. So that is why people are fighting. Now people are coming up with the new things. When ChatGPT comes in 2023, the majority of the problem which we have faced is bias, training bias. I'll just give you how AI will work first before going to these things. So when we go to hospitals, right? So there are 2 doctors are available. So I'll just keep on giving these examples all the time. So Dr. A is 20 years of experience, and Dr. B is 1 year of experience, but Dr. B is a gold medalist in medical and also PG. But still, we prefer the Dr. A because of his experience. This is what we feel, right? Though he is a gold medalist, sometimes we believe more on experienced doctor, because the doctor have seen the same kind of patients, maybe 500 patients, 1000 patients, 2000 patients, is having more knowledge than the doctor who have a gold medalist in UG, PG. So the similar way, so AI comes in. So why AI is getting very popular in healthcare? But I cannot feed a 20,000 patient details to the young doctor. It is not possible. So that is where AI is getting emerging, especially in healthcare. I can give an experience of 20,000 patients, 30,000 patients to the machine, where that machine will understand the patterns. The pattern recognition is the most important application of AI in healthcare. So it will identify the pattern. Based on the pattern, it will give you suggestion to the clinicians. Finally, the clinician will take the decisions. This is what the process we call it as AI. AI, there is a 2 concept called training and testing. So the training is going to happen with based on the already samples data, like we called it as patients, historical patient details. So maybe 10,000 patients of cancer, breast cancer, will, if we train in the model means machine, mean hardware. If we train 10,000 patient details to the machine, it will understand the patterns. Based on the patterns it understood, when we give a new patient details, when new patients comes to the hospital with some CT scan or mammography data, then if we upload that image to the machine, it will go and check the patterns. What is the pattern it has with the training? Based on the patterns, it is going to take a decision. This is what the traditional AI is doing. So we are dealing these things. Maybe 2 years back, this is what the case. When AI is introduced in healthcare, it is only for pattern recognitions. This is what I wanted to mention. This is a traditional AI. What traditional AI will do, it learns the pattern from historical data and to assist the, assist whether the disease is available or not, mean detection and prediction. So if you see there is a, lens or license, so it is going to identify and it is going to say whether the disease is there or not, yes or no. That is the traditional AI, what we have seen maybe 3-4 years back. Okay, it is used to just to, classify or to predict whether disease is having or disease, there is no disease or there is no chance. Okay, this is where AI starts in healthcare. So after this, we have a concept called generative AI. I think this is the most buzzword in AI. It is going to generate the data. Apart from only detecting or only predicting, it is also going to give you summary or recommendation. What is the tablets you have to take? What is the prescription is going to do? This is where the most demanded skill set or most industry is recognizing. Even USA is way behind India because of this. Because in India we don't have any independent chat GPT with us. The GPT tools we don't have. We have only GPT, either from OpenAI or Google Gemini. Still today we don't have any, not even single LLM in India. That is the one of the drawback of Indian research. People are struggling to kind of coming up with a new things. Now Bangalore-based company called Sarvam AI, it is come up with a new India's first LLM. So now people have started using our own data sets for building their own LLMs. So now whatever we are using, it is either from US or either from Europe. France, we have Mistral LLM. We use those data. Whenever we say using those LLMs data, again there is a question of bias. So when Google Bard has introduced in 2023, they have given a wonderful results. But the clinicians are it is not only in healthcare, in most of the cases, when we go back and check the quality of the results, there is a bias. Because they have trained the data on only US people or white people. There is a huge argument has happened in 2023 on ChatGPT and also Bard. Because these models have trained only on some particular region of people, and we cannot take those data and we cannot do it to some other places. That is where now responsible AI comes in picture, where there are a lot of things. I was giving one more lecture last time in a medical. It is an ethics and responsible AI, where if you give a data to the model, what is the data samples you are taking up from? What is the age? Okay, if I train the model for breast cancer more than 50 years of age, if I am giving the same machine to the 20 years of age or 35 years of age of patient, it is not possible. So if you want to believe in AI predictions, the data training is most important. So AI is just machine. We cannot blame AI, but the trainer or the training, what we have done, what kind of data we have used, that is most important. Ultimately, there is a responsible thing what we need to understand before getting into the generative AI. Now, the most challenging thing in generative AI is hallucination. As I told you, it is giving some wrong answer. So people are fighting, and people are improving the accuracy day by day. Nowadays, maybe last 1 year, we are getting a very good results. Now in India, there are some there are some tools which is already approved by Indian government, and also it is approved by World Health Organization. For example, one such best startup in Karnataka only we have for breast cancer is Nirami. So they used to build a AI-based device, a low-cost device to screen the breast cancer, and it is awarded by the central government one of the best startups in India. And also there are so many startups, they have come up with their own device which is adopting the rules and regulation of ICMR, and they are producing a very good results. So now the same Nirami is adopted in Apollo. Okay, now they are using this Nirami AI-based breast cancer screening in a daily clinical flows. So when it comes to generative AI, as I told you, apart from predicting or apart from classifying the data, it is also giving you some summary of the contents. So this is where we have seen generative AI. But the problem is, it is not going to take the multi-source data. It is going to take the either one source or two source. So to overcome that, now people have started using multimodal thing. This is very important. Now every research is going in healthcare. Either way they use multimodal, because the data for cancer, it is not only taking from only from CT scan. It is taking from so many aspects, and also so many aspects means patient's genetics details, patient blood test, patient radiology, all those things we have to take it together and we have to give it to the model. So this is the real challenging and real research is going on nowadays. So what happened? So it is going to take the data from multiple sources, and it is going to give a model. what AI model it is going to predict, mostly use it for yes or no questions or prediction. Generative AI, it is going to create a content like ChatGPT. So ChatGPT comes here. So if I ask ChatGPT to generate something, it is going to generate. But the question is hallucination. Again, the question is whether the GPT is generated is correct or not. To overcome that, there is a concept called RAG in AI. We call it as a RAG. To reduce the hallucination, to reduce the false negative, to reduce the false output which is given by AI, we will be using a technique called RAG. It is pure engineering techniques. We use RAG to reduce the hallucination, to reduce the false negative. False negative means wrong predictions or wrongly projected data. So now people like OpenAI or Gemini, they are using RAG to reduce this very less. Now the era is multimodal. The topic which was given is multimodal. Now multimodal is very popular because it is taking the data from various sources and integrating together and giving an output. It is not only giving output and pattern recognition, it is also giving a data and avoiding hallucinations. Yeah, one more thing. Why multimodal is important? Why multimodal? I've been keeping multimodal. Why it is more important? I think you also agree with this. So the data from only one source is not enough to take ultimate decisions. Sometimes we need to have a multiple data to take some decisions. That is why, as I told you, imaging, it does, what does the structure looks like? It will give you the structure of Alzheimer, maybe tumor. If we go with this, I can see the tumor structure, but may lack in clinical and historical context. I cannot go with the historical aspects through imaging. In the same way, laboratory, what is happening and physiologically. Binds plot may show abnormal biomarkers but lacks structural evidence. So each and every individual thing, it's having its own pros and cons. So how do we come up with these cons? How do we do that? So the answer is correlating themselves, correlating all these features together with a prediction, with a multimodal is a answer for this. So as I mentioned, correlation is one such things I think everybody knows, like comparing one variable to other variable. We call it as variable. You can call it as one report to other report and just find some pattern over it and try to use this pattern to come up with some solutions. That is called correlation. So now every aspects depends on correlation. For example, there is a correlation between imaging and also history. There is a correlation between pathology and laboratory reports. That correlation gives you a lot of useful information in the coming days. The value is not simply having more data. The value is connecting relevant data. I think this is the most important aspect. We have huge amount of data in hospitals, right? Nowadays, most of the hospitals are generating a data every day, every minute we are generating a data. Earlier, this is a huge challenge, but now we have a huge amount of data. The problem is connecting this data together is the challenge. Together is challenging, and if we try to connect this together manually, again time consuming, again there is a chance of misaccuracy, again lot of problem will comes. To connect this data together, we use multimodal techniques. So I'll just go with three use cases of medical. Okay. So instead of opening multiple system, AI organizes and connects relevant information. As I already mentioned, it will take all the data together and it will combine everything and it will find the patterns. Pattern is going to the next input for the AI model. That model will take decisions. So where does AI fit in clinical workflow? So patient consultations, definitely we can use AI. Data collection, as I told you, we have huge amount of data over in different department. Collecting and putting data in one place is challenging. We can use AI to collect the data. AI assisted integration, as I told you, integrating, we will be using AI, especially mathematics we'll be using. Clinical summary, it is generating a summary. So earlier it is used to predict whether yes or no question. Now it is going to generate. It is going to recommend the clinician. So this is the pattern I have observed in the X-ray machine. So this is my recommendation. You can take your final call. This is a recommendation where AI can give it to the clinician. So based on that, clinical decision will be done by doctors. So practically, so what can multimodal can do? As I was mentioning all this, it is going to summarize the complex patient details. So when I think COVID comes, right? When 2020, first wave and second wave, when COVID comes, maybe in first wave, we seen COVID cases more often in Europe and very less cases in India. So there is a challenging time when we seen such COVID patterns, especially in vaccine production or protein-protein interactions, where AI has played very big role. So most of the vaccine production companies have agreed, we have used AI to produce the vaccine to understand the patterns in it. So this is what multimodal can do with laboratory sessions, laboratory findings, clinical documentations, patient communications, explain complex medical information simply, as I mentioned. So there are some patients, so this is quite often, I've seen tier 3, tier 4 places where patients will not understand English, but something which we can give it to their content in their own language, maybe voice message or text message, that is also a application of AI. So where they understand only Kannada, but unfortunately representation of that thing in Kannada is also very challenging, and also doctors sometimes we don't know Kannada, but patient misunderstand the conversation. That is also happened. Some kind, so maybe 1 or 2% it happens. There is also one such applications where AI can be used effective communication way for a patient and doctors. That is also thing, and also day-to-day operations in medical, especially hospitals, we are using already in AI. Apart from this medical, there are a lot of things where we can use. In our medical college only, we are using attendance management system for medical students. So we have a 200 students sitting in a classroom. It is very difficult to take the class attendance by manually. So where we are spending 20 minutes or 15 minutes by taking attendance to avoid the proxy, we have implemented a CCTV based attendance management system. It is giving 99% of accuracy. We have trained it, we have tested it. So where every student's flow is monitoring in a medical college. So this is the application of AI. I know some hallucination is going on, some misunderstanding of AI, and somebody is using, as sir rightly mentioned, students are misleading the AI usage. Even some common people also, they are searching the tablets in AI, and also they're going to medical store. That has to be avoided. But other side of story, there are some advantages of also advantages of AI is also there. So I'll come up with two most important use cases. One is cervical cancer. I think you all know. So how multimodal can be integrated? This is what I have created simple slides. So if you can see, there are different types of different kinds of data. So HPV test, laboratory information, or visual findings. When we take these multiple data, we call it as a different sources. When we push them to multimodal model, definitely it will give you very nice summary. So this is where we can use this multimodal, for example, cervical cancer. So all patients, for example, these data can be generated in one hospital, or this will be generated in different hospitals. Integrating or connecting the dots is very important. This is where we can use multimodal model. Another example is metabolic risk. I think nowadays majority of most of the people, not majority, most of the people are getting fatty liver disease because of so and so reason. So again, in fatty liver things, we have to understand, and we have to take with multi-source data. We cannot only decide BMI. We cannot decide only on one parameter. We have to integrate different parameters. Then only we can take the decisions. Here also in NFLD decision also, definitely this multimodal application can be more useful. So if you can notice this, AI is not diagnosing fatty liver from one image. It is bringing different piece of clinical information into same context. AI output is not diagnosed. The physician makes final decision. So as I'm keep on mentioning this again and again, AI decision is not final. we are not in a stage where we cannot depend only on AI. AI can be a supplementary tool for clinician or doctors where they can take the decision quickly to reduce the time and also to improve the accuracy. So this is what the two use cases which I am planning to present. One is cervical cancer, another one is NFLD. So as Sudha madam also mentioned, this is the challenges we have. Still we are facing a lot of issues with AI, and still we are not in a position to claim, oh, we are good at AI adoption. No, in India, still we have a lot of challenges. One is hallucination. I keep on mentioning this hallucination bias, because the training of the data is most important for AI. Whatever the output which we believe from AI, the data is most important. If I train the data, for example, breast cancer, if I train the data of 1,000 patients, the age more than 50 plus, now we cannot take the training data to predict the patient which is the age between 20 and 25. So that is the bias going to happen. And also missing information. Information may be missing or unavailable in data, leading incomplete conclusions, or it is going to give wrong predictions. This is also one of the challenges in AI. And most importantly, data quality. The data quality also matters a lot. If the data which we are giving, it may be incomplete or it contains poor quality, definitely the decision which we have taken from the AI, it will not be trustable. So that is why nowadays the most demanded skill set is data pre-processing. So in AI, if there is a 3 steps, the second step is data pre-processing. Most people are spending more money on data pre-processing or data cleaning, because the output, whatever we receive from the AI, it is purely dependent on the data. If we give a proper data, then you will get a proper results. If we give a wrong data, we'll definitely get a hallucination, or we'll get some missing information over it. And also interpretations, as we keep on mentioning, interpretation with a different context also, it will lead incorrect conclusions. Now, automation bias. This is most dangerous now because of AI, generative AI. So earlier, this is traditional AI bias. Okay, that is because of training. But this is most dangerous now. As Sir rightly mentioned, we have to restrict AI to avoid this bias. Everybody is believing whatever AI is generating. I don't know whether in medical field, but in engineering field or in other field, whatever ChatGPT gives, some people will believe that it is correct. No. So automation bias is happening more. So still we don't have any LLMs in India. That is the one problem. I'm not talking about only on AI or healthcare. The results come from LLM, which is trained by somebody else's data, maybe US or some Europe and other things. Since we don't have our own LLM, which is trained on our own data, the data results come from this automated AI is not trustworthy. I mean, there is a bias in it. And also privacy risk, right? Privacy risk we have seen. So there will be a trend in every 2 months or every 1 month in AI. One simple example is nano banana. I think everybody know it. So when we upload our image, it will create some fancy image of us. Most of our students, most of our kids, they'll upload our images to the AI. That will create a nice image with a background or with some video. That is most dangerous now. If we upload the data into the public LLMs or public AI platform, definitely we are opening ourselves with the cyber security aspects or attacking security, or they will definitely leak the data. That is one thing. So now, that is why government has insisted students and also medical aspirants, medical persons, to avoid the uploading personal information to these peoples or LLMs. By avoiding these things, we can reduce lot of problem in healthcare. So this is the pipeline. I think whatever we have seen, all the slides, we have a various patient details. We will be flooding all the patient details or radiology details or all the details to the AI models. Definitely AI will give you some suggestion. Based on the suggestion, clinicians or physicians is going to validate. Ultimately, the validation stage or final approval things is going to with the doctors. If we adopt this life cycle, then we will succeed. If we adopt only AI, definitely there will be a huge failure in coming days. That is why government is restricting the usage of AI in healthcare, they have a separate body. They're coming up with a AI law in India, where if you want to, manufacture a device for healthcare or any other, platform, we have to get a permission from ICMR and other platforms. Then only we can adopt it in, healthcare. So this is where the life cycle. And so behind the model, there are some, real world implementation challenges and also most important aspects I have already gone through. High quality data, interoperability, privacy, security, reliable models, infrastructure, continuous monitoring. So infrastructure is one of the biggest challenge. How do I say, like, if I want to develop our own LLM, so the reason is why India don't have LLM, because of infrastructure. One is infrastructure, lack of support from government. So the same model from US, they're getting a huge funds from government. They're building a LLMs because of huge GPU machines. Now we have a very lack of infrastructure. If you want to have your own data center or image repository or data repository, you have to have a very good infrastructure, spending crores together money. And also continuous monitoring is one of the most important thing if you wanted to adopt AI in healthcare. So because the day by day, the data input we are giving is change. So if I give the data as I mentioned, the training happened, the age difference is different, and also location is also different. If I train the data of US people, if I'm trying to get the same output from Pavada or some remote place in Karnataka, I cannot assure, I cannot depend. That is why whenever or wherever we have to have our own data, our own LLM, still we cannot predict or we cannot fully adopt AI in healthcare. That is why now Government of India now funding Servam AI in a huge amount they are funding Servam AI, India's first LLM. So they are doing really good. Hopefully we will get our own region data will be trained in a Servam AI and we'll get a better results in coming days. So the conclusion of my talk, Vivek sir has given multimodal topic for me. That is why I just go through these 2-3 use cases. The importance of multimodal, combining and correlating. Correlation is most important in nowadays in healthcare. Conclusion, what is the physician remains control. So he is having control, but the adaptation of AI, we have to go through it. If we don't adapt now, somebody else will adapt and they'll go. If we don't adapt because of so and so fear, some hospitals will adapt and they'll go first. So people will go. For example, if I want to do radiology, if we don't adapt AI in our hospitals, so it will take 30 minutes. 30 minutes, maybe 500 patient or 100 patient in a day, they has to wait. Patient won't wait and they'll go to other hospital there where they'll get a report in 5 minutes. This is going to happen in future. So my opinion is adaptation of AI is very important, and also the most important is controlling AI and also bringing ethical AI is also most important. This is what I wanted to present. Thank you very much. Any questions? Yeah, AI hallucinations, sir, in LLM, especially after traditional AI. Yeah. So as I told you, going to have to classify yes or no. Okay. After this, we have a generative AI. This is the ChatGPT thing. So what ChatGPT will do, whatever we ask, right? Whatever we ask, it will give some data. Okay. So though the training is not there, for example, I have a patients of 500 patients, as I told you, same example. I have a 500 patient details which is trained by US patients, or the age between 60 to 70 patient. I have only that data pattern. But when you ask the patients of breast cancer for the 25 years, it is going to take the same samples and it is going to give the result, but it is not correct. So we have to that is called hallucination. Hallucination means giving a wrong answers. So this is most happening nowadays. Government is trying to adopt some techniques, even not government. There are so many companies are trying. As I told you, it is a technical word called RAG. So if we adopt RAG, it will go and check the data which you have. For example, if you have the patient, if it is between 25, then only it will give the result. Otherwise, it will give the answers. The results which you are looking, we don't have such data. It has to give, but most of the ChatGPT prompts, it will not give you like that. That is why we have to think over it whenever we are going to search in front of ChatGPT. So this is called hallucination. Hallucination means giving a wrong answer. But we feel it is correct. But the data which they are trained is wrong. Hope I cleared answer. Thank you. Yeah. Yeah. This is going to happen, sir. This is going to happen definitely. So maybe in another 5-10 years it is going to happen. The only thing is accuracy matters a lot. Okay, accuracy, and also clinically they have to approve. So now as we are in a stage where we not in a stage to approve those models in a clinically. In the coming days, definitely people are fighting and people are doing it. They're doing a lot of business out of it. So if we are not adapting, definitely someone will do. As you mentioned, how do we differentiate? Going ahead, instead of differentiating, we have to adapt it and we have to go further. This is what I feel. So if we, for example, in Tumkur, in Sridevi, if we don't adopt AI, definitely people who are sitting in Delhi with a tier 1 hospital, definitely they'll adapt and they'll go quicker. So by the time we'll go behind. So definitely, if you want to differentiate, this is a time, but differentiate. But going ahead, instead of differentiating, we have to go behind. We have to work together with AI, and there is a limitations, or there should be some restriction we have to make. So final decisions should be doctors, and it can give only suggestions. Ultimately, decision makers should be clinicians or some or doctors. So unless we get approved from government of India, now we are not in a position to take final decisions.
So, excuse me, sir. Here.
Hi, sir.
So I'm Dr. Puneet. I'm a pulmonologist. I congratulate you, Dr. Girish, because as you started, you said you're going to take a technical session. So I was thinking it must be too much for our doctors, but you made it very clear that what is the language of AI, what basic aspects of AI is really important. As we had discussed earlier in the audience, they were asking, do we have AI for medical students? I think AI should be there for the medical faculty first, because we have to be trained first to know what to teach our students. And taking this in background, I just wanted to ask you one question. Do you think it's very important to learn the language of AI in terms of programming, coding? Is it important for a healthcare professional?
I think I know Sidlinga sir well. So being a doctor, he is far away than our engineering graduates. I think he has not studied programming. Now, after AI adoption, he is quickly adapting things. I think, sir, now you don't need to learn language. So even engineering graduates also, companies like Google, nowadays they're not asking students to learn coding. They are expecting students to adapt the new things and solving some real-time problems. If you are ready to solve some problems, you don't need to learn coding. So when we were doing engineering, definitely the focus is only on coding. But now it's not like that. We have to adapt the new things to solve some problem. Ultimate question is problem solving. I don't think, sir, you have to have generative AI course, maybe online course or some other course, but need not be a programming. Programming is not that much important. Adaptation of frameworks is most important from the perspective of medical, what I feel. So there are so many tools, sir. There are so many tools like open source tools like anti-gravity, okay, and Gemini, Claude. Claude, I think you have heard a lot about Claude. It is eating up too many jobs in IT market, like thousands of jobs is going because of Claude. If we can use the Claude, definitely we can simplifies the usage and we can build our own solution. For example, you can build your own application in day or 2 days. For example, to maintain your own daily routine, to take patients in and out. If you want to monitor everything, you can build our application in 1 or 2 days without doing any coding. The only important thing is prompting. So prompt means you are asking ChatGPT or some tools to generate something. That prompt is very important. What is your prompt? What exactly you are asking? What is the conclusion you wanted to have? If you give properly, definitely it will give in 1 or 2 prompt. I think language is not matter, sir. framework is most important nowadays.
Coming to the one point of Canvas you were talking about, do you think how many data would be, as per now the current, what should be the minimum data programming
Yes.
should be?
Again, that is depends on the data. For example, if the disease is very new, as I was mentioning in a use case of COVID-19, so in 2020, very less cases happened in India, but still huge number of cases happened in Europe and other things. When there is a new disease, when there is a new research, obviously there will be a lack of data. But now there is one more concept I wanted to mention. Like there is a concept called synthesizing data. That is called if you have a 500 patient details, but if you want to have a more accuracy, definitely you need 5,000 patient details, but I have only 500. There is a concept called generative GANs, that is generative adversarial network. It is going to generate a synthetic data. Synthetic data means if I give your face to the ChatGPT, it will generate 500 similar faces of you. That similar faces we call it as a synthetic data. That synthetic data we will use it for our model training to give a better accuracy. So nowadays most of the new disease or new samples, sometimes when new research is going to happen, there is a limitation in data collection. Then they'll use synthetic data along with original data, then they'll start doing it. So I would say in terms of number, I cannot say numbers, but I'm mentioning the percentage. We will be using 70 to 75% for training, remaining 20% of the data for testing. Okay, so most of the data we'll be giving for training the model, so that models will understand the different patterns. Once understands pattern, then we'll give another 20% of the data to check whether the model is performing well or not. So I would say 75 to 25%. 75% for training, 25% for testing.
How reliable is that, sir?
What do you
The
mean?
synthetic data?
Synthetic data is not duplicate. It's not a, what do you say? It's a duplicate data. It is not a fake data. Okay. So there are two types of data. One is original data, synthetic data, fake data. So synthetic data is not a fake data, but is a duplication of the patterns, duplication of the data. If I am giving my face, it is a synthesizing the data. So of course, final decisions are developing a models. People still not believing synthetic data, but some research is going on. For example, in telco domain, some data which hospitals are not allowing to share the details. But as researchers, we cannot keep quiet, right? So then what they'll do, they'll use the synthetic data, they build a model or build a prototype, then they'll submit a proposal to government. If the prototype is agreed, the government will give a permission to hospitals or some governing persons to share the data through proper channel. That is why now synthetic data is using in real time. So in my PhD, I was working on a telco domain. So we asked China Mobile to share the details to understand the customer churn, but they're not ready to share the data. We have requested in all the formats. Later, what we have done, we have do synthetic data generation. Through that synthetic data generation, we have published a paper and we have approved. Again approved China Mobile. Then they have shared the details. So this synthetic data generation can be used for research purpose, not in clinical workflows.
Clinical practice.
Yes.
Okay. And regarding the sources, Dr. Girish, I have a question for you. So is there any checkpoint that from where we are getting the sources to fed into the system? So where you are trying to get the end result, so which has to be most reliable, most accurate, which we have to use it in clinical practice.
Yeah, there are some platforms. I don't remember the name. There are some platforms, they'll check only for data validations. So before flooding into models, as I told you, I'll take 1 minute. So as I told you, so lot of money is investing in data pre-processing. They'll validate first, then only they're giving. So there are some people are making money out of it. They're checking the validation of the data and they're flooding into things. I'll just give you, give me 5 minutes, madam. I'll get back to the details. Okay.
That was a very crisp talk. We thank Dr. Girish on behalf of the management and the
Thank you.
Department of Anatomy organizing team, and we congratulate the organizing team of Department of Anatomy also. Thank you very much.
Thank you, Dr. Girish sir, for your valuable insights. Now, the inauguration will be.
I request our chairperson to kindly present a token of appreciation to Dr. Girish, sir.
Now I request Dr. Premnand Ballal sir from BGS MCH Nagarur to felicitate the chairpersons. Thank you, chairpersons. Now the inauguration will be taken up by Mr. Saran sir and Ms. Febamul.
Good morning, everyone. A very warm and pleasant morning to all distinguished dignitaries, respected faculty, delegates, students, and dear participants.
Now I request our esteemed following dignitaries to kindly grace the dais. Dr. Raman M. Hulnaikot sir, Medical Director and Trustee, Sridevi Charitable Trust. Dr. Lavanya Ma'am, Professor, Ophthalmology and Trustee, Sridevi Charitable Trust. Dr. Harendra Kumar sir, Principal, SIMS and RH.
Okay. Dr. Mohan Kumar sir, Medical Superintendent, SIMS and RH.
Dr. Rekha Gurumurthy Ma'am, Vice Principal, SIMS and RH.
I also invite Dr. Nagraj sir, Group Director for Teaching and Learning, Student Experience and Alumni.
I also invite Dr. Tejaswi HL sir, Professor HOD, Department of Anatomy, Adityanagiri University of Medical Science.
Dr. Vasudeva Kulkarni Ma'am, Professor and HOD, Department of Anatomy, MEU Coordinator, Agash University of Medical Sciences and Research Center, Bangalore.
Dr. Sudha M.J. Ma'am, Professor and Pharmacology, Director, Helios Med Education Private Limited, Bangalore.
I now request Organizing Chairperson Dr. Shivalila Ma'am, Professor and Head, Department of Anatomy, and Organizing Secretary Dr. Viveka S. sir.
I also invite Dr. Ram Nair sir, Trauma Head. Please occupy the dais.
May I request everyone to kindly welcome our esteemed dignitaries and guest speakers with a warm round and applause as they take their seats on the dais.
Artificial intelligence is transforming the way healthcare is thought, researched, and delivered. From medical education and imaging to clinical decision support, research, precision medicine, and patient care, intelligent technologies are opening new possibilities while also bringing important questions to ethics, responsibility, privacy, and human oversight.
Every auspicious occasion begin with seeking the blessings of Almighty.
To invoke the divine blessings, now I invite Ms. Surya and Vinay, first year BPT students, to present the invocation song.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि गानचतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय गानमत्ताय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थायिने गुरुविक्रमाय गुह्यप्रवराय गुरवे गुणगुरवे गुरुदैत्यगलक्षेत्रे गुरुधर्मसदाराध्याय गुरुपुत्रपरित्रात्रे गुरुपाखण्डकण्डकाय गीतसाराय गीततत्त्वाय गीतगोत्राय धीमहि गूढगुल्फाय गन्धमत्ताय गोजयप्रदाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्तजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि.
Thank you, Ms. Surya and Vinay, for the beautiful invocation.
To formally welcome all over the distinguished guests and delegates now welcome at us.
Thank you, Fiba. A very good morning to respected dignitaries on the dais, distinguished speakers, honored guests, faculty members, delegates online and offline, students and supporting staff. It is my privilege and honor as the organizing chairperson to extend a warm and heartfelt welcome to each one of you to this national level hybrid CME on artificial intelligence in healthcare from theory to clinical mastery, organized by Department of Anatomy, Sridevi Institute of Medical Science and Research Hospital, Tumkuru. Today, we stand at the intersection of innovation and medicine, where AI is transforming the way we diagnose, treat, and care for our patients. This program aims to bridge gap between conceptual understanding and real-world clinical application of AI. I invite you all to actively engage, explore, and envision how these advancements can enhance our everyday medical practice. On this occasion, it is my proud privilege to welcome our esteemed chairman, in his absentia, Dr. M.R. Hulinaikar sir, a visionary leader with an unwavering commitment to quality education and compassionate healthcare. Sir has transformed his vision into reality through exemplary leadership and dedicated service. His inspiring guidance continues to lead our institution towards excellence. I extend a warm welcome to our medical director, Medical Director and Trustee Dr. Raman Hulinaikar sir, whose unwavering support and constant encouragement have been instrumental in fostering our academic pursuits. We are truly honored by your gracious presence here, sir. Welcome, sir. In his absentia, I warmly welcome Shri M.S. Patil sir. A special welcome to Dr. Lavanya madam, Professor of Ophthalmology and Trustee, Shri Sridevi Charitable Trust, whose meticulous planning and steadfast support have been invaluable in organizing this program. I extend a cordial welcome to our respected principal, Dr. M.L. Harendra Kumar sir, whose encouragement and guidance continue to strengthen every academic initiative, including this CME. Welcome, sir. A hearty welcome to our medical superintendent, Dr. Mohan Kumar K. sir, for his wholehearted support in making this program possible. Welcome, sir. I also welcome, in their absentia, Dr. Rekha Gurmurthy ma'am, Vice Principal Academics, and Dr. Hemant Raj sir, Vice Principal Administration. I also extend a warm welcome to Dr. Nagaraj sir, the Group Director for Student Welfare, Alumni. Welcome you, sir. I also extend a warm welcome to Dr. Ram Nair sir, who is a trauma head for Sridevi Institute of Medical Sciences. Welcome you, sir. We are deeply honored to welcome our distinguished invited guest speakers, Dr. Tejasvi HL, Professor and HOD of Anatomy and Vice Principal, Adi Chinchangiri Institute of Medical Sciences, Mandya. We are privileged to have you with us today. Welcome, sir. Dr. Vasudha Kulkarni, Professor and HOD of Anatomy, Akash Institute of Medical Sciences, Devanalli, Bangalore. It's a privilege to welcome you on this occasion, madam. I also welcome Dr. Sudha MJ, Professor of Pharmacology, Director of Helios Med Limited, Bangalore. We sincerely thank you for accepting our invitation and sharing your invaluable expertise with us. A special welcome to our in-house resource faculty, Dr. Sidlingaya sir, Professor of Community Medicine, SIMS and RH, Dr. Girish, Professor and Head, Department of AI, Dr. Krishna Anand, Professor, Department of AI of our Sridevi Engineering College, whose expertise will further enrich today's scientific sessions, and also welcome student speaker, Ms. Pranjal Soni. I extend a warm special word of welcome to all our delegates who have traveled from various institutions from within and outside the state to participate in the national level CME, and also our esteemed online delegates who have joined us from across the nations, Madhya Pradesh, Uttar Pradesh, Jammu and Kashmir, Rajasthan. So from all over the India, we have got a beautiful response. I welcome all of you to our national level CME. We hope your visit to our institution is academically rewarding, professionally enriching, and complemented by our warm hospitality. A heartfelt welcome to all our faculty members, postgraduate and undergraduate students. No academic event is successful without teamwork. I place on record my sincere appreciation to our organizing secretary, Dr. Viveka S., and every member of organizing committee, including the scientific registration, stage, hospitality, IT, transport committees, as well as our faculty, office staff, lab technician, housekeeping personnel, and student volunteers. Your dedication, enthusiasm, and tireless efforts behind the scenes have made this program possible. Before I conclude, I once again extend my heartfelt welcome to each one of you. Thank you for joining us and making this academic event truly meaningful through your gracious presence. I wish this CME every success and all of you a productive, enlightening, and memorable day of learning. Thank you.
Thank you, madam. We welcome you too. Lighting of the cinnamon lamp signifies a triumph of knowledge over the ignorance and marks the beginning of an enlightening academic journey. I request everyone to kindly rise.
I request to all the dignitaries on the dais to kindly proceed all the ceremonial lamp lighting.
thank you, respected dignitaries. Please be seated. Okay. It is now time to honor our distinguished guest speakers for graciously accepting our invitation and enriching today's scientific program.
I request all dignitaries to kindly felicitate Dr. Tejaswi HL, Dr. Vasudha Kulkarni, Dr. Sudha MJ. Thank you, dignitaries. Thank you, speakers. We are honored by your presence.
We now move on to the inaugural address. May I now request our respected Raman sir for inaugural address.
Honorable Chairman sir, former MLC Tumkur, Dr. M.R. Vinayaka sir in his absence here. Dr. Nagaraj Group Director, Sridevi Group. Dr. M.L. Harendra Kumar sir, Principal, Sridevi Medical College, Dr. Mohan sir, Medical Superintendent, Dr. Nayarji, Director for Trauma, Sridevi, Dr. Shivleela Madam, Professor and Head Department of Anatomy, Dr. Tejasviji, Professor Head of Anatomy, Adi Chinchungiri, Dr. Vasudha Madam, Professor and Head Department of Anatomy, Akash Medical College, Dr. Sudhaji, all the professors, delegate members from various medical colleges who are attending this national level CME, staff, faculty members of Department of Anatomy and other departments of Sridevi Medical College, students, very warm good morning to you all. First of all, I really appreciate and commend the Department of Anatomy to taking a great initiative of setting up this national level hybrid mode CME, that too in the field of artificial intelligence in healthcare. So it's quite surprising how come Department of Anatomy is organizing artificial intelligence in healthcare, a topic which is more into non-medical field as we think, but anatomy has always spearheaded everything. Department of Anatomy, it is the foundational course for all the medical sciences. It's the first thing we study for any surgeon to put an incision, for any pathologist to study a slide, for any radiologist to do a scan. You need to know the anatomical structure, the correlations. That's why Department of Anatomy has spearheaded all the foundational the sciences or the latest advances which is being happening. Time immemorial it has happened. Initially they were studying on, they were being written on parchments, then came cadaveric study, then came the notebooks or textbooks what we studied. Now it's all digital models. Even we study the three-dimensional studies, virtual reality being used in Department of Anatomy, even anatomy which we have in our skill lab. All this advances are spearheaded and being done by Department of Anatomy. So there's no surprise that this topic has been taken up by Department of Anatomy, and well done also with such good resource persons and such great topics which is much needed. So we feel what is this artificial intelligence being taking a role in healthcare, but it is the future of medicine. Yes, if we adapt, as Dr. Girish was telling, we need to adapt or else someone else will adapt. Yes, this is the future of medicine and we need to gain more knowledge in this field and adapt in our day-to-day practice so that we stay abreast the latest trends and the latest developmental therapies what is being done. So just yesterday we had a national level conference where international speakers also had come in the field of pharmaceutical sciences. They had similar topic of artificial intelligence, its role in pharmacy and pharmaceutical sciences and all. So it's taking ground, and we need to be there when it comes into each and everyone's life, a doctor's life and the patient's life. That's why we need more and more CMEs like this. So what is the role of an artificial intelligence, we might ask. It's already there in diagnostic medicines, though not completely, but various technologies are already being adapted. Like in a CT, they are already doing their artificial intelligence rendering images of and even the pathology, the slides, diagnostics, they're helping. In the field of medical educations, we are using virtual reality, we are using anatomy models. All those we are already adapted it. So that is in the field of diagnostics and all. But in the field of treatment, therapy-wise, also we have the surgeons, they're using robots. It's just a technology, but the AI part wherein they reconstruct the 3D models, how to, if there's any strokes or vascular strokes, the anatomical vasculature, how to operate, where to operate, everything is being done. So all those are already being adapted, and we need to be knowledgeable in these aspects. And yes, there is a question among all of us, as Dr. Girish was telling, a lot of jobs are being lost. But no, I don't think so. It's always a collaborative measure, each and everything. During times of 1990s, 80s, when the computers came into being, that too in our country, there was a lot of apprehension among various people that there will be job losses. But people who adapted it could survive. It's just an additive in our day-to-day means, which will make our life more easier, more faster. And that's what AI will be in the field of medicine, at least. No one can replace a doctor. No one can replace his compassionate touch, his healing words. No one can replace it. No machine can take it up. And that's what we need to emphasize on. Even if 95% of accuracy becomes in diagnostic medicine, but the 5% decision making has to be done by a doctor. That's what AI will be there for us, so that even the smallest of subtlest of the nodules, cancer nodule can be detected. A calcific plaque can be detected, the smallest of the by the AI modules. That's what it is there for, and we need to adapt it. And the apprehension where the AI will replace doctors, I don't think so. But yes, the doctor with the knowledge of AI will replace a doctor without AI. So we need to take into serious note of that. So, and that will make our life more easy and the patient safety even better. Now, it's not only in this field of medicine, even precision medicine is being coming in a big way. Genotypic mapping, wherein each and every person genotypes is mapped, and the therapies are being designed for each and every person. That will be the future. So the toxicity of medications will come down. The treatment aspect, the safety margins will improve. So all this we need to study and gain knowledge on. But everything looks rosy, but it's not all hunky-dory. There are the ethical issues of artificial intelligence, because the name itself tells it's artificial. It's not the asli intelligence, it's the artificial intelligence. So the ethical part plays a major role. It gives a, you can say, a mean, diagnosis or suggestion or decision it can give. But for a diverse population, varied population, whether it is suitable or not, that we need to take a decision. And also the accountability part, whether the clinical doctor who has taken the assistance of the AI models, how much he will be accountable, so who will be accountable, that part. All this is a concern where we need to lay more eyes upon, and more discussions need to be done, especially the ethics part, the AI and the ethics part. So more and more CMEs and conferences like this will give us more knowledge. And lastly, again, I need to appreciate the Department of Anatomy and the faculty members who have done an incredible job in taking up this topic. I also thank the resource persons who have come from various colleges, even our resource person from Sridevi Engineering College. I just listened to half of the Dr. Girish topic, but it was really very enlightening and all. It's not only what we are discussing or taking notes on, but practically also we are doing it in our college. For example, Department of Anatomy, Dr. Yogesh and Dr. Girish from Engineering College of Sridevi, they came up with a novel idea. Ours is since last year it's a batch of 250, and professors all know taking attendance it takes a big part of our time, maybe 15 minutes, 20 minutes. In that, a lot of proxies being happening. So they came up with a very novel idea. They put up a very high-end camera, and it recognizes the students wherever they are sitting in the classroom, and automatically with time stamped, it takes within seconds, it takes the entire classroom's attendance. So they have developed that in our own college, and it's being deployed since last month. This helps in alleviating the pressures of just time management, wherein half or 1/3 of the class is being used up only to take attendance. So it's just the simplest way, and the Department of Anatomy have taken up that initiative, and our Dr. Girish from Engineering College, they set up this model. So all this, as Dr. Girish was telling, it's the problem statements which need to be identified, and how an AI model can be inculcated into that and a solution be brought upon. That's how practically we need to place into being. So I wish all the very best for department, and all the delegates, thank you for coming here. We'll share more knowledge with each other. Thank you.
Thank you, sir.
May I now request Dr. Harendra Kumar sir, Principal, to kindly address the gathering.
Respected dignitaries on the dais and distinguished faculty, eminent speakers and researchers, and dear students, ladies and gentlemen. Good morning to one and all. It's my great pleasure and privilege to welcome you all to this CME on the timely and transformative theme, that is artificial intelligence in healthcare from theory to clinical mastery. This AI is no longer a futuristic concept confined to science fiction or research laboratories. It has entered our hospitals, clinicals, classrooms, and even our mobile phones. Today, AI is assisting the clinicians in diagnosing diseases, predicting patient outcomes, personalizing the treatments, interpreting radiological images, accelerating drug discovery, and enhancing healthcare administration. And we are witnessing one of the most significant technological revolutions in history of medicine. However, the technology alone does not transform healthcare. It is the healthcare professional who transforms technology into better patient care. This is why today's theme is particularly meaningful. Our goal is not merely to understand the theory behind the AI, but to develop the knowledge, skills, and ethical judgment necessary to integrate AI effectively into clinical practice. Dear colleagues, artificial intelligence should never diminish the human touch in medicine. Compassion cannot be automated, empathy cannot be programmed, and trust cannot be generated by algorithms. This remains the unique strength of healthcare professionals. Medical education itself is undergoing rapid transformation. AI-empowered adaptive learning platforms, the virtual patients, simulation-based education, automated assessments, intelligent tutoring systems are changing how future doctors learn. The faculty members must also continuously update their competencies to effectively teach and guide students in this evolving landscape. Our institution recognizes the importance of preparing the students and faculty for this digital future. So we must cultivate professionals who are not only clinically competent, but also digitally literate, ethically grounded, the research oriented, and capable of collaborating with engineers, data scientists, and healthcare innovators. The research opportunities in AI are expanding rapidly, and predictive analytics, precision medicine, and population health management, digital pathology, robotic surgery, telemedicine, and clinical decision support system offer exciting avenues for interdisciplinary collaboration. I encourage our faculty and postgraduate students to actively engage in AI-based research while ensuring the scientific rigor and ethical responsibility. Today's CME provides an excellent platform to interact with experts who have practical experience in implementing the AI across various medical specialties. I urge every participant to actively engage in discussion and ask thoughtful questions and critically evaluate both opportunities and challenges that AI presents. Let us remember that mastering AI is not about replacing the doctors with a machine. It is about empowering the doctors with the intelligent tools that enable faster diagnosis, better decisions, and improved efficiency, and ultimately a better patient outcome. As healthcare enters the era of digital transformation, those who embrace lifelong learning will lead the future of medicine. So today's program is an important step in that journey. I sincerely congratulate the organizing committee for selecting such a relevant and forward-looking theme. My appreciation also goes to our distinguished resource persons for sharing their expertise and valuable insight. I wish this CME the great success and hope that every practical participants leave us with the knowledge, the practical skills, and renewed confidence to integrate artificial intelligence responsibly into a clinical practice. Together, let us move from theory to clinical mastery, ensuring that innovation always serves humanity and the technology always strengthens the compassionate and patient-centered healthcare. Thank you, Jayan.
Thank you, sir. As we come to the conclusion of this inauguration ceremony, it is a time to express our heartfelt gratitude to everyone who has contributed towards making the today's CMEs a reality.
I now request Dr. Viveka sir to propose the vote of thanks.
Sabhage Namaskara. On this auspicious day of 12th August being Bhima Amavasya celebrated in many parts of India, as well as in Kerala, this day is celebrated as Karkataka Vavu. Okay, we are looking into the AI in healthcare on a strong foothold that we stand on very strong and robust Indian knowledge system. When we are talking about adopting the artificial intelligence in future clinical practice, it is important to remember one important Sanskrit saying whose gist goes like this, that it is not that something is new we should be adopting. It is not that something which is old we should be rejecting. No, those with good intellect will choose the good and bad. So with that attitude, which is reflected in our Dr. Hulinaika's principles, we decided to undertake this CME. On this occasion, we thank our chairman, sir, Dr. Hulinaikar, sir, for wholeheartedly supporting the entire event. We thank from Department of Anatomy and organizing committee, we thank our director and trustee, Dr. Raman Hulinaikar, sir, who made time in his busy schedule to attend this inaugural event and encourage us with his gracious words to undertake more such events. And also thank Dr. Lavanya ma'am for her complete wholehearted support in identifying each and every detail of the program and guiding us through the program. Similarly, we from our department, we thank our director, Dr. MS Patil sir, for wholehearted support for our program. We place it on record the complete support given by Dr. Harendra Kumar sir, our principal, who will be the backbone for our every program conducted here in the institution. We also thank Dr. Mohan Kumar sir, our medical superintendent, for gracing the occasion. We thank our group director, newly joined Dr. Nagrat sir, for joining the for this program, and our trauma and emergency department head, Dr. Ram Nair sir, to join this occasion. Thank you so much, sir. We thank our speakers who have traveled all the way from distant places. Dr. Tejasvi sir, thank you so much to accept our invitation and to come here and to, we will be delivering the next session will be by Dr. Tejasvi sir. Dr. Vasudha ma'am, who has traveled all the way from Bangalore. Thank you so much, ma'am. We thank Dr. Sudha for the session in the morning about ethical use of AI. We thank our engineering college vice principal and also director for AI and placement department head, Dr. Girish sir, for an excellent presentation. And we thank our Dr. Krishna Anand sir and Dr. Sidlingaya sir for accepting our invitation. We, from the department, we also thank our IT department people, media people who are present here, and also special thanks to our BPT students. Special thanks to our department staff, Dr. Yogesh sir, Dr. Krishna Kishore sir, and Dr. Ram Prakash, Saran, Feba, and Sai Kumar, and also special thanks to our Bhavana and Ravi Kiran and Nagratna for complete support for the program. So with this, I end my vote of thanks. Thank you very much, one and all. We'll break for tea now, and once we come back, the sessions will continue. Thank you so much.
Thank you, Vivek sir. And thank
5
you
minutes,
everyone.
quick break.
We will now pause for a brief tea break. Tea and refreshments are served left side to the door of the audience. We request everyone to kindly reassemble by everyone here.
Now it's my turn, right? I can talk like this also.
We welcome you back after the short tea session. We now move to our next session focusing on AI scientific writing from research question to thesis completion by Dr. Tejasvi HL.
To preside over this session, we warmly invite our chairpersons, Dr. Virupaksha KL, Professor and Head, Department of General Medicine, SIMS and RH, Dr. Jyoti K.C., Additional Professor, Department of Anatomy, MS Ramaya Medical College, Bengaluru, to kindly take the chair.
I now request Dr. Ram Prakash sir to introduce our speaker.
Good morning to all. It is my honor and privilege to introduce Dr. Tejasvi HL, an accomplished anatomist, medical educator, academic leader, and digital content creator with more than 15 years of teaching experiences. He currently serves as Vice Principal, Professor and Head Department of Anatomy at Adi Chunchandgiri Institute of Medical Sciences. He completed his MD in Anatomy from Mysore Medical College and Research Institute, securing third rank in RGHS. He is a former fellow and has completed his advanced course in medical education from St. John's Medical College. Since 2019, he has been serving as a coordinator of medical education unit at AIMS, contributing to CME implementation and curriculum development. He has worked with leading medical edtech platforms and is the author of competency-based questions and answers in anatomy for first year MBBS professional examination. He received the Best Teacher Award from Adi Chunchandgiri University. With these expertises, he is the ideal to take us through the today's session, that is AI for scientific writing. Please join us in warm welcoming Dr. Tejasvi HL. Thank you.
Thank you, sir. Thank you for that kind introduction. Good afternoon to all the respected dignitaries on the dais, all the delegates, and the organizing committee. At the outset, I express my sincere thanks and gratitude to the management of Sridev Institute of Medical Sciences for inviting me here for this brief talk on how to use AI responsibly in scientific writing. I bring greetings from Adi Chunchandgiri University. On behalf of the university again, sincere thanks for having me here, sir, or to the entire organizing committee. May I request the audience to take a look at this and comment on, do you find any fault in this? This was actually brought to me by one of my students, a UG student. Please see if you can find out a mistake in this. Sir? Sir? Instead of, sorry sir, abbreviated. Most of the journals actually require for abbreviated name of the journals as per Medline. That was also correct. Italicized. Agreed, sir. Agreed. Okay. Title is italicized and journal name is not italicized. Anything else that you could think of? Yes, sir. Basically, this is in Vancouver style, sir. Vancouver style of referencing, which starts with the abbreviated name of the authors, last name followed by the first name, and then it has the title of the article, then the abbreviated name of the journal as per Medline. Then it has year of publication, volume, issues, and then page number. So it is very difficult to find a fault in this, except for that abbreviation or italicizing it. Interestingly, the journal is real. The problem with this reference was there was no such paper. There was no such paper at all. If you want to check, you can actually Google it right away. This is an actual reference which was brought to me by one of my own students, saying that they had referred this and they have cited this in their research proposal. When I went and checked the reference, to my surprise, there is no such paper. So the entire reference was actually unreal. The journal name was very familiar to all the anatomists. The Anatomical Society Journal of India is very famous. But it had everything actually. It had correct formatting. The journal was well known. The research area was common. But basically the reference itself was fake or unreal. Right? Now, why I wanted to start the whole session with this slide is, as research supervisors, as guides, our undergraduate students and postgraduate students will bring lot of proposals, synopsis, then their dissertation work, PhD thesis. If we are not aware of, AI can create such beautifully cited and well formatted reference. We will be at soup. With this background, let's try and discuss for some time regarding how we can use AI responsibly in scientific writing. Usually when we like give a talk, we try to keep it very simple. First, I would like to start with why we need to be very careful and we need to be very responsible when using AI. And after that, we will briefly see how do we use AI in scientific writing. Coming to the first part, the big question, why? Let me ask you let me ask the audience, why do you think we need to be very careful or responsible while using AI, especially in scientific writing? Anyone? Plagiarism, right? So there is a big risk of plagiarism. When it is AI written, as we will see in the end of the slide, there are two things to look at. One is the similarity report which the plagiarism check software give, and the other report it generates is AI similarity report. So plagiarism is very common with AI usage, so we need to be very responsible. Anything else that comes to our mind why we need to be very careful while using AI, especially in scientific writing? False data. I think Girish sir beautifully highlighted what do we mean by real data, synthetic data, and fake data. So there is a risk of generating fake data. Can you believe if you use actual prompts, very good prompts, AI can create a fake master sheet. It can analyze the fake master sheet. It can write the entire dissertation and thesis in a span of half an hour to 1 hour. This is what it has come down to. So as research supervisors, we need to be extremely careful. So the first thing is, when the research scholar defends it in front of the examiners, of course, once they get into trouble, the blame shifts to us as research supervisor. We need to defend what we have published in the thesis or dissertation as supervisor or in the manuscript. So it is not just the research scholars who are at risk, it is also the research supervisor who are at a much higher risk if we publish without knowing the actual use of AI. The second thing is, a fabricated paper which is published can be treated as misconduct if that paper gets retracted by the journal. It can reflect negatively on the author himself, The second thing is reflects very negatively on the institution, and the accreditation and ranking agencies may look at this very severely in future, awarding negative marks for retracted articles which are published from an institution. This is how we can lose our job to AI if we are not responsible. The third thing, our name is at stake. The name gets printed on the front page, and imagine if our name gets printed on a fabricated manuscript, where we will land up. So this is why as research supervisors, we need to be extremely careful while evaluating a paper. We will see how we can do it. This is the recommendation by ICMGA, the International Council for Medical Journal Editors, which clearly mentions that AI cannot be given authorship. This is very much clear in the guidelines. It also states that the attribution with respect to citation, plagiarism check, and permission is solely the responsibility of the publishing author. Third, it also says regarding review of manuscript. Most of us as research supervisors are also reviewers for journals. We will get articles from various journals asking us to review it. Now, if we think that we can save time by uploading the paper onto the AI platforms, review it, please do not do it. Most of the Scopus Index journals warn the reviewers from uploading the manuscript directly onto the AI websites. If we upload the article of someone else for reviewing it, it will be viewed upon seriously, and again it will reflect very bad on us as the reviewer. Then transparency, ICMGA clearly states that if we have used AI, it has to be clearly mentioned where it was used, what was used, and for what purpose it was used. All this has to be mentioned clearly. As we go to the second part of this session, we will see in each step of scientific writing how we can incorporate AI responsibly, right? So this was about the why of using AI responsibly. As I said, one of the major problem with using AI is plagiarism. So when we use anti-plagiarism check softwares, it usually generates two kinds of reports, as I said. One is called similarity checking, which was done earlier before the age of AI, where it will be compared to the various resources published in the internet, and it will give that this phrase, this sentence has been copied from a particular journal or a particular source. Now, the plagiarism check softwares will also check for AI. The problem with AI check softwares is it will not give the same result if you run it twice. On the first instance, it might give you the percentage of AI used in the manuscript or in the dissertation is about 10%. You run it again, it will give 35%. We have experienced it. We have done it using Turnitin. We have tested it using Drillbit. In both top plagiarism check softwares, the AI similarity is very inconsistent. So remember this, whenever our article goes to review for journal submission, it will be run through these two checks, similarity check and AI check. So before we submit, it's always better we run a plag check as well as AI detection before we go ahead and submit it. Fine. That was about the first part. Now let me ask you this question again. Do you think we need to use AI very responsibly and ethically while publishing? If the answer to this question is no, I will stop at this stage. If the answer is yes, I'll go to the next stage. So if you want me to continue, I'll go to the next stage based on your answer. Do you agree that it is needed that we use AI responsibly? Thank you. So we will move on to the next part of the workshop, which is, the session, which is about how do we use AI in various stages of scientific writing. There might be few important headings which will be missing here. The purpose is to introduce all of us into what are the major headings in which a scientific manuscript is written, and how AI can be used responsibly in each of these headings and each of these stages. I have just phrased it as, the first thing is choosing, framing, doing, reporting, and finishing. Choosing is basically about thinking of a research topic, doing a literature review, and then finalizing the topic. Starting from this point, we can actually use AI. Then writing introduction, objective, and methods, how we can incorporate AI into it. In writing synopsis, getting ethical clearance, how AI can help. How AI can help in analysis of the findings that we have from our research. How do we report the results? How do we write the discussion? Finally, how do we write references, the abstract? And how do we actually declare at the end of writing scientific manuscript how we have used AI? Let's try to see about each of these individual steps, how we can use AI and what possible tools we can think of. First is with respect to finding a topic. With the advent of AI, one thing we had was, I still remember Girish sir saying, if we don't adapt AI, we will be left behind, someone will take over. With the introduction of AI, all of us have, let's say, a faster car. The only thing we need to do is, we need to know where we are going. We have a faster car. If we use it appropriately and know where we are going, we can utilize it to perfection, right? So how we can find a topic? Most of us, when we were starting with the use of AI, we would simply ask, suggest a thesis topic in anatomy. Most of us have done that. Most of our research scholars would do that. But what is a better way of asking by creating a better prompt? Try and check. Here are 3 problems that I have encountered in my clinical practice during my anatomy administration, or with respect to UG teaching, PG teaching. Try to give 3 or 4 common problems that you actually face or you want to research on, and then ask it to frame a research question. This is how AI can help in finding a topic which is satisfying that criteria of FINER, feasible, interesting, novel, ethical, relevant, all these criteria. So it's all about how we ask the AI. To put it in simple words, all of us, when we were postgraduates, we would struggle to talk to a statistician. We would want only one thing from our statistician. Sir, give me a significant p-value. Sir is from community medicine, and most of the research scholar would probably come to sir saying, sir, make sure that my study gives like statistical significance with a p-value. Right? We did not know how to communicate with the statisticians. When we started doing research methodology workshops, the purpose was not to make the postgraduates masters in writing statistics or methodology, but it was like to communicate with the statistician. What we get from AI depends on how we communicate with it. And that is what is all about choosing a right and a relevant prompt. I wanted to demonstrate live how we can generate prompts for each, and using the prompts, how we can actually generate what we want. But since we may not have that much time, I have set of prompts readily incorporated into the PowerPoint, which will be shared with you after presentation. Try using it. Try modifying it. You will definitely get better outputs, right? If you ask me what is the best tool that I can use for finding a research topic, I would suggest go with an AI tool called Consensus. It's an excellent tool which can help you in finding a very good research topic. Most of us limit ourselves to ChatGPT, nothing wrong in it, but there are better AI tools which can be used for each part of the research, right? In the end, we will also have a summary table for which part, which is the best tool, and the presentation will be with you, right? The second thing is regarding the literature. Once we have the research topic, how do we proceed? For example, I wanted to do a study on how many postgraduates in our medical college use AI for scientific writing and actually disclose it. This was a research topic I'm saying. Now what I want to do is, I want to find a research gap. How can we find a research gap by using AI? Instead of asking, summarize the literature on this topic, we can in fact ask the AI, I will upload around 8 papers or 10 research papers from my research area. What you do is, you try to organize it by reading it. So we can ask the AI to summarize the findings, organize the findings, and then based on the findings, find the research gap. Most of us use AI for rephrasing, but AI can be used to do lot more than simply rephrasing. So starting from finding the research topic, the second area is to find the research gap. And how do we find the research gap? Find the relevant articles on your research topic, upload it, ask AI to analyze the papers, segregate them, and then ask what are the research gaps that you can identify on which I can work as a thesis topic or a scientific writing. Done? Again, if you ask me what is the best tool, Notebook LLM is a good tool which you can use here. We can even use our Acrobat PDF, which basically summarizes findings. So we can use this, or I would even suggest try uploading your articles into Claude. The only disadvantage with Claude is it's an excellent AI tool, but the free version is very limited, right? We cannot use it extensively. So there are plans which are expensive, but Claude is a wonderful tool if you use it, but it's very expensive. The third thing is finalizing the topic. We have the research area, we found the gap, and then we need to finalize the topic. How do we do it? Based on the research gap. And how do we ask the AI to do it? Instead of asking, is my topic good? Give it a prompt where you say, think you are a reviewer who is actually seeking to reject my study. Identify the weak points. If you go like this, our work in front of the reviewer will be a lot more easier, right? So basically, what I want to highlight is, never ask the AI to argue in your favor, but ask the AI to argue against you so that you will find a better answer. Fine? This is how we can actually finalize the topic, and ChatGPT or Claude is wonderful in doing it. I consistently use ChatGPT and Claude for creating documents for my administrative work. We can use this for research as well. So as I said, it's more about asking questions in the right manner. So this is about choosing a topic. If we go further, it is about writing the introduction. As I said, if you give Claude a good prompt, it will write your dissertation within half an hour. You need to review it, we need to review it, and we need to see whether it is correct or not. Not the ethical way, not the right way, it carries too much risk. So how do we want to write introduction? Instead of asking it to write introduction, you write the introduction, then ask the AI, don't try to rewrite it, because it will be detected by the plagiarism check software. Do not try to rewrite it. Check if this follows the funnel approach, right? All of us research supervisors know that what is funnel approach, how an introduction should end. So check if it follows the funnel approach, identify every sentence that conveys information, and every claim advance without a citation. Introduction, review of literature, methods, discussion, All these should have citations, right? You can use AI to use whether you have written the introduction in the right manner, does it follows the funnel approach, and then see if anything has been uncited by mistake. It will flag and show you this is not uncited. I'm sorry, this is not cited, you cite it. This approach is good to write introduction. Again, I would suggest PaperPal is a wonderful tool which we can use. Chat GPT or Claude. But PaperPal does a wonderful job. Explore it. That is a very good tool. Consensus and PaperPal are not very frequently used. Try it. Jenny AI is one more thing that most of us use for research writing. Even that is like an excellent tool for writing thesis or dissertation. The next thing is about aim and objectives, and how do I frame a prompt for the AI. My aim should be a single sentence. There should be only one aim that is known to every one of us. My aim should be a single sentence, and my objectives should be measurable. We need to expand that. Instead, what I've given is, it should be SMART. AI is smart enough to know what do we mean by SMART. Specific, measurable, attainable, then relevant, time bound. Right? So AI knows what SMART stands for. What we can do is check if my objectives are written according to this SMART requirement. Fine. This is how we can refine the objectives that we have written to check if it goes as per the regulations. Right? This is regarding the aim and objectives. I would suggest ChatGPT and Claude for this. Both are like excellent in rephrasing. Regarding methodology, methodology is an extensive section. It is very difficult to give a single prompt to write the methodology section. But what I would suggest in simple, it's not an actual prompt for methodology section. It's just an example where I would say, read this as an investigator required to replicate my study exactly. I think Sir would agree. The main purpose of writing methodology is using a detailed methodology, someone else in the field should actually replicate it. This is one of the main reasons why we write a detailed methodology section. So ask AI, if AI was the investigator, could it reproduce the entire methodology by looking at the methodology section that I have written? If it is not reproducible, suggest corrections by which I can make it so detailed that the methodology section is foolproof. Most of our research papers get rejected because the methodology section is poorly written. When we see Scopus Index journals, Q1, Q2, Q3, Q4 journals, the studies are not that novel, but the detail with which the methodology is written makes the paper stand out, right? This is one section which can actually make or break the paper, and if we use AI judiciously, this solves a problem to a great extent. If you ask me which is that one important section where AI has to be used extensively, I would suggest it's methodology. Rest we can write, but methodology, if we tighten, our publication chances will definitely improve. I would suggest OpenEpi. I think all community medicine faculty would know this. OpenEpi is one, NMaster, GPower, SciSpace. All of these are excellent tools to find the errors in methodology. We can use it. Apart from choosing appropriate statistical tests, we can also use it to check if our methodology is robust. Once we are through with methodology, how do we write the synopsis? This actually requires a proper synopsis template from the university. For example, Sridevi Institute of Medical Sciences would require the synopsis template given by RGHS. Our college requires the research synopsis template as prescribed by Adi Chinchanagiri University. So before writing this section or before making corrections to this section, the first thing is the actual template needs to be uploaded to the AI to find what are the headings under which the proposal has to be written. And we ask the AI, check if I have written everything as per the template. If I have not written anything, flag it. So that is the question that we are asking to the AI, so that we find the missing link in the entire synopsis or protocol. Again, ChatGPT or Claude, very good language models. They are excellent in rephrasing or flagging missing things in a synopsis. We can use these two tools. Ethical committee. I'm not sure like how ethical committee functions in each college, right? In our college, ethical committee is slightly stricter on the research proposal. If we want our research proposals to get through, ask AI, act or think that you are a member of the institutional ethical committee or you are the coordinator of the institutional ethical committee. List every objection you would raise to this protocol in the sequence you would raise them. Right? So ask AI what possible objections can be raised by the ethical committee on the research proposal. If you know the objections, you can be prepared for it. Remember, it is not the research scholar who is alone using AI. It is also the ethical committee coordinator or the research committee coordinator who will also be using AI. In fact, both of them may use the same AI. So in fact, it gives you a better edge that you are already prepared for the questions which the ethical committee coordinator has listed. Unless the ethical committee coordinator is very strict, very smart, he will ask if the research scholar has uploaded the proposal into Claude, what are the possible objections it can give? If he has uploaded it into ChatGPT, what are the possible objections it can synthesize? If your ethical committee coordinator is twice smart as you, then you can go ahead with this. Half an hour bill. Right. Okay. Fine. So data and analysis. The flow of the entire presentation was made like this just to ensure what we actually ask and what we should ask. As simple as that. Right? So it depends on what we should ask. If we fine tune it, everything else will go fine. Right? So I'll go a little bit quicker with my slides. This is regarding the results. With respect to results, one thing I wanted to share is, please never ever upload a master chart into AI. You are feeding AI sensitive data related to patients especially, and never ever do it. You can be sued anytime by the institution for uploading patient's data into AI. Never ever do that. You analyze the master chart, then you upload the table and the chart, then ask it to analyze. But please never ever make a mistake of uploading a master chart onto the AI, right? Absolutely no, right? So what we can do is, once we create tables or charts, we can check if the results actually match with the objectives that we have written. If anything is missing, should I rewrite it? If I have overwritten anything that is not stated in the objective, should I remove it? This is how AI should help in rewriting the results in a better way. For graphs, there is a beautiful tool called BioRender. It creates excellent images. Claude is very good at writing, but very poor at making images. ChatGPT nowadays creates wonderful images. Canva, I would suggest, very user-friendly. So if you are a novice having difficulty in doing something, stick to Canva, stick to Excel. They will give you wonderful charts, wonderful tables, right? But if you want to use a higher tool, I would suggest BioRender is a wonderful tool to get you good quality images for your results. Discussion and conclusion. Again, try and ask if the findings that I have reported are not interpreted, what differences from other studies have not explained. So in discussion, basically we compare our study with other studies. So try and ask AI, have I left anything that is already stated in articles? Should I compare it? If I have missed it, how do I do it? Right? So ask AI what to do. Please don't ask AI to do it, because as all the speakers before me said, it will hallucinate. A simple way of explaining hallucination, with due respect to all my students, we have seen all our students hallucinating in exams. We ask something and they answer something. AI does the same thing. You ask something and it will tell you something. This in simple is hallucination. Regarding citation and references, what we can do is try and identify the sections of your manuscript where you have forgotten to cite it. Citations are often missed, right? If we use Zotero or Mendeley, there is very little chance that we will miss citation. But if you are not using it, there is a risk that we will miss citations. And please check with AI, have you missed a citation, right? And then based on the style which the university requires, most of the universities requires the references to be in Vancouver style, few in NLM, few in AMA style. So whichever style of referencing you want it to be done, ask the AI to rephrase. If you ask me, can I use AI to rephrase reference section? Use it. Because most of the journals, when they actually check for plagiarism, this section is often left out. It is excluded. They don't look for plagiarism in references. So if you want to use AI readily for rephrasing the references, use it. Use it at your will, right? The last thing, once we write everything, the title and abstract. Most of the manuscripts require the abstract to be in 250 words. Tell the AI to check if it is under 300 words. It is not a big work. We can actually do it in Word document. We can count the words if it is there. But what we can do is ensure that the introduction section should retain at least half of the length for the results. When we write abstracts, we don't usually give importance to this. We simply write introduction, methodology, results, conclusion, right? But when we write abstract, at least half of the length of the abstract should be dedicated for results. Ask AI if half of the abstract is dedicated to results. If not, write it again. The last part, I think this is the last part with respect to use of AI. When you use AI, it becomes absolutely essential that you declare it. I have used AI for this purpose. I have used ChatGPT to write the acknowledgement section. I have used Claude to rewrite the introduction section, right? When the journal takes a call on AI similarity report, you have already declared it. If the journal declares you have used AI and you have declared it and it is as per journal norms, they can go ahead with publishing your manuscript or accepting the dissertation. Unfortunately, unless the university makes a regulation on what is the accepted level of AI use in dissertation, in scientific manuscript, this would be a gray area. For journals, it is clearly defined. Unfortunately, for dissertation work, this should come from the university. This much similarity is allowed. This much percentage of AI usage is allowed. If this comes, then you declare it and you get it done with, right? So this is what I wanted to tell about how we can use AI in different steps. What I've done is I've tried to summarize everything in the table. Right at the end of this presentation, I will share this with Shivlila ma'am, and you can actually try and use it, right? And one more thing I wanted to tell us, this is what I was talking about. End of the presentation has prompts for each of the 14 steps that we defined. Starting from finding a topic, to declaring what you have used. What I've done is I have given parenthesis or brackets where you can write regarding your own study, right? Please feel free to use it. Please feel free to modify it and share it with others, right? Before I close, this is what I wanted to convey. AI can definitely compose the sentence, thesis, or your manuscript. But what it cannot do is, it cannot sign each one of this. It's us who will sign it. And if we don't use AI responsibly, we are definitely at risk of losing our jobs. It's how we use AI judiciously can make or break us. Before I close, I have used Claude to format this and fine-tune this. The whole presentation idea was mine, but I asked, or I kept asking Claude, give me this content. It took me about 12 to 14 attempts before I could fine-tune the presentations, right? Use it widely for creating your presentations for your other academic work. But when it comes to publishing your name on something, please do it judiciously. Thank you. Thank you. Thank you. If I have time, we can take questions. Okay. Ma'am has said 2 questions only. Yeah, I was just okay. Ma'am is my senior, so ma'am, please. I was little bit biased towards Claude, ma'am, because initially when these AI chatbots came, I was using ChatGPT and Gemini to start with. When both of them came, Gemini was much more superior in writing compared to ChatGPT, and later ChatGPT took over. Now ChatGPT creates wonderful images, which was earlier taken over by Nano Banana from Google. So I was little biased towards Claude because I use it extensively. So it's my experience that Claude does a wonderful job if you use it judiciously, but Google Gemini and ChatGPT are no less inferior than these AI tools. Even Gemini and Nano Banana are like very good. In fact, Claude gives us plugins where we can use Claude to do something in Canva. There is something called Higgs field. If we had a chance to do this hands-on, we could have actually done it and see how this can be done. But Gemini is equally good. Gemini is good, ChatGPT is good. These are like language models. You can depend on them blindly. But for scientific writing nowadays, most of them prefer using Jenny. Jenny AI actually writes everything sentence by sentence. So what you can, that too with citation. So you can actually keep it, or you can actually remove it. So it gives you the freedom to write one line at a time. But believe me, ma'am, like most of us are so impatient that we want everything written at one go. That is why I think Jenny is not being used very popularly. But Jenny AI is like a wonderful tool for research work. If you want to suggest one research tool for your postgraduates, I would suggest Jenny. It's an excellent tool. Thank you.
Sir?
Yes,
Sir,
ma'am.
where do we code the declaration, sir? Is it a separate paragraph in the entire paper, or in the conflicts of interest?
Usually we don't include in the conflict of interest, ma'am. Some of the journals ask us to include this in acknowledgement section, and some of the journals have a separate section where we have to use AI disclosure statement. So either it goes with acknowledgement or a separate section for it. We don't include it in conflict, ma'am.
It was very excellent presentation, sir. It was very informative and thought-provoking.
Thank you.
And which stage of scientific writing we can use this AI best, sir? Whether for the methodology, if not for all, from the beginning you said in detail, from the topic choosing till the end, but which stage, whether it discussion part or review of literature, which stage we can use this AI?
I think Jyoti ma'am asks a wonderful question. Given a chance, which is that one stage where I would use AI extensively, and my answer is methodology. If I have a proper study design, if I have a proper methodology section, the chances of my paper getting accepted in a Q1 or Q2 journal is greater. So if one section I had to completely write using AI, it has to be methodology. It has to be methodology.
What is hallucinating referencing? Or is it same like fake referencing or something?
The reference that I showed, ma'am, to be honest, we had a few PhD thesis presentation from our university in the last 2 weeks. We tried doing it. We asked Claude to write the introduction, discussion, results, conclusion based on the result section that we had got. It actually wrote. Initially what it did is, it did not give us citations. Then we asked, can you add citations? And we gave the reference number. We said a PhD thesis should have anywhere between 150 to 200 references. Why don't you try and add references? It gave us 170 references, out of which 40 were like not existing. So this is a type of hallucination. It had also missed citations in particular part of introduction, discussion, then the method section. So when we asked the same Claude tool to identify if some citation had been missed, and we also asked, please check if all the references are valid, then it came with an answer that this particular page, this sentence is not cited, and these 40 references are unreal. So this is the risk with asking AI to write citation and references. If we upload articles, let's say I upload 20 or 50 articles, then I ask Claude to cite it and reference it, it does a wonderful job. But if we ask the Claude to create citation and references, it messes it up.
So we should know where to draw a line between AI assistance and AI doing research for us.
Yes, ma'am. To put it simple way, as I said in one of the slide, never ask AI to work in your favor. Ask AI to work against you. That will give you a wonderful result.
Thank you, sir.
Thank you.
Thank you, sir. It was a nice presentation. So my question is, you told, sir, there is a master chart. Don't upload the master chart. So instead of that, you can give except patient details, rest of the can be
in fact, sir, if you ask me how I can overcome this, I got the doubt, sir. In fact, that's also a wonderful question sir came up with. What if I'm very weak at statistics, I don't have access to a statistician or an expert, and I want to analyze it quickly because I don't have time. We can code it and we can upload it. That is also possible.
Give the patient detail, rest of the thing.
Demographic details, if it is absolutely needed for the study, it has to be included, sir. But if we can use code for the patient details and analyze it, it still does a wonderful job. The only thing is, when it comes to medical ethics, one of the major principle we respect is the confidentiality and the privacy of the patient, which can be breached very easily with the use of AI without our knowledge and intention. We do not want to do it, but we think everything can be uploaded into AI. That is where we make mistake. So if confidential data, private data is not shared, we are at safe. That's what I can say, sir. Thank you.
Thank you. There's no more question. We wind up the session. Thank you.
Thank you, sir, for sharing your valuable insights.
Thank you.
I now request our chairperson to kindly present a token of...
So, ma'am, is it okay? I'm meeting into time of Vasudha, ma'am. This is the last question and I'll close, sir.
Sir, as a reviewer, how do we identify how much AI has been used?
Ma'am, I think for reviewers, we are at free or relaxation because no journal will ask us to find AI in it. It's the responsibility of the editorial committee. They will find similarity report and AI similarity.
No, sir, as a guide, if I want to see how much
of AI has been used.
As a research supervisor, you want to check it? Ma'am, upload it to Drillbrit or Turnitin, which I think most of the colleges provide. It will flag. As I said, the only risk with AI similarity is first time it may show 10%, second time it shows 30 to 35%. It's very inconsistent. Plagiarism, it is perfect. But these plaque check software, they have not yet perfected AI finding. But one more unethical way of doing it is you upload it into Claude, ask it to identify which section has been AI written. Within 10 minutes, it will show you, but not an ethical way. Thank you, ma'am. Thank you all. Thank you all for the support. Thanks for having me here, ma'am. Shivlila, ma'am. Thank you.
I request our chairperson to kindly present a token of appreciation to Dr. Tejasvi HL, sir.
I request Dr. Annapurna ma'am to now I request Dr. Anupama ma'am, additional professor of anatomy, MS Ramaya Medical College, Bangalore, to felicitate the chairpersons. Thank you, chairpersons. Now we will move on with the session 5.
The session 5 focusing on AI medical educators, transforming teaching learning by Dr. Vasudha Kulkarni.
To preside over this session, we warmly invite our chairpersons, Dr. Suma MP, Professor, Department of Anatomy, BGS MCH, Nagarur, Dr. Rupa Shri S, Professor, Department of Microbiology, SIMS and RH, Tumkur, to kindly take the chair.
I now request Dr. Yogesh sir to introduce our speaker.
Welcome, chairpersons, and I'm delighted to introduce distinguished speaker, Dr. Vasudha Kulkarni, ma'am. She is a distinguished academician, anatomist, medical educator with more than 18 years of teaching and administrative experience. She currently is the head of the Department of Anatomy at Akash Institute of Medical Sciences, and she is also the convener of Medical Education Unit at that institution. And she is an MD in Anatomy, and she is also certified in ACME, that is Advanced Course in Medical Education from St. John's, and she is a FIMA fellow. So that speaks volumes of her experience, and she also is the first rank holder in anatomy for the university exams. And she's made significant contributions in innovative teaching, competency-based medical education, simulation-based medical education, and health professions education. And she is published more than 30 research works. So with that vast knowledge, I hope we will be enriched with our knowledge with what she is going to share. So she has also served as a resource person, moderator, and invited speaker at various academic and faculty development programs. With her rich experience in medical education and innovation in medical education, she is ideally suited to take us through today's session of AI for medical educators, transforming teaching and learning and assessment. Please join me in warmly welcoming Dr. Vasudha Kulkarni, madam. Over to you, madam.
Very good afternoon to one and all. At the outset, I would thank the chief patrons, organizing team for giving me a platform to stand in front of you. and I would say I'm extremely sorry I'm coming in the way of you and the food. It's the lunch time. I'll try to do justice to keep you focused on this interesting topic, which, of course, we all know that our students are using AI right and left, and we as faculty are also using to a great extent. So let's streamline the same and use it responsibly. So I would disclose that I have used AI, I have used social platforms in preparation of these slides. Yeah. So at the end of the session, we would be focusing on what are the current applications of AI in the medical education field. How do we integrate AI tools in teaching? How to design AI-assisted assessment, particularly in the era of competency-based medical education. What are the ethical challenges, tips, and governance issues related to AI use in medical education? Yeah, this is from a social platform. Now, I believe many of us were certified for AI program by NBEMS. May I have anyone who has done it recently? Yeah? Yeah, okay. Just 3 months back, we had National Board of Medical Education in NBEMS, which had released a course of AI for the physicians, and we had a Guinness World Record also for maximum physicians who were certified, clinicians who were certified. Now, when we were using this, focus was on generative AI, and by any chance, do you know the doubling time of medical education? What's the information doubling time? Information doubling. In 1950s, the information used to change once in every 50 years. In 1960s, it used to change once in 25 years. So at the current era, what is the change doubling time for the information? 10 days? 5 years? No, it's just 73 days. 73 days, I'm specific about the medical education. But when you speak about AI, it could be as less as 6 hours. That's the information doubling time. Now, why this is so important is because we are now jumping to agentic AI from generative AI. Now, agentic AI, as Dr. Tejasvi was mentioning about Claude, Anthropic AI, so we need to upskill ourselves to jump to this agentic AI, and let's see how we can effectively use in medical education. Yeah, we keep hearing this again and again. Why AI? Will AI replace us? Will AI replace clinicians? Will AI replace educationists? Instead of saying yes, no, I would say AI will transform us from information providers to designers of educational experiences. We will definitely get transformed into designers of educational experience. So as we spearhead towards this, this is a famous model of curricular design, what is called as PICRAT model, which is a 2x2 matrix, which states that how students interact with AI. It ranges from passive, interactive to creative mode. How we faculty interact with AI, it would be in the form of replacement, amplification, and transformation. Now, why AI? Why AI? We all know that there is a lot of burden on us, especially with the CBME curriculum, with the strength of 250 students. We need to document, we need to focus on the personalized learning, continuous feedback, as well as particularly in the postgraduate teaching, the focus is on workplace-based assessment as well. So thereby, AI gives scalable solutions to predictive analytics in terms of the analysis of the data which is generated by AI, be it attendance records, be it the number of simulation sessions, be it assessment of the simulation sessions, be it the feedback decoding. So predictive analytics is through AI, adaptive e-learning pathways, particularly intelligent tutoring system, wherein the focus should be on how AI can help a student to tutor himself or herself. Also, evidence information informed educational decision making. Let's spearhead towards that. So in nutshell, how exactly AI is being helpful in medical education would be in the form of not just teaching or facilitating, even in the form of research in educational field, in healthcare, in assessment, and in learning. If we have to broadly sum up the various tools which we can use in educational field, it could be standalone LLMs like ChatGPT or Claude, to that of Notebook LM, and then embedded AI assistance, which is already available through Copilot and Microsoft and other fields. Moving ahead, we can also use multi-LLM platforms, particularly Perplexity, and then open source and developer tools like Mistral, Llama, and GitHub. Now, these are especially beneficial when you have to integrate the educational research in the medical education field with that of AI. So what are the 5, broadly if you look into the AI tools which we can use in our day-to-day routine teaching learning activities, we can consider this to be the commonest ones being ChatGPT, Claude, Copilot, and Gemini. Particularly I'm focusing on Notebook LM, which will be helpful for us for creating PDFs, texts, videos, chatbots, podcasts, which we can use. We can make our lectures more interactive by using Notebook LM. Copilot would be helpful for preparation of the presentations. There are many more which we will see. Consensus and open evidence, as Dr. Tejasvi was citing, when we are moving ahead for the research related to medical education, and Perplexity, of course, for exploratory research. Whenever you're choosing an AI tool, focus on how pedagogically it is effective. Can it produce the output? Can it produce a PPT in the required format? Can it help you in lesson planning, question creation, and research synthesis? Can it handle the vast documents and the images? Also focusing on cost and alignment with the educational objectives. Many of them are not free. We know Claude is the ChatGPT. We can go to agentic part of Claude. Now, it has specific tickets, and to generate one or refine one PPT, it would require, let's say, 3 days to 4 days in a free version. Sometimes it can go up to 10 days because the free access is very, very limited. So the same thing with many other tools. So look into the tool which is easily accessible to you for day-to-day teaching and learning activities. Sometimes, but if you want an effective presentation for a specific forum, probably you can use the paid version also. Additionally, look into the safety and privacy, particularly managing the memory and managing the data, and look for the transparency, that is for the hallucinations, and then whether the cited sources should be verified or not. Trace how the answers were generated. Now, all coming to this. So as we were discussing, so this platform is all about, just a moment. So let's have a small demonstration of how exactly can we use the Notebook LM. Yeah, this is one such platform. This is called as Brisk Teaching. This is helpful for providing the PPTs. Brisk AI, it is already incorporated into my Google. It can be used along with Google. Gmail account, it needs a Gmail account wherein you can produce the slides, you can even create a presentation. So here, considering the shortage of time, I'll not, because it is taking time, I would just say that, suppose if you have a video, YouTube video, and you want to convert that into PPT, you can just copy the link here, and then it will generate you the PPT. Let's say development of midgut. So just copy the animated video here, and it would give you the entire PPT or presentation of the midgut development. This is one tool. So focusing on Notebook. Notebook. So let's start creating one notebook. Of course, it would buffer. So we can upload the files, we can upload the websites, we can use a drive. How effectively as a teaching faculty you can use this, let's say, I would not give any prompt. I would just give you one topic, let's say ischiorectal fossa. I'm not putting any prompts right now. So there are two things which happens here. If you see the left side, it's the sources where it is searching for. Sometimes we have to, of course, yes, if yes, what are the so it giving you the prompts. Now, what is my aim is to generate an mind map. So suppose if you want to sum up the entire topic at the end of your session, it would give you a mind map in a fraction of few seconds. So this is what I'm doing right now is a faster way of using the notebook LM. But as you see, ChatGPT is making me very troublesome questions. It is generating a lot of questions for me. That's because I have not put a proper prompt. So this is very much important. Generate a mind map. Let's see. As it generates, I'll move on to the next one. There's one more important tool which is even more easier to use in our sessions, that is Anki GPT. Okay. So as it is buffering, Anki GPT is a platform wherein we can generate the flashcards. Suppose we have an interactive lecture and suddenly you want to break the monotony. You need to generate flashcards. Drag the students' attention who are using the mobiles, their smartphones. We can make them more interactive. So generate the in the studio you would usually get it. So it can also generate study guide. Okay, fine. So let me move to Anki GPT. So we'll keep browsing between the sessions because considering the buffering time over here. Sign in. Oh. Mobile code. Okay. So it's there's a disadvantage of using this because of safety issues. I've locked my mobile, so I cannot proceed further. Anki GPT would help you in generating flashcards in fraction of few seconds, wherein you can generate flashcards up to 15 very easily. So we'll come back to Anki GPT a bit later. So right now, what are the other ways of using AI effectively in medical education? So we need to consider a few tips. These are the tips which have been quoted in Medical Teacher, a famous journal related to medical education, which would say that the first and the foremost important tip for a medical educator is to use a right LLM platform. Not necessarily that for every session you need to use Claude. So you can use a simple, you can use ChatGPT also, you can use Google Gemini, depending on your learning objectives. Especially for simulated scenarios, probably Claude might make a difference, but for routine interactive, a simple lecture, ChatGPT might be of more help. Okay, fine. Now, the most important tip while using AI effectively in medical education is to, not just anywhere, would be to use appropriate prompts. So what is prompt? A set of instructions which has to be given, because we are obviously communicating with AI when we are generating any information. So use of appropriate prompts is a must. Now we have gone a step ahead. Earlier it was, there are set of prompts which are available through various journals, but now there is a platform called as Gen AI Chatbot. again, can I have your help, please? Yeah. No. Huh. So this is Gen AI chatbot prompts library for educators. Now we can see that the prompts are available for different platforms like administrative, assessment, communication, for students, for lesson planning. So whatever prompt you want, let's say for assessment, I need some prompts for assessment. So here are certain prompts which are available, which can be easily created, whether it is for the rubrics or for Bloom's taxonomy or for designing and any essay into discussion or for multiple choice tests and projects. The various prompts are already available, so you can choose them and put it into the relevant LLM platform for generating your educational tools. Further, of course, I would leave it to the domain of software engineers, who would say that prompt engineering is a vast field which was previously related to, the substrata was prompt engineering, now it has moved to loop engineering. Further moving, a prompt should always be in a Tracy framework, just like how we have objectives, specific learning objectives in the form of smart objectives. A prompt should be having 5 critical aspects. It should mention a task, a role, audience, create, and an intent. With an example, you are a clinical educator. What is this in the prompt? It is a role. Develop ideas of 5 cases you could use to teach group of learners. Develop ideas would be a task. Audience are the group of learners here. C refers to the context here, or for the creation, the cases should align with Pangro's rhyme model. And then lastly, intent, to encourage development of clinical reasoning skills. So this kind of complete prompt would help us in creating the relevant information. To put it in a simplest form, sometimes some prompts are when you have to get a response at a faster pace and for the limited source of information, these are something especially useful for faculty. For example, if you want to create scene real life examples, just put the topic and /scene, it would give you the case scenarios. Similarly, if you want to generate handwritten images on any topic, let's say thyrotoxicosis /generate handwritten image, it would give you an handwritten image. Similarly, sticky notes, visualize learning. It would give you the diagrams and visuals and concept maps related to learning in ChatGPT. For students, the most important prompt would be 80-20 exam plan, which would help the student to identify top 20% concept of that particular topic and to score 80% of the marks. So what are must-know areas a student should learn from this prompt can be easily generated from this particular tool. So these are some summary of some student prompts which can be easily used for them to learn any specific topic, with the help of AI, what we call it as intelligent tutoring system. Now further, always review the content before using. Always review the content. I know it is an exaggeration. Recently we had a physiotherapy practical examination for first year BPT students, and one of the students' topic was cubital fossa. The student started answering that the floor of the cubital fossa is formed by gluteus maximus. I doubt if AI can give you such hallucinations, because I asked the student, where did you get this information from? The student said ChatGPT. I doubt if such kind of hallucinations happen, but we could never say. We don't know what kind of prompt the student had given for the ChatGPT, whether popliteal fossa, gluteal region and cubital fossa were given in the same platform. So probably there is a hallucination over there. Now, so always review the content before using it, even in your lecture sessions or in your practical demonstration sessions. Learn basic knowledge of how LLM works, particularly if you're focusing on educational research. You can work with the custom tools, particularly for case-based generator, MCQ generator. Additionally, multimodal opportunities like Adobe Firefly, GPT Avatar are specifically useful for Simulated patients, when you want to use the LLM platforms to create simulated patients, always pay attention to the privacy and security, whether it is student or whether it is patient. Never ever share their personal information on an LLM platform. Always there are some local deployment platforms like Llama and Mistral, which would maintain security in a better way. So if institution has access to them, kindly use them. Always collaborate with tech experts when generating educational related research framework. So for research framework, FACET format is something which is helpful, particularly for medical education related research. Now focusing on how exactly AI helps in assessment. We know from Miller's pyramid, can AI help us in all this? Of course, yes. For nose, like for example, if you want to have a best response MCQs, flashcards or question papers, GPT would help. Clinical reasoning, short answer questions, DDX by Sketchy is very helpful. For visual simulations, OSCE and procedural tracking, it could be virtual patient simulators. Workplace analytics, like for example, if you want to create mini CX forums, if you want to create multi-source feedback forms, you can utilize the Microsoft Copilot. Further, these are some must-know tools for medical educators, for question designing, for rubric marking, for OSCE and clinical assessment, for documentation and content enhancement, for oral feedback support, and academic integrity and analytics. Additionally, AI is also helpful for summarization tasks, for predictive tasks, for medical board and other examinations, for assessing clinical reasoning. These are some data which is already available. There are 12,723 MCQ questions which are available in this data set of MedQI, which can be accessed through AI. Google MedGemini and Google Bards are helpful for that. Now, can we assess empathy? Can we assess communication skills? Can we assess non-verbal communication through AI? Yes, of course, yes. Through README, we can do it. This is something which is our immediate requirement. Many a times we are, let's say for formative assessment, I need to create a question paper. This is a prompt which, if I would be able to put it, so this is a prompt related to, I need to upload the syllabus. So a good prompt will definitely make a difference, and it's a matter of few seconds wherein as the prompt is given properly, we would be getting a generated question paper. So what is our task when we have a question paper with us? Validate it, look for hallucinations, verify every word of a question paper. So it has given me in the specified format as per RGHS template. Only thing is that please verify every question which is generated through AI diligently and responsibly. So it has made our job easier, but more responsible as well. So this was about how exactly the question can be generated. So moving further, because I'm shuffling between the surfs, probably there is a lot of technical glitch. I'm extremely sorry for that. Close my door. So we are almost at the verge of last few slides. Yeah. Right. Okay. Okay. Previously, in the earlier sessions, we were discussing about this retrieval augmented generation. Now, this is a platform which reduces the hallucinations. Pertaining to our field, it is said that it has a case, let's say we have a case library of 413 cases to that of 2,525 hospital records from a specific data set. How exactly RAG would help us is to create case scenarios without hallucinations. Similarly, Articulate Medical Intelligence Explorer is one such platform which helps in generating the history-taking, diagnostic accuracy, management reasoning, communication skills, and empathy. Additionally, I just wanted to bring your notice to a blog which I had read today. Now, what is the role of AI in being a virtual simulator? Here's a case which was wherein a 15-year-old woman gains 9 kgs in 20 days, starts shouting in her sleep, develops mouth ulcers, keeps crashing into hypoglycemia after meals despite normal HbA1c. The real-world case resolved well. CPAP for newly severe obstructive sleep apnea with then a cleanup of an overloaded diabetes regimen. Good outcome, good medicine. But what a simulated virtual patient did was to explore. There was a weight gain of 9 kgs in just a span of 20 days. This could pick up because of the use of drug interaction between pioglitazone and insulin, which would cause rapid sodium and water retention. Now, this was picked up by the virtual simulator, but not in a real scenario. Similarly, focusing on HbA1c, normal values for an age for a patient of 50 to 60 years with rigorous treatment of diabetic regime alarms over usage of the drug. The rigorous correction of the glucose levels. So these two salient features were highlighted by the simulator and not by in a real scenario. Now, our students need to be picking up that particular aspect of reasoning, wherein we need to spearhead ourselves to train our students as well. Now, with this, what is the main concern in the use of AI? It could be either never skilling, misskilled, or de-skilled. So, a classical example of never skilling is, let's say, the attachments of pretracheal fascia to the aspect of thyroid cartilage to that of cricoid cartilage would be elaborated in the standard textbooks, but usually we tend to ask students the question, why thyroid gland moves up with deglutition? Suppose if the student has a ready-made answer through ChatGPT, the student never makes an attempt to learn the correlation between what is the attachment of pretracheal fascia and why there is movement up with deglutition. So that clinical reasoning would have never happened because there is a ready-made answer available every time. So that is never skilling. Misskilled. That happens particularly when ChatGPT hallucinates or any LLM model hallucinates and that is not supervised by the faculty. De-skilling can also happen. Someone who was good at clinical reasoning in the first year gets excited during third year, and de-skilling can happen. Because every time they would directly go to the LLM model for their clinical reasoning and they would forget their basic skills of reasoning. So these are the main concerns with us with the use of AI. So thereby, we need to use AI responsibly, focus on ethics, set expectations for the AI use, disclose faculty AI assistance like student also, maintain authorship integrity, protect always sensitive information, never ever disclose the student data like that of patient data, follow data regulations, use institutionally approved tools preferably. Recently I have applied for this Stanford clinical med reasoning tool which can be used for a duration of 4 weeks wherein we can generate the clinical scenarios particularly which are already configured and which is already implemented with the help of RAG. So this will help our clinicians to focus on creating MCQ pool with the scenario-based questions. So critical thinking, verify every word of AI-generated content, maintain academic integrity, and edit unsafe or inaccurate information. So of course, we know this. There is something else also which is happening, halo effect. Sometimes what happens is that when you give repeated prompts, you feel that the fifth prompt is definitely correct answer. This happens with our students also. When we keep asking the questions, if 4 students are scored in the range of 2 for the same question, when the 5th student comes and answers one sentence above that, that becomes an halo effect. We tend to score more, so focus on this kind of prompting. So if ChatGPT makes it easy to cheat on an assignment, teachers should throw out the assignment rather than ban the chatbot. Another writer has also said, are we just grading the robots? So what is important is verifying whether the assignment was correct or not, because the student is able to answer it with the help of ChatGPT. In nutshell, I would be, if you find time, please read these 3 interesting books related to AI, how exactly responsibly we can use AI, and how can we effectively collaborate with AI for upskilling ourselves. In nutshell, to summarize, always have a responsible use of AI, optimize it, use AI as a supplement, promote feedback, provide training. These are the 3 summary slides for today's session, which is generated by AI, and an infographic. These are the references, and my sincere thanks to all of you for your patient listening. Thank you so much. Thank you.
Thank you, ma'am. That was a wonderful session and enlightening session. We got to know about various AI platforms which can be used by teachers in medical education. Since we are talking a lot about AI hallucinations from morning, from a student perspective, how do you think we can train our students to critically evaluate the AI information?
I would say we can start using AI as a form of SDL sessions, self-directed learning sessions. That's a best platform where we can use AI tool. So you supervise every information. So let's say we give a proper prompt to the students, ask the students to explore a particular topic with the help of that proper prompt, which is initially you generated, supervise it, and then check whether the information which is provided by it is correct or not. So SDL sessions are the best way of deciding whether the AI is effectively used by students or not. And sometimes we can even upload the textbook, ask the students to upload the standard textbooks, generate summary out of that. That would definitely reduce the hallucinations. That's one more way of doing it.
Thank you, ma'am. And one more question, since you're also MEU coordinator, what is the role of an MEU in incorporating this AI in medical education?
Yeah, we need to conduct faculty development programs wherein, of course, this should go to an MC wherein BCME should have one component of how exactly AI can be used by medical educators in teaching and learning and assessment. One is that particular way. And informally, I think all of us are doing it.
Should we have a policy like what?
Already the policies are in place. I can share you the websites and the policies. AMEE, American Medical Education Association. There are 3 standard guides which are already released. Guide number 83, 159 and 169, which are about regulations and policies related to use of AI in medical education specifically. The policies are in place, and even WHO has released AI education policies for medical education specifically. Probably I can share in the group those specific guides. Yeah.
Thank you, ma'am, for sharing your valuable insights.
I request the chairperson to come and give a token of appreciation to Dr. Sudha Kulkarni, ma'am.
I now request Dr. Rekha Gurumurthy ma'am, Vice Principal Academics, SIMS and RH, to felicitate chairpersons.
Thank you, ma'am. Now we will break for lunch. As it is already we are lagging one session. So we request all the delegates, please come back by 15 minutes. Thank you.
Xiaomi Music speaker. Bluetooth mode. Connected.
We are going to start with the sixth session.
We now move on to the session 6, focusing on Build Your Own AI Clinical Agent by Dr. Siddhalingaya SH Sir. HS Sir.
To preside over this session, we warmly invite our chairpersons, Dr. Anupama M, Associate Professor, Department of Community Medicine, Siddhganga Medical College and Research Institute, Tumkur. Dr. Manju MD, Professor and Head, Department of Respiratory Medicine, SIMS and RH. To kindly take the chair.
I call upon Mr. Saran Sir to introduce our speaker.
It is my pleasure to introduce Dr. Siddhalingaya HS Sir, Professor, Department of Community Medicine, Sridevi Institute of Medical Science and Research Hospital, Tumkur. He is a public health physician, researcher and medical educator with more than 15 years of experience in teaching, research and public health. He completed his MD in Community Medicine from PGME at Chandigarh, and he served as a surveillance medical officer with WHO India. His areas of interest include epidemiology and disease surveillance, immunization and antimicrobial resistance, AI in medical education. He has more than 20 publications with recent works focusing on the intersection of public health, medical education and AI. He developed FAP Next Generation, a website-based solution for the family adoption program under the NMC's CME framework. This innovation reached the top 3 in the AI of All India Open Data and AI Readiness Challenge and won the 3rd prize at the AI India Summit 2026 in New Delhi. He has also conceptualized India Patient Safety Surveillance System, a digital framework for the patient safety reporting and prevention. With his hands-on experience in developing AI solution for the healthcare and medical education, he is ideally suited to lead today's session, Build Your Own Clinical AI Agent. Please join me in warmly welcoming Dr. Siddhalingaya HS Sir.
So thank you very much. So first and foremost, I thank the organizers for giving this opportunity. So this is a very interesting topic. Also thank the panelists. So actually this is a very interesting topic, and since morning you have heard so many speakers telling about the importance of AI, the potential of AI, and how we should be not missing this opportunity. I mean, other countries are actually racing ahead. So I also think that we should use more and more, integrate this with our daily life as well as our work. So this agentic engineering, as the previous speaker told, all the problems that are associated with AI, like hallucination, inaccuracy, all these things can be addressed. They are innovating. Every day you are getting something or the other new innovation. Agentic engineering or agentic AI is one such solution, which enhances the accuracy, also ensures that there is robustness in our work, and people are actually there building agents in their companies, replacing them. They're acting like a worker, basically. A company with no workers, only agents, they're coming up. So that is the potential of this. In addition, agents used as swarms, or many agents working together, are loop engineering, loop agentic engineering, and even graph agentic engineering are the latest things that are coming up. So that is, moving towards frontier or kind of advanced super intelligence kind of thing is going to come up. So let us understand what are these agents and how we can, with a no coding language, coding background basically, how we can use our English language as the coding language and use to build anything and everything. Okay, so people say English is the best coding language in the world. You don't need to know anything, no Python, no nothing. So if you know proper English, if you know how to use it, so that is the best coding language that currently we are living with. So what are these agents? Basically, and I can say with confidence that everyone with some curiosity and with some basic tools can be a builder, can use these agentic workflows to bring in accuracy, productivity, efficiency in your work. So I'll show you some examples. I'll start with some examples. I just built these agents and hosted them on a website called Streamlit app. So it takes 5 to 10 minutes. If you give a prompt, these are prototypes basically. We need to work a lot more to make them as final products, usable products, and commercial products. You know, so these are prototypes. Just to tell you the potential, how these clinical agents can be used in our day-to-day workflows. See this guidebot capability is, it answers only from the loaded guidelines. As previous speakers told, LLMs are there. They've trained those LLMs based on the entire internet's data. Internet's data has so much fake data, false data, accuracy is doubtful. So if you ask a LLM with some general query, it will give you a response. We don't know whether it's correct or not. But with agentic AI, agents will limit all the, whatever guidelines you give, it will remember, it will create a vector database out of it, and it will answer from those guidelines. So that is the beauty of this agentic. If you build agents and deploy them in your institutions or in your personal this thing, it will definitely help you with accurate results and accurate, your work will be better. So this guidebot, I'm just giving some examples. What is the treatment regimen for sensitive TB? I'll ask the chatbot, this agent, it will give me the guidelines retrieved from national latest guidelines. Also, like if you give WHO guidelines, it will exactly refer to that and give the details. And if you want to make an agent for preparing discharge summary, like discharge summary draft, you just have to write these, input these details, day 1, day 2, day 3, day 4, what happened, and it is going to prepare a, including ICD coding. It will give you the ICD coding, diagnosis, course in the hospital, everything. So the way you want to build it, you can build it. So it will reduce so much of efforts, so much of, it will save resources basically. And it will give a lot of time for human beings to, pursue other aspects. So most of the time is going towards doing unnecessary tasks, which are not useful, which are wasteful. So human actual experience of living a human life is it is not possible for many because they're involved with all these struggles. So AI will change that. If we use it properly, we'll have a lot of time, sufficient time for many useful pursuits. So another agent is clinical, this triage assist. So 45-year-old man, these are some, how to triage. He has got some problem, chest pain since 2 hours, sweating. So what is the triage and what is the risk score, where should you go? This can be built, fine-tuned in a particular hospital. Even screen mate. For example, let us say you are doing inclusion-exclusion criteria you have added, and you are giving some abstracts, 4 to 5 abstracts from PubMed, and you want to screen all the abstracts. So as previous speakers were telling, some commercial applications. If you know the agentic workflows, you don't need any software. You don't need to buy any software ever in your life. You can build anything and everything with agentic workflows. Okay, even agents are creating new LLMs. The advancement in AI field is done not by humans. People working in Anthropic or, they are 80-90% of the work is done by AIs. Okay, they're just watching whether it is giving the accurate results or not. And now they're just going on holidays and agents will be working 24/7. So that is how the advancement is happening. And the problem is the guardrails are there so that it is not going to overtake, like it's overbuilds itself and it's gains superpowers and all. Similarly, pharma guard, you can build in any field, medical field, even other fields also, you can build anything and everything. Here see prescription of medications and patient's condition. Let us say there is some contraindication which is not, a clinician is ignoring it, is not able to capture that. But this agent will tell you. So these are the parameters, like whether there is any contraindication, whether we are prescribing any medication which is not supposed to be prescribed. So those things, those alerts, you can have on your, if you are sitting in a OPD, if you have this agent on your mobile or anywhere, just give the basic, I have prescribed these medications, this is the background of the patient, is it correct? So even if there is some remote possibility of some adverse reaction, it will tell you. So similarly, lab alert. We can create lab alert values which are extremely abnormal. See, I'm just adding some information here. You can change it. It will give different result. Like it will analyze, because this agent has a particular, I'll tell you the anatomy of an agent, how it works, what it is. Similarly, there are numerous. I'll build one ECG live and I'll show you how it works. Trial matching, like for example, in a trial, we have patients coming, okay, there is some bug that's not coming up properly. So differential diagnosis check. Okay, so you give the patient details. So what are the possible differential diagnoses? You can build, it is not built by somebody else. You build it your own. So you can build it. Okay, there is no need to, with just plain English language, that's all. What you know is English language and what tools to use. Okay, so don't have to refer to any software or anything like that. So radiology vision, here, see multimodal, you can make these agents here, see, it will scan the documents, hundreds of PDF pages, it will create a database, so you can add any capability to that. You can make these agents use any tools, calculators, so many like glomerular filtration rate, or risk scores, so you can build all these things into your agent. And it will refer to those specific parameters that you have given. It will not go to the internet and see some fake data and give you the wrong. So that hallucination will be made almost to zero. So that is how the agents are actually taking over. And pathology scan, example in pathology. You give the details, the description of the histological details and all, or you upload your slide. So it will give you the accurate, accuracy also we need to check, but probably it's better than normal LLM. So wound tracking, just show the photo of a wound. So what is the stage of, like ulcers, wounds and all, it will grade and tell you like what to be done. Always there is a clinician loop there. There is a human loop. So all these agents, definitely there should be a guardrail. It should be verified by the human. And chart vision and fundus vision, otoscope, even for the ENT. So for anything and everything, we can have this any number of agents and build them easily and utilize them. So this agentic thing is so huge that now it's a $450 billion industry. If you really want to do some commercial application and become an entrepreneur, you can become. There is a huge opportunity here. Okay, there are a lot of solutions. There are a lot of problems which can be solved. Okay, but you should identify those problems and act on it. If not for others, at least for your own sake, you can build these agents, utilize them effectively. 73% of the clinicians are overloaded with what is called as decision fatigue. They are getting so much information and they can't even decide what is correct, what is wrong. In such scenarios, it will definitely help. Nearly 5% faster triage. These are the experiments done, studies conducted and reported. So in early AI triage experiments have shown that it is more efficient as well as faster. And 68% of the adverse drug reactions sometimes which happens during handing over, taking over, like shift changes and all. So those things can be cut down. So basic LLM, if you ask a chat GPT, it will give you some answer which is not relevant. Maybe information is 10 years back, old information, which it is trained on everything. So there are billions of parameters, weights and biases. So it will give you some output, we don't know the accuracy. But agentic, if you are building your own, so you are giving all the latest documents, particular documents, I want everything to be from a PDF of a Davidson textbook or Harrison textbook. It will refer to only to that. Okay, so that is the beauty of these agents. And it has the ability to plan, use tools, verify the facts, and you can even verify it, whether it's correct or not. Once the output is there, verify it, review it, then give the human prompt, like human will verify whether it's correct or not. And finally, act. Act portion is like robots. Like probably the robotic engineering is also taking a lot of this thing. So agents will, combined with robots, is going to be the future, basically. So most of the tasks, including Optimus robot, is being built. So surgeries and many manual tasks in most of the industries, hazardous tasks, everything can be done with a lot of precision, accuracy with using these robots, of course with these agents. So if you see the evolution of this software and all, earlier 20, 30 years back only like some Word tool, Excel tool, if you know how to use it, it will give you the output. How to do the calculations, what to do, how to add, subtract or use those functions. So that is fixed software. Then predictive AI show a number, whether computer is able to pick up and identify that 4 as 4, 5 as 5, with what probability. That was around 15 years back. Generative AI, maybe since 2015, 2020 onwards it has taken, since GPT. Copilot, a little better than that. It interacts basically with it's like assistant. And many of the laptops had this. Agentic engineering is the current, it can be autonomous. One of the most, highly autonomous, can be with accuracy. It all depends on how you build it. Okay. So now, the agents have all this, this is the, we can say like sort of anatomy or the X-ray. You give instructions, so they work with a particular goal. You are building an agent with a particular goal. It will always try to achieve that goal. And how? With a particular knowledge base, which is predefined, very, very well-defined knowledge base, what you are giving to it, specifying to it. Tools also are specified. And memory, it has memory basically. So LLM may not remember if you ask the second prompt, third prompt. So what you asked previously, it may not remember. But these agents will have everything in memory. It is almost like a human working. So that is another advantage. So there is a memory file that is stored locally, and it will refer to that. It acts as a sort of short-term memory. And even how human brain functions, similar to that, these have a capability to function. So there are workflows, one after the other. If there is some error at one particular point, and there is like what to be done, it will not proceed, basically. If there is something, it will not hallucinate, it will not imagine. If there is no data, for input data, age is not there. It will not imagine the age of a patient and give the output. Okay, so it will stop there itself. So it knows what is right, what is wrong. So those kind of things are inbuilt in this. Safety features are inbuilt. You can build them. There are something called guardrails, where you can define the boundaries. You should not do this. Your boundary is only up to this. So don't hack other system. Don't see other files. So whatever, or don't see older informations. So those kind of guardrails can be set in, and these are being set by even if you want to do some advanced research, whatever frontier models that are released, they won't do. They will refuse because of this guardrail. Not that they are not capable. They are capable. But that is released only to certain set of only select group of people. So guardrails are there. Interfaces, like there is definitely an interface where humans interact. It will show you for approval. So that is also important. That is the part of this agentic workflow. And everything is auditable. What steps, what decisions were taken, everything is written. You can see and check if anything has gone wrong. So that audit capability is also there. How the work was executed, everything remains in the audit. So these agents, so this is like you want to build an agent, you should have an aim basically. What problem you are trying to solve. So that should be specific. So before building agent, you should prepare a plan, a draft. I want to build an agent with these things. So that basic blueprint you should have. So that is a human ingenuity. Okay, then that is followed by ground, on what ground it should act, and what information database, information set it should act. Equipment, what all tools necessary for this particular agent, for decision making, for making a judgment. How to navigate, what workflows are built, like one step after the other, how it should move, how the things are integrated. And testing, and finally deployment. And if it requires approval, software as a device, it requires CDCSO approval and licensing. So all those things come in a governance. So this is how agents normally are built and used. Like let us understand what is this ground. So even engineering, Dr. Girish was telling about RAG, retrieval augmented generation. So this is what makes, this makes the agent current, live. It's not like a 10-year, 15-year information it's going to give you. So this RAG system is like you are giving some data, and that is going to create a database, vector database from that, those sources. And it will not deviate from that source. Everything that is given to you will be referenced or will be taken from those particular documents. Okay, so that is this RAG. So this RAG is what is advancing. They're trying to build better and better data systems, and it should be current, immediate. If there is a data requirement for some decision making while the agent is running, if you need information, it should be able to retrieve from correct sources. So that live retrieval also is important. So that RAG pipeline is a set of instructions which gives the ability to get the correct and relevant information from appropriate sources. Okay, so the clinical question you give, like TB regimen for a 52-year-old adult, 52 kg adult, then the search, you have an approved corpus of information or database, and this retrieve agent, whatever is the pipeline is there, that will search for all the tables, like what is the weight of the patient, what is the age band, those things will be searched, and finally that information is given to LLM. LLM is the brain. So LLM will think and tell. It is going to reason. That reasoning ability for this agent comes from LLM. So there is a need for AI. AI definitely will be in the loop, but you need to connect this agent with some LLM, maybe OpenAI's, Anthropic's, whatever it is. So that is required. Then it will give you the final output. Okay, answer with citation. So this is the agent speciality, ability to work with RAGs. And second is tools, equipments. So you can build whatever appropriate tool is required for agent. You can build that in, build in this emergency health, what is this? Electronic health records, EHR. And FHIR, FHIR is a sort of convention for data, transfer, especially health data between government's database or private hospitals database. BP stored in a particular column as a variable. That is, there are conventions what name should be given. So that is that FHIR, FHIR. So that that's a tool basically. Those tools help the agent to communicate with whatever databases that are available, already established, okay, according to conventions. Calculators like GFR, BMI, creatinine clearance, even Wells risk score for DVT, curve, whatever scale is there, you give it, it's going to create that scale, and always, whenever there is a need to generate score with a particular context, it will generate, and it will classify. And knowledge base, the standard established guidelines and information. Then workflow actions. So this is how, these like even, there are tools. Tools are nothing but, they are just some scripts, Python scripts, and they help the agent to execute, to communicate. So that is a tool part. And guardrails are the safety parameters that we define. So everything is told in plain English. That get converted into code and stored as some files. I'll show you how, how it is stored in one of the repositories. I'll show you that. It's like permission policy, input validation. Like there is no data with respect to some parameter. What should be done? Should you fabricate that data and use it further, or should you wait or ask for the, get the response from the user, then proceed? So those kind of guardrails. Output part. When there is an output, verify that, then give it to the user. Okay, clinician for verification. So human in the loop, audit trail, and incident response. So all these are part of these safeguards that are used in the process of agent building. So if you are building agent, you need to address all these things. You need to then it becomes a good agent. Maybe commercially useful. It will do the actual work for you. It can replace, not replace, of course it will make the person's work easier. Okay, so it will increase the efficiency of organizations, and aim. This aim is what is the actual question that the problem we are trying to solve. If this is wrong, then there is no need for relevance for that agent will be not so good. So identify which is a burning problem which needs to be solved, which is utilizing a lot of resources, creating a lot of burden, and try to address that with the help of agents. So, for example, certain problems like deterioration in a ICU, it will see the vital parameters and it will generate some alerts. If it makes error, it is critical. So we need to be extra careful while building such agents. Now, for like building a discharge summary or some documentation, it's a low risk. It can be easily built. So depending on the complexity and importance of the work, the aim that we are selecting, agent should be rigorous. So we can build this is an example like 55-year-old male newly diagnosed pulmonary TB, 52 kg, no comorbidities. What regimen monitoring should be and monitoring should be considered for this patient. So agent will actually, these are the goals for the agent basically. Retrieve appropriate approved TB guidelines, identify missing clinical information, use weight band, and cite the evidence source, and require clinician confirmation before action. So if you want to achieve this goal with just a LLM without agent, it will give you an answer which is not reliable, not verifiable. Okay, another second iteration is, second variety of making it is, add a RAG. Even then it is not complete. It is going to give you an output. Maybe it is correct, but beyond that it has no capabilities. So you need to add some more layers to it. Add tools like guideline search, get patient record, calculate, and search for drug interaction. So this is another layer added to the agent. It becomes an agent orchestrator. Maybe several agents working together. Different parts are done, works are done by different agents. So that kind of orchestration happens. Then final approval. Human approval is always required for any health-related whatever you build. There should be human approval. Without that, I think it's very dangerous. So agent flags the issue, prepares the proposal, gives it for human review, then approve. Either he will correct it or make it, ask it to correct, or he'll approve it. Then it will act. It will give you the output, a prescription, whatever it is. Diagnosis, prescription, differential diagnosis, whatever output, whatever aim that was intended, it will be given. So this is how, there will be some instructions here, and these are the observe, decide, retrieve. This is the workflow basically, how it works. Approve, verify, audit. And after that, once you build it, you need to test from the basics, whether tool calls are working, whether RAG accuracy is there, RAG retrieval, information retrieval that you are getting, whether that is actually accurate or not. How much is the latency? You give the prompt, how much time it is taking. So all these things need to be addressed. And safety scenarios. Whenever you are testing an agent, give the critical things, like in case of a pregnancy. If something goes wrong, some prescription goes wrong, it will be, so that's why always critical error rate matters more than average accuracy. It may be 95% accurate, but if it is making errors at the critical situations, it is dangerous. So always testing should be done on such scenarios which are critical. If it crosses this criticality test, then it's good. Then end-to-end tests, the next step is end-to-end test, then user testing, then real world test. So this is how the actual thing goes. And governance part, at each and every layer of building, we need to, clinical part, data part, for everything there are guidelines. We need to adhere to those guidelines, ensure that those aspects are met. It can be done. For example, software also, if somebody hacks a software, what are the securities that should be built in? And governance, is it compliant with the DPDP Act of the government or some data protection acts? How to ensure that nobody can hack? What are the secure policies? How the data is protected? Those things should be predefined. So it can fail also. Agents can fail if there is no human responsibility layer, or if the knowledge is not updated. Guidelines are you're building agent for today. Tomorrow guidelines might change. You need to update. A new version should be provided. Then alert fatigue can be there. If you set the low threshold for the agent, it keeps on giving alerts. So what is the critical level at which it should alert us? So those things, and permission, like write access without human approval. If it gets to do the final work, that's also dangerous. So these things should be ensured to make it safe and effective. So like for example, let us build a agent. Before that, I'll show you some examples, real published examples. Sepsis alert. There was a RCT. It showed like 20% reduction in ICU mortality with that particular agent monitoring vitals and lab continuously. The parameters are continuously monitored and gives the alert to the persons. So this reduces so much human error and all. If the agent is accurate, if it is doing a proper job. And chest X-ray triage. There are hundreds of X-rays coming in, and this will just see and flag it for the radiologist. So this is having these issues. So this will increase the turnaround time by 40%. AI flags the abnormal findings for radiologist review. It is not the final, but it is going to help you. And if any things are missed by the human oversight, so it will definitely help. So discharge summary preparation, it can be done accurately. Medication safety, yes, it will give you this thing. Follow-up coordinator also giving, like identifying persons who require follow-up and probably calling them or sending them messages. And clinical trial watching. So even in clinical trials, agents are used to screen the patients. Like you want to match a particular case with a control. So it will help you to do all that. So ethics, equity, see basically AI should be available and used for everybody. It should be accessible, affordable, available to everyone. That's a bigger goal. Does the agent perform equally well across ages, sex, ethnicity, and language groups? That's another question. That's a part of the training. Sometimes there will be biases. So it will give different answers to different these things. Explainability, data privacy, regulatory class, for example, this software as a medical device, compliance, continuous safety, and informed consent. So these are some of the aspects we should be looking into, and build something that makes clinicians' hardest days little better. So that is the bottom line. I think it's a potential area, and we should not think that it is not possible for us. I think some countries are, even common persons are using it in a big way. So India infrastructure also has to develop. So I showed you this thing. So first, most useful thing is to just have a agentic, like this is a anti-gravity. There can be a VS Code or any number of IDs, integrated development environments. Here you just have to use the plain English language and agentic workflow. You can use frontier models. They'll give you the best and highest intelligence. So I have built a implementation plan for a ECG agent. You need to build a plan. This is called implementation plan. So this is how agent should be built. Then this plan is going to be executed. I'll say continue. Now it will build in minutes and it will deploy. How? It will build, all the coding will be done, and it will push it to GitHub repository. This account is connected to GitHub repository, where GitHub is the most developers use it for storing and versioning their software. So this is how it looks. You can have your own account here. Okay, connect it. Everything is automated. I don't have to manually upload the files here. So this clinical AI agent, it's available for everybody. If you want to, I'll give you the links. If you want to develop it further, you can build on other person's work. It's free source code. So you want to build on with just plain English. I want to add on more capabilities, you can add on. And deploy it. Where to deploy? Deployment requires its commercial little bit, but easier. There are free versions. The personalized AI agents can be deployed on Vercel, Streamlit. It can be easily deployed, and that is also automated. See, simple click here. I say generate this. It is writing a lot of codes, app pi is being written. Okay. And this is also agentic. Agent is writing it. And agent is going to verify that the code works. There are no errors. And then it will push the code to the GitHub. And it will automatically appear in the Streamlit. I showed you this Streamlit. This is the front end. Ultimate final product you see here. I have 14 agents now. 15th will appear in few minutes. Okay. So this is how anyone can be a developer, or you can build your own agents and you can develop them. These are prototypes, as I told. They are not final products, but it's possible to build. And so this is, it is just a matter of curiosity. See, the problem is if you have correct intentions and curiosity, that's all the requirement for this. Okay, so there is no, and proper you should have proper knowledge base in your area. Physics, maths, whatever, how much you know, it's fine. But your whatever subject area, you know, like what is correct or what is wrong. That kind of judgment should be there, because it requires human inputs and guidance, basically. So this repository anyone can use, and I'll show you how these tools are there. There is a folder here, tools. So this tool for check the cost calculator. It is just a code, some 100 lines of code, that's all. And that is just logic. These codes are nothing but logically arranged arguments, that's all. Okay. And this app is asking me some permissions. I have to review actually, then it will get published. So prototype is built, it is going to go into the GitHub and it gets live. So I hope, I think due to lack of time, so we can't, it can be done as a hands-on workshop, basically. So there is a huge potential and we should not miss this opportunity. China is racing ahead. Even young children school, they are teaching, and all the even maths problems are being solved. There is no limit actually. There is no hindrance for anybody. Only thing is we should be open to it and explore that. So thank you very much.
Thank you, Siddhalingaya sir, for your excellent address.
I request our chairperson to kindly present a token of appreciation to Dr. Siddhalingaya sir.
Now I request Dr. Kulgeri sir, Professor of Biochemistry, SIMS and RH, to felicitate the chairpersons. Thank you, chairpersons. Now we move on to our 7th session.
We will now begin session 7, AI as a personalized tutor for medical students, by Ms. Pranjal Soni, ma'am.
To preside over this session, we warmly invite our chairpersons, Dr. S. Aarti, Professor and Head Department of Physiology, SIMS and RH, Dr. Archana B., Professor, Department of Anatomy, Siddhganga Medical College and Research Institute, Tumkur, to kindly take the chair.
Good afternoon, respected dignitaries, respected faculties, and all the esteemed guests who have arrived today. My name is Pranjal Soni, and I'm a final year MBBS student at SIMS and RH. I consider it as my privilege to talk about AI as a personalized tutor, and would like to thank Dr. Shivleela ma'am, Head of Department Anatomy, and Dr. Vivek sir for providing me with this opportunity. Artificial intelligence, the AI. As we speak of AI, what comes in my mind is the quote of Stephen Hawking. He rightly said that success in creating AI would be the biggest event in the human history. And congratulations to all of us that along with the COVID, we are the one who witnessed this AI bloom also. Ever since the existence of life on this planet, there existed teachers and students. The journey of medical education has seen many changes and evolved over the time, from ashrams and gurukuls in ancient India, where wisdom was passed by the wise, to the documentation of knowledge in the medieval century, to the structured textbooks and curriculums in the late 20th century, and finally to the age of AI, we have traveled a long way. And I won't be wrong if I say that we are in the golden era of the AI, where anyone, anywhere, and at any time can learn. Only what is needed is the will to learn. And as a student, or rather I would say as Gen Z students, I used to consider myself that who would know AI better than me, or who would know AI better than Gen Zs. But I was wrong, because it was when my teachers reflected and highlighted that the way we were using AI was not correct. To use AI to its full potentials, there is certain ways which needs to be followed, and that is what my teachers have taught me. Like, to treat a disease, we should know the cause of the disease. Similarly, to use the AI effectively, or rather more mindfully, first we should know what are the problems we students face. So the problems faced by us as students are large syllabus. The first day of my medical college, I remember when I was taught that there is, when I got to know that there are subjects like anatomy, biochemistry, and physiology. I did some research and I got to know that there is some book called as Gray's Anatomy, and I was too fascinated that I will go to college and I will read Gray's Anatomy. But I was disheartened the moment I opened the Gray's. Okay, few initial 1-2 weeks were okay, but when exams came, I got to know that either I can read the book one time, like either I can pass the exam or I can read the book. The book is wonderfully written, no doubt, but it is too huge to retain, to revise. Only one reading was possible. So the next problem was, no time was there. Second revision was not there. There was lack of poor revisions. There were difficult diagrams. We had viva anxieties. There were too many books, like single from Gray's Anatomy, we shifted to BD Chaurasia. Then at one point, even BD Chaurasia was too huge to cover, so we shifted to Vishram Singh. And then finally, we were on the last book that was solved, Singhi Yatiraj. And the next problem is whatever we learn, integrating it with the clinical knowledge, that was our problems. So how AI helped us as students in all these problems. Then came into the picture the AI cycle. AI, what it did was, it helped me understand the topic. It shortened my topic, like by visuals. It summarized my topic. And after all readings, to retain it more, it helped me to practice the topic by self-test, by quizzes, by flashcards. So it made my revision more. Like, I was able, instead of reading it one time, I was able to read it twice or thrice. As Vasudha ma'am have already told about a lot of AI tools, here are some of the AI tools which we use. The most common which everyone uses is ChatGPT. After ChatGPT is the Gemini, which is my personal favorite. Till 2 years back, I was also familiar only with ChatGPT, that you ask ChatGPT anything and it will answers. But I recently got to know that I was using ChatGPT in a very wrong way. I was asking ChatGPT to give me an answer, but I was supposed to ask ChatGPT to teach me. Next is Notebook LM, the best app. I will say that it is a boon to students' life, is the invention of Notebook LM. ChatGPT, what's the problem which I faced was with ChatGPT was when I used to ask ChatGPT for answers, it used to give answers, but it used to give answers which were available on the web. And when I used to, in Viva, during Vivas, when I used to present those answers, my teachers used to know that I have asked Google or ChatGPT about the question. Notebook LM solves all of my problem. I'm able to upload my standardized textbook. I'm able to upload Vishram Singh. I'm able to upload Gray's Anatomy, and even I can upload Harrison's. Like, it's the dream of every medical student to read Harrison's for medicines. But practically we know it's not possible with 11 subjects in final year to read Harrison's. So we will ultimately come to the shortest book we will get. But Notebook LM have solved that problem. I can upload the PDF of Harrison's, and it is a chat board. So when I upload the PDF of Harrison's and I ask questions, like for example, if I ask acute MI, so it will give me answers from Harrison's itself. It will not surf the net. It will give the answers from the sources I have uploaded. I have demonstration also after this that how it helped me. Gemini Live. If I am too lazy that I don't want to even upload, I don't even want to type, Gemini Live is the best thing. I just need to have one phone with working camera, and if I show the text image to it, like through the camera, it will answer everything. Gemini Live also I have demonstration. After this, I would like to show demonstration of all. Now, okay, I have learned the concept, like everything is in my mind, but my mind is very volatile. I need frequent revisions, and revisions should be interesting. It should not bore me. Like, if like revising through the books, the problem is that when I surf through the pages, it will feel like I've already read it, like I knew it. But so that is not an effective revisions. So for that, I needed quiz or flashcards. Anki, this is the same thing which Vasudha ma'am also told. Vasudha ma'am told about Anki GPT. It is actually, I have used Anki Droid. It also creates the flashcards, and for the prompts you can use Gemini only. Like in Notebook, I have uploaded my textbook. I have uploaded Harrison's or I have uploaded Vishram Singh's. I can ask Gemini only now to create a prompt or create a code for creating flashcards for my Anki Droid app. Anki Droid app, I have brought some images, like I have uploaded Vishram Singh, and I asked Gemini only that to create flashcard codes for Anki Droid. It created, and then my flashcards were there. So it gives me an option that I can ask the question, and the question will be asked, and then I can see the answer. If I knew the answer, I can say, okay, it was easy. I can give it a rating of easy. If I didn't knew the answer in first go, I can grade the levels of difficulty, like it was good, it was hard, or it was, I need to read it again. After this, after these flashcards, this Anki Droid app also gives me the feedback. It gives me the statistics, that how did I perform, which questions I marked as easy, which questions I marked as tough, which needs to be revisited again. After that, in final year, till third year, it was more of a textbook learning. In final year and in some of the third year subjects like ENT, Ophthal, we need a lot of clinical exposure, because there is clinical cases we need to present we need to take history from the patients and all. So that also requires another level of practice. For that, Neural Consult, I found it as a very nice app. It gives me patient stimulations. The patients are virtual, but I can talk like one-on-one with them, and it's like artificial, it's AI, but it will talk as if I'm talking to a real patient. So it really helps with my Viva and all. Now I would like to give you the demonstrations of my Notebook LM, how I use it, and the Neural Consult. And first, I used to give only the prompt as what is brachial plexus. So no doubt ChatGPT used to tell me that what is brachial plexus. It was sufficient to write my answers for my paper. But then I realized that it won't stay with me until and unless I understand the concept behind the brachial plexus. It won't stay long in my mind. So then I got to know that my prompt was wrong, and I learned the art of giving proper prompt. So then I started giving prompts like, I'm a final year medical student, or I'm a first year medical student. I want to study brachial plexus. Teach me as an anatomy professor. When I gave this prompt, literally taught me like a teacher. It used mnemonics. It make mind maps that how the trunks are formed, how the roots are formed, how the divisions will be there, which was initially lacking in the previous prompt. It also gave me the Viva questions. Next, this notebook LM. This is the best thing which I have discovered. I will literally say it's a boon to students' life. For example, I uploaded Vishram Singh Anatomy of Head and Neck. It's already been uploaded. I can ask like Chat GPT. One feature is similar to Chat GPT, like asking questions. Like I wanted to discuss about the sensory and cutaneous branches of the radial nerve. So it gave me answers like Chat GPT. Now I am not in the mood to read this. So I can go to the studio features and I can ask it to create a short video. Like for carpal tunnel, I have created a short video. I was not in the mood to read all those things. It was very boring. So I created this short video about carpal tunnel syndrome.
Your wrist is an extreme anatomical bottleneck where everything operating your hand squeezes through one tiny gap. Imagine a patient whose thumb, index, and middle fingers go completely numb after typing. Inside, carpal bones form a hard U-shaped valley. This valley is capped by a thick fibrous band, locking it into a rigid, unyielding tunnel. Packed inside are 9 tough cords that violently slide back and forth to operate your fingers. They share this space with one soft wire carrying feeling back from the hand.
For creating this video, I didn't do any coding or anything. I just opened my notebook LM. And in notebook LM, after uploading the notebook, like create new notebook, so it will give me options that you want to upload your sources in form of what. Like you can upload it in the form of PDF, audio, images, websites, even YouTube videos can be uploaded, or from Google Drives. After uploading, it will hardly take 5-10 minutes. My source will be uploaded. See, my source is Vishram Singh textbook. Then I can chat with my source. It will give all the answers from Vishram Singh's only. Unlike Chat GPT, which gives answers from the web, like from the different sources available on the web, my notebook will give me answers only exclusively from Vishram Singh. Now, if the text is too boring to read, I can go to studio and create different things like audio overview, video overview. For this also, I don't need to give any prompt or any code. I just need to open and I just need to describe that what exactly I want. Like I want carpal tunnel syndrome with applied anatomy. So it will create carpal tunnel syndrome with applied anatomy. Similarly, I can create infographics also. I can create flashcards and quizzes also. I've created one mind map which is very helpful. I was never able to learn the radial nerve. With the mind map, my radial nerve learning has become very easy. It have given me like if I want to know what is the origin and root value, so if I just click it and it will tell me everything. And it does not take any coding or more time. It's just one thing, that is notebook LM. Similarly, infographics is also there, visualized infographics of rotator cuff. So everything can be created only with just one app. And if I'm too lazy to even upload this, like I don't want to upload a PDF, I don't want to download a PDF and upload the PDF, there is one more thing which Google gives me, that is Gemini. This is Gemini, and in this I don't even need to type. I just need to on its live feature, like Gemini Live is on. I need to on the camera, and I need to open my textbook and just show it. I just need to give command, hello Gemini, I am a final year student and I'm having difficulty in reading this diagram. Can you simplify for me and explain me? I think some network issue, but this features also works very well. It is tried and trusted features. So it is like a boon for us students, that if we are too lazy to even upload a PDF, we can just use the Gemini Live feature, and it can also be used for quizzes. Like there was an online quiz though it is unethical to use it for a quiz, but I used it for a quiz and I got instant answers. In ChatGPT I have to type. In Gemini I don't have to even type. I just need to show and within seconds it will give me answers. It's if used ethically and reasonably, it will be very helpful for us. But so its mindful use is very necessary. At the end, I would conclude my talk by saying that we need to relearn how to learn so that we are not left behind by those who use AI. Thank you. Thank you all. Have a good day.
Yes, it was a nice, insightful talk. We have come to know how the students are using the AI. As a student, I want to ask you only one thing. Where you feel that the AI cannot take up the role of the teacher?
Ma'am, to use something, first we should learn how to use it. So we were using AI, but we didn't knew how to use it correctly, like how to use it effectively. And that effectiveness was taught by our teachers, that how to use it correctly.
Are you talking about using AI correctly or the content also?
The content also, because the knowledge is vast, ma'am. If we see Harrison's or Gray's Anatomy, everything is not to be studied in UG. Like if we sit and study everything, then we won't be able to pass exams or have that basic knowledge of the top. So it's our teachers who tells us that what is important to be studied.
All your teachers have studied Harrison and are here for that reason without AI. Isn't it?
Ma'am.
See, the constant reminder was the students are lazy to even upload a PDF or something like that. So how lazy can you get even afterwards? Like, when your patient comes, so I am lazy, you will explain that using AI?
Ma'am,
no, one thing, you generated a video, the terminology is used there. Something, it said chords. That is not the terminology which is expected of you as a medical student. So how what we call it as hallucinations in AI, you are not, you don't have that technical knowledge to know whether those terminologies are correct or not. So how will you go about correcting that? Can you have that time? You go back every time it is like teacher says it's wrong, then you come back again, revise your prompt and again study?
No, ma'am. That's where our teachers are necessary. That's where AI cannot replace our teachers, only it can augment our learning. It can act as a catalyst in our learning.
So in your experience, which do you think is the best for you to use AI? Your day-to-day thing or for some quick revision, something like that?
Ma'am, I would say for competitive exams, the AI is best. Like the quizzes it gives, the flashcards, and for revisions. Not for learning the concept. Learning concept, I think, in person, teachers and other faculties and videos, they teach more elaborately in comparison to AI. But for revision, AI is a very good source.
Yeah, I think platform is open for discussion. To concise a large topic is definitely, I think AI would be helpful. But then you should have prior knowledge instead of choosing AI to learn it for the first time.
Yes, ma'am.
How simplified the Gemini live would make.
If somebody is studying, like some students are there, they will lose their interest and lose their concentration in the class, and they are not able to even study that simplified diagram also. Then if somebody once teaches you, then it becomes easy. So to get that edge.
Okay.
Thank you, madam, for your comprehensive presentation.
I think one day you need AI to have that human interaction also. I think the day is not far, isn't it?
Yes, ma'am.
You're not ready to come talk to us. You are talking to AI, so. No, good. Thank you. Well presented.
I request our chairperson to kindly present a token of appreciation to ma'am.
I now request Dr. Ravish PM, Professor, Community Medicine, SIMS and RH. To felicitate the chairpersons. No, sir. Thank you, chairpersons. Now we move on to the last session, that is
We now begin the eighth session, which focus on handling uncertainty. We now begin our eighth session, focusing on handling uncertainty in AI intelligence for medical diagnosis by Dr. Krishnanand sir.
to preside over this session. We warmly invite our chairpersons, Dr. Pallavi Harsur, Professor and HOD Department of Pediatrics, SIMS and RH Tumkur, Dr. Ravish, Professor Department of Community Medicine, SIMS and RH Tumkur, to kindly take the chair.
I call upon Mr. Saran sir to introduce our speaker.
It is my pleasure to introduce Dr. Krishna Anand sir, Professor at Sridevi Institute of Engineering and Technology, Tumkuru. With nearly 3 decades of experience in computer science, artificial intelligence, research and engineering educations, he holds a PhD in Information and Communication from Anna University, along with the ME in Applied Electronics and BE in Computer Science and Engineering. His expertise include AI, machine learning, NLP, neural networks, and evolutionary computing. He was authored a book on artificial intelligence and has extensive research experience in AI application in healthcare, including cancer detection, diabetics, coronary artery disease, and diabetic retinopathy. He also an expertised resource person and trainer in AI and machine learning. With his extensive expertise in AI and healthcare applications, he brings a valuable technological perspective to today's program. Please join me in warmly welcoming Dr. S. Krishnananda sir.
We request Dr. Kulgeri sir, Professor of Biochemistry, to please chair the session.
Good evening to one and all. I know this is the afternoon session. Of course, I shall try to make it as interesting as possible. So, first time Dr. Vivek came to me 1 month back. So I just asked what list of topics people were taking, so that I don't want to repeat something which somebody talked about. Many of the sessions were something about clinical or either generative AI, LLM, and so on. So I wanted to take a different topic. I'll talk more about uncertainty in AI, where none of them have talked so far. And one other reason I'm not so much supporting this LLM, your Gen AI concept and so on. Reason is what has happened is people who have used these technologies last 3-4 years, technology has brought beautiful results. People have told how much beautiful results, wonderful, how fast you can do. But one thing they didn't tell is they made you stop using their brains. The students these days, they don't use their brains. They simply use ChatGPT. They simply those things, project beautiful results without knowing what is what. So that is one thing I observed. So it will tell some results. I'm not bothered whether it is correct or wrong. It will tell. ChatGPT has told. I asked one student, you have got some 25 out of 40. Tell me how much you have got out of 100. Please, we will enter. Immediately went to ChatGPT. I got 25 out of 40. How much did I get out of 100? Asked the ChatGPT. And they made one typing mistake. Instead of 25, they typed 250. I got 137 out of 100. How is it possible? No, ChatGPT is telling 137 out of 100. First thing, you should use your brain to know what can be an answer. Then ChatGPT as an assistant tool. It should not act as your brain. Whether it is ChatGPT, agentic AI, LLM, whatever it is, you should have a rough idea what should be the fact. Rough idea. You say, if it is 87 into 9, it should be in the 700, 800 range. You should have an idea. It cannot be 8 lakhs. So some rough idea and then use the tool, which people don't use these days. I'm very worried in 2-3 years' time, maybe people who are junior to Sonal and so on, if I ask the name of your father, you will refer ChatGPT and tell. It is not, day is not far away. Right? So I don't want to go into that. I will take a topic pertaining to what is uncertainty. This is an issue which initially I used it in boiler applications during my PhD days way back in 2009, 2010 and so on. Later introduced it into medical field. In 2014, COPD was the major problem where we designed some type 2 fuzzy models and so on. So people don't give an importance to uncertainty. This uncertainty is something which is happening everywhere. What is uncertain? Uncertain is some measurement. You are saying here we are, all your results are based on data. Whether the data is correct or wrong, you assume data is correct. Plenty of assumptions. And you yourself know data is wrong. I saw in the boiler field where operator has to measure, when fuel you have to pour. Due to laziness, he doesn't pour. Some value is entered. Some random value, and that is used as your data. That can create severe problems. In medical domain, it is very high, especially with doctors or even with people. Continuously you have to report data. Every half an hour you have to measure the blood pressure is given to you. One time you are tired. You cannot say, I am tired, I didn't refer. I will give some random value, fill it. Who will check? So problem what is happening is your data is used for analysis, validation, and even producing beautiful reports and results. And most of the patients, they are all laymen. And even some of the doctors may be laymen in other fields. If it tells the result, I will trust. So that is one reason we need the human expertise at all times. So here, what we are doing is, we will impute some values. We will impute some we will impute some values. Suppose some values are missing. We should try to fill or identify the best possible value. What could be the possible value? So we have different ways in which we can handle uncertainty. So when we hear, this is basically where you can apply AI. Okay. So since this is a medical college, we have taken a medical aspects. So now what you are doing, your AI models you are building, you are giving some very good prediction, but there is no confidence. So you may tell me, okay, fine, you predict it and check with a doctor. Yes, you can do that. If the doctor is going to answer, what is the use of your prediction? You are going to predict. Whatever you predict, the doctor is going to cross-check and give the correct results. So either there is no use of prediction, or you can directly go to a doctor. So this is one major problem. So how confident is this diagnosis? You are telling some particular value. Yes, you have breast cancer to a possible 93% accuracy, you're predicting. How do you know it is correct? So we need to do some validation. And why mistakes occur? Most of them, they occur because of uncertainty. What is uncertainty? There are so many things you do not know. Medical knowledge is very vast. There are so many things the medical field, the doctors may not have learnt. Maybe tomorrow it may be a new subject. Even AI models have plenty of uncertainty. There are so many AI things which you cannot do. Tomorrow you will find out something. So too much of uncertainty is there. So what do? Fill some value. Whatever possible value that you want, they will try to fill. And mention that this is going to be meaningful for physician users and so on. Right? So I've just given a definition here. Uncertainty basically is lack of confidence in an AI model's prediction. So your AI model is predicting that you have pneumonia. That pneumonia with 95, I will not say 100%, 95% certain. Why 95% certain? There are still 5% things which you don't know about pneumonia. There are maybe some characteristics which you don't know. Some things AI may not be able to find. And some wrongly put values because of the laziness of the operator in filling a value. Instead of 75, you fill 758. Somebody has to correct, right? So because of all these things, so you're going to have, so your sources will be limited information, noisy data. We use the word, in electronic terms, they use the word noisy. Data is not perfect. Having some impurities. You have to measure 24 times, you measured 23 times. One time was imputed. It's a noisy data. One error will be there. And your model will have some limitations. I can do only certain things. And unknown clinical scenarios. There may be some situations in the clinical which you may not have considered, you may not be knowing also. So because of all these things, we have some uncertainties. So in healthcare, the problem what will happen, because of uncertainties, of course, patients will be harmed. And doctors, you'll get some confidence estimates, not perfect estimates. You'll have some clinical decisions and support in your expert review. So by doing that, of course, with help of doctor, you can improve your patient safety, increase trust, and better treatment planning. Okay. I'm now concentrating on two common types of uncertainties which arise. Technically, we call it as aleatoric uncertainty. That is because of noisy or incomplete data. Whatever data that you have should be 100% perfect. You may claim it to be perfect, it is not perfect. Even for example, you take a patient records. I don't know about Sridevi, but few years back, I was surprised to hear when you went at some doctor, they don't have some data. The patient wants injection. The doctor tells, no, I will not put injection, you don't need. Patient feels, I'll be cured only with injection. So what does the doctor do? Doctor gives an injection without any medicine, empty syringe. Patient says it is wonderful. So one more aspect is involved. What is the mind of the patient? The mind of the patient is something apart from whatever problems you are treating. If the patient feels, however good you treat, I am going to suffer. That mind also plays a role. So there's a separate area, which we will not discuss today, called cognitive computing. The mind of the patient can also add to some of the cure. The patient feels an injection will cure me, whether it needed or not. When you put an injection, the patient gets better. So cognitive, some other, that is what your normal clinical will not give you, those things are going to add across. So aleatoric uncertainty is mainly from noisy or incomplete data. So this you cannot eliminate. When you have lakhs and lakhs of patient records, mistakes will come. Then examples, poor quality X-rays, motion blur in MRI, incomplete. Some of them, of course, you can rectify. Second is epistemic uncertainty. You have a limited knowledge of the model. You have a model. You know some things. Like somebody talked about Gray's Anatomy. I've studied. She would have studied Gray's Anatomy. She would have studied only 70-75%. 25% she doesn't know about it. Or 5% you may not know. There is some knowledge which is not known to you. That is limited knowledge of the model. Because of that, there is some uncertainty. That we call it as epistemic uncertainty. So two major uncertainties we need to deal with. So for that we create multiple models, and which is the model which will have more accuracy? It is a mathematical model. So in AI we have introduced different kinds of models, Bayesian model, Markov model. So like that we have introduced many models. So we will come back to that models little later. I've just shown some sources of uncertainty, limited training data sets, missing clinical information, rare diseases. Disease is rare, you may not have knowledge. Sensor errors, you are measuring the blood pressure, but the equipment is having a mistake. It will show you a wrong reading. Annotation mistakes, data imbalance, and different protocols followed in hospitals. So training model. So from training, we define an AI model, prediction plus uncertainty. So you are going to combine both. Okay, so these are some of the models which will handle uncertainty. The main one, which is commonly done for a long time, is the Bayesian model. It basically deals with probability estimates. With probabilities and all, you try to calculate. Suppose you want to plan an event, whether it will rain, you don't know. So with probabilities, you try to predict. Then Monte Carlo. So basically for generating different random numbers, they use. And this is the major one which is going to provide the difference. Ensemble method. I want you detect whether there is pneumonia. I am designing an AI model. It is telling there is pneumonia. You have one more AI model. You have 3 AI models. All the 3 AI models are telling you have pneumonia. Then there is a high chance your model can be correct. 2 models are telling you have pneumonia. 1 model is telling you don't have pneumonia. That means there is some problem. Where is the problem? Major problem with uncertainty. 1 model is telling different. So you need not check with anything else. You construct multiple different models. No, you design one AI model. Keep it with you. 1 model. You design. Each of you I am asking you to predict. All of you give me the same answer. I need not cross-check. And 100% of the time it likes. And ensemble methods are the one we are using for critical cases. Critical things. Wherever it is critical, you want to take a decision, you do 1 model. I'll ask somebody totally unrelated to you, some other model. I will use a fuzzy logic model. You may use a neural model. You use a different, excellent. genetic algorithms they are going to design well and good. All of you give the same answer. No cross check is needed. So ensemble method is the one which is going to create a difference and handle uncertainty better. And calibration normally we will do in the medical measurements and so on. So this is just a formula. We are not going to go in detail. So Bayesian model is mainly based on probabilities. So you will try to basically identify what is the probability that this disease is going to be true. So based on factor. So we will not going to the matter. This is basically the formula for Bayesian probabilistic order prediction. But the problem with Bayes is that it only deals with probabilities. It will give you a probable, so that means what is the probability that this disease is present? Well and good, fine. If it will not give you an accurate yes or no, it will tell you the likelihood. For such cases, Bayes will do well. Then we have other measures based on entropy. Entropy will mainly deal with deviation. So you cannot get 100% accuracy. How much are you satisfied with? You are satisfied with 95? Okay, fine. I'll give you a maximum measurement of say +5 or -5. Within that, if your range comes, we will deal with. Again, it is not for perfect accuracy. These are cases where you want to do some prediction with some 95 or 98% accuracy. We go for such measures, entropy-based measures. This, as I told, is the ensemble method, deep ensemble. I've just given one example. I want to have 3 AI models. Your AI model is telling there is pneumonia. Your AI model B is telling pneumonia. Model C is telling there is no pneumonia. That means my conclusion is I am not going to base the result on this. I'll say that now we need to do some other cross check, or we have to identify the uncertainty and impute the values. So this is the ensemble method. If all the 3 models told there is pneumonia, then we can safely conclude that the solution is true. You may ask why we are talking about this is, we want to do this without a cross-check of the doctor. Because if you cross-check with the doctor, ultimately what they say, what is the use of prediction? I will directly go to the doctor. So we want to make our prediction such a way that if a doctor tells, either the doctor is wrong or the doctor should agree with your answer. So you have this is the last 3-4 years people are going for deep learning, where they are doing deep ensemble, where the 3 models will not have a relation with each other. Like one can be a genetic algorithm model, which maybe the professor is going to talk about after some time. One may be a neural network based model. One can be a complete fuzzy logic model, and so on. So models disagree means uncertainty is high. So this ensemble method is the one which is going to. So like that I've just given some sample prediction what AI will give you. Oh, it predicts pneumonia with this confidence. So what do you say? If confidence level is low, radiologist should review the message. If confidence is 100%, no further cross-check may be needed. So like that I've just given some, just showing some samples. So what type of uncertainty can be there? So either for cancer diagnosis, so because of I possibly talked about time, so we'll just go through some samples. So like that, rare disease diagnosis. Why rare diseases? You will not have much experience. The problem with rare diseases is doctors may not have that much amount of experience. So these are the main challenges that we are having whenever you are doing either clinical treatment or AI or combination of both. Lack of diverse data sets. Because when you want to treat patients, for example, you want to treat lung cancer patients, you're bringing all the patients from Tumkur or Bangalore. Patients are not from different regions. Some are tribal patients. Some are aristocratic. Some are from Germany. If you have a diverse set of data, your analysis, 2-3 minutes. So with diverse set of data, your accuracies will be better. Otherwise, they'll be concentrated on a specific aspect. And AI models are black box. You don't know what is the model, how you are designing. Just like your ChatGPT is the best example. You don't know how it works, what is happening inside. From where it is producing result, don't know. I'm showing some result, you simply trust. A black box model. Data set bias, as I told, you may prefer some specific data sets because of availability. And fourth major is ethical concerns. Like I told, you can start predicting, and if you try to replace a doctor, there will be other issues. So doctors will not be happy. They have worked hard and they have earned something for their profession. There is something which only doctors can do, which your model may not be able to do. Ethical concerns, privacy issues. So some aspects you don't want to share. Patient would not like their data to be transferred to all places. They want to keep it within closed doors. Regulatory approval, government should approve. All the things you should do. You can build a very good AI model, it is doing everything. If the government doesn't approve, it will not go ahead. And clinically, it should be validated. Whatever you said, yes, perfectly fine. In the clinic you check, it should match. So these are all the main challenges and limitations. Since only half an hour was provided, I made it short and crisp. So my major conclusion here is, we are talking about aspects of uncertainty. This uncertainty is in every domain. Medical is not an exception. Uncertainty comes because too many mistakes are cropped in when you have plenty of data. Some data you will not record. When you don't record, you fill randomly some data or keep it blank. So when you keep it blank, what happens? For example, the doctor is critically treating some patient. He is asking nurse, at 3:30, what was the blood pressure of the patient? If that nurse did not measure, nobody measured, what will happen? You cannot give the data, or you will give some wrong data. So if you don't get the data, how best to get closest possible data that we can get using our methods. So I think with this I will stop. I hope it was somewhat informative. At least even if it helped 3 or 4 of you, well and good, fine. I now leave it to panelists.
Thank you, sir, for an exceptionally informative presentation.
Thank you, sir. Congratulations, sir. Yes, Krishna Anand, for your excellent presentation. You made your presentation very interesting with giving some very interesting experiences. So this, what I understand by your presentation is that there is a lot of uncertainty in using AI. So what you would suggest, whether AI should be used or not?
No. What I said is, there is plenty of uncertainty in there is uncertainty in measurements, uncertainty in data. With these uncertainties, we are using AI, we reduce the uncertainties and try to fill with best possible values. We have some methods. Imputing a value. Even if the nurse did not measure the blood pressure at that time. So I will try to predict what is the best possible value that should be there rather than filling any value. That is what our AI methods will do. It will reduce the uncertainty.
Thank you. Thank you.
Me open for discussion. Overall, with these uncertainties, such blindly we should not go with any available AI models. So first it has to be validated. That is what the message is. Thank you, sir.
Data used in AI models may have uncertainties. One AI model is, that's why we have ensemble model, different models.
Because digitally still illiterate. Our country is digitally illiterate. The percentage is more digitally. Just because of an AI model is there, blindly is not, it should not be followed.
No, if you follow, I'm not sure the answer is correct or wrong. You should not simply trust the answer. That is what is my.
Okay, sir. Thank you very much, sir.
Thank you.
I request our chairperson to present a token of appreciation to Dr. Krishna Anand, sir.
I now request Dr. Lakshmi D. Ma'am to felicitate chairpersons, Professor of Biochemistry, Siddhganga Medical College. Thank you, chairpersons.
We move on to our last session on bio-inspired AI medicine. Should I say so?
Very good evening, everybody. Welcome to the last session before the panel discussion. Immediately after this, there will be a panel discussion.
To preside over this session, we warmly invite our chairpersons, Dr. Ashwini S. Dodmani, Associate Professor, Department ENT, SIMS and RH, Dr. Manjunath GV, Department of Pathology, SIMS and RH.
Good evening, all the delegates. Good evening, all the delegates and respected chairpersons. My session is on bio-inspired AI in medicine. How exactly this evolutionary algorithms and neural networks has influenced the development of AI. I'll be talking on this before the panel discussion really kicks into this final CME on this particular thing. Now, the next big revolution in AI is not something about building how robust the large language model will be. It is about making AI more like a human brain. It should think like human brain. Okay, that is the more important challenging one. Now, so imagine a small child walking around here. Suppose if at all you want to teach something to her, this child, it is quite simple, right? You just go and tell something. Suppose if they are receptive, then it takes split second to learn. Every one of us are learning every single day without knowing, especially from Instagram. We take less than 5 seconds or 10 seconds to learn. If at all the image, the knowledge or the information is conveyed in a proper way, it takes less than a split second to learn. However, for AI, for that to make it to learn, we need to feed it with a huge number of data. Okay, so the example what I have quoted here is, if at all you show a zebra to a child and say that this is the zebra, even if you show a next zebra which is a little smaller in size or a baby zebra, like it will still identify as a zebra, but that is not possible with AI. So what is actually making the difference is the one what I'm going to talk about now. Now what happened with the evolution of the AI? Now algorithms are also thinking in terms of human brain. Okay, it is almost acquiring intelligence the way we are acquiring knowledge. The human brain, having so many billions of neurons with trillions of connections, works with just 20 watts of energy. Okay, that is not possible with the current models of AI right now. So for an AI model to build, that the difficulty would have been understood by those who have tried to install Ulama in their personal laptops. It doesn't work at all. If at all you want to, you can have your own model in your own laptop and make it to run, but you simply say hi to it. By the time it will say hi back to you, it will take 5-10 minutes within your laptop. So for that we have interfaces, better interfaces like ChatGPT or Gemini and all those things, which works on internet and takes your hi to the agent sitting somewhere else in the corner of the world, and it will immediately respond back to you in a split second. So that is not possible for a local LM deployed in your machine. Just not simply like human brain. Now what actually happens within our human brain, this is the model of the neuron here. The neuron collects impulses from all over the different centers of the brain and try to synthesize something and try to execute. The similar thing happens with the AI model. It will take inputs from different sources and assign weights. This was the one which was missing all throughout in the evolution of the information technology. The weight allocation was the one which was missing. And once it allocates appropriate weight to each of the inputs, then it will summarize and provide a calculated output. So this is what happens, and if at all you pictorially represent, they both look alike. They both look alike. So this is what led to a concept of bio-inspired AI, biologically inspired AI. Because time and again, what has been proven is the biology design is the supreme. And anything which imitates, anything which looks similar, anything which works similar is supposed to be successful. So that's the overall point here. Now, how exactly the brain works? It has got neurons and neural networks. AI also, the entire model will have deep learning, transforming, and finally it will come up with agentic AI. The principles used for AI, which is imitating our learning, is hierarchical processing, distributed representations, attention, then predictive coding, then homeostasis, then plasticity. Now, hierarchical processing is, as and when you are looking at this picture, your brain is taking each component and trying to match with the already existing memory. Now, once that matching happens, then you are processing the entire input in a hierarchy way. So you are going to get that impulse as you are going to get the final image input as, this is a dark lit background. There is white letters on it. All those things your brain is processing. Similarly, AI also takes up some different impulses from different sources and try to layer it, like early layers, middle layers, and deep layers, and finally process it and finally come up with an output. This is hierarchical processing. And attention, like just the way you are concentrating on one particular object, like the person who is serving your coffee, you are concentrating only on him, right? In spite of other distractions. Similarly, AI also tries to concentrate only on one particular input, which is going to make a difference in the final output. So this is the attention, the one which is imitated from our human brain processing. Now, with predictive coding, your brain keeps on always predicting. like the first prediction, your brain is working right now, is it's already 4 o'clock when the session ends, you're predicting, right? Similarly, AI also will obviously predict the very next word, what it has to say. So there is almost a similar overlap in the entire processing technology, what is being employed. And the other one is distributed representations, wherein neurons will not just get one impulse from one particular source. For example, you are having tea, eating biscuit, then concentrating on my talk in a dim lit auditorium right now. So lot of information right now currently processing. So similarly, AI models will also take impulses from different models, as rightly pointed out by Dr. Girish sir, in his multi-model AI used for clinical practice. Now that will take inputs from clinical notes, from laboratory reports, from the images, from the pathology, from the previous records, and all those things, and finally come up with some patient summary or predictive diagnosis, differential diagnosis, all those things. Now the most important one is the plasticity. We are having a capability to relearn. First thing, unlearn, then relearn. Similarly, GPT has shown a mirror to us that it can relearn, unlearn. Now, suppose if it makes a mistake, and if you tell that, okay, you have made a mistake, it will immediately correct and say, okay, I made a mistake, I am learning. So this is the plasticity which we need to be very careful about. And finally, the homeostasis, wherein brain will come up with a balanced, stable, robust output always. But that robustness is not yet completely proven with the AI models, because at times you are chatting with something and immediately change the topic and ask a different question, and it is still, it is stuck with the previous topic, and it will throw you the answers for the previous topic. All those things are possible. So the evolution of AI algorithms also followed the same pathways as doctrinated by Charles Darwin, wherein the survival of the fittest will eventually matter. Like we need to wait and watch and see which one will survive. ChatGPT, Anthropic models, Gemini, Grok, or other things, or our Swarnam. It is also in competition, right? So it has to survive the competition. And one more important thing, what the AI is trying to get inputs from the nature is the swarm intelligence, wherein the group of ants searching for the food, or bees building their hive, or birds having the coordinated movements, or fish moving in harmony, it all has a shared intelligence. So if at all we can come up with some kind of swarm intelligence as demonstrated by these organisms in nature, which is already there in nature for many millions of years, then it will be more successful. And finally, why bio-inspired AI is, bio-inspired AI will have fewer shots, it is more adaptive, it is more continual, and it may lead to robust AI models. So the current medical education tools are still largely rely on general purpose models, which are not on the biologically grounded systems. So what is important is the AI with the biologically grounded the models, having human oversight will give us the better medical outputs. So with this, I will conclude my talk saying the artificial intelligence began by imitating the brain. The future of medicine may depend on how closely we continue to learn from the already existing learning process, what we are following right now. Thank you very much.
Thank you, sir, for your comprehensive presentation.
I request our chairperson to present a token of appreciation to Dr. Vivek sir.
No discussions? No, maybe at least we should appreciate him. He has given a very good presentation.
Thank you, sir.
But I would like to, it's an interesting topic. So I remember when I was doing MBBS days, there was only MD medicine. By the time I became a professor, there are already super specializations in human, this one. Like for example, neurologist, nephrologist. I think a day will come in AI where, as you said, it will be specific.
it will be nephrology specific.
Yes, sir.
It will be neurology specific. And that has got advantage, disadvantage both. As you know, when I think of neurology, I will think only of neurology. So probably you have to have a combination of both, where AI will go and direct you to the neurology subject, and neurology, that AI will make a diagnosis of neurology. So I think those things will happen. And next one is, what is the effect on the human, our capacity to learn things? Because as a PG teacher from a long time, whenever I ask some questions nowadays, the postgraduates try to hide their phone in between and go to the chat GPT and answer. I think the plasticity of the brain is going down, normal plasticity. Our thinking capacity is going down. So probably whatever AI gives in future, we'll be accepting it. Now only we are accepting. If bio AI, if it becomes very accurate, then I think our plasticity will go down tremendously.
Certainly.
So
sir.
we should be careful about this, so there should be balance. Because as you know, WHO classifies, as a pathologist I'm talking, every 3 years or 4 years they reclassify the tumors. The best brains in the world, they combine and they give. With that, actually, the AI model has to change every 3 years. They have to feed their data. So all these are quite challenging, but it's an interesting topic, because you're almost like a super specialization of AI, this field is.
Yes,
so
sir.
it is nicely, actually it's quite nice. You have put it in a nice...
Thank you, sir. Thank you so much.
Anybody, one more question?
Thank you, sir. Thank you.
I now request Dr. Sudha MJ, Professor Pharmacology, to felicitate chairpersons. Final discussion. Now time for one of the most engaging and insightful segments.
It is now the time for one of the most engaging and insightful segment of today's CME program, the panel discussion.
We invite Dr. Rekha Gurumurthy, Dr. Kumar GV, Dr. Sudha MJ, Dr. Hamsaveena. Now, request our respected moderator, Dr. Shivalila C, to kindly take over the session and lead us through the panel discussion. Dr. Vivek sir, the moderator, to kindly take over the session and lead us through the panel discussion.
Welcome all panelists for panel discussion. Panel discussion is on the ethical guardrails, data bias, and human touch, navigating AI healthcare. Since morning, we have had extensive talk on many of the aspects of AI, including how to use AI in medical teaching, and also in research and for clinical practice. Now we will begin with this panel discussion on data bias and human touch in clinical patient care by asking this question to Rekha madam. If AI becomes highly accurate, what aspects of medicine should always remain exclusively to human? Like which are the aspects of medicine where we should have a say?
Good evening, everyone. I thank the organizers for this opportunity. And I don't know why you have chosen me to speak on this because I'm not a very AI person at this stage. But I understand that AI is going to be a part and parcel of our lives. And it is evolving as we speak. From morning to now, it has evolved so much. It has gained so much knowledge. And as of now, when we talk about the three domains of learning in medical education, there's cognition and there is skills and there is the attitude or affective domain. So in that right now the leader in the whole thing is in cognition. AI is conquered the cognitive domain. It remembers. But when it comes to the skills and the affective domain, I think there is still a long way to go for the AI. One is the human touch and physical examination and getting the cues from the patient when we are interacting with the patient. We were taught when we entered into first MBBS, we were taught when a woman walks in, we have to see the height, weight and gait. Gait is very important to tell. So that sort of teaching, I don't know how much of AI, that much of teaching is happening with the AI. And of course, the ethical concerns and also I want to give an example and what my previous speaker was talking about missing the clinical data. I think that is the most important thing when we are arriving at conclusions when it comes to you're talking about hospitals only, no? The patient care. So I want to give one example. There was one patient, I just walked into the labor room and they told me that there is a patient who got admitted somewhere in the night. There was a senior obstetrician who was on duty that day. They said this is a patient who is having anemia and ascites. This is the information. Why I am saying missing clinical data reminded me of that case. So they said we are transfusing blood for her. She is a case of anemia with ascites. That is all the data which was given. But when I actually examined the case, I knew that something was not right with this young girl, unmarried. So they didn't think of pregnancy. They didn't do a urine pregnancy test. And it was actually a case of ruptured ectopic pregnancy. And if we had waited for a longer time just giving blood, we could have landed up in a mortality. So what I am trying to tell is the AI is only as good as the data that we give. So there is a long way to go, but humans and human intelligence, not artificial intelligence, and the human skills are still very relevant in the hospital setting.
Especially in patient care, something called Kai Guna. Like
Human touch.
The moment you walk in the ward, many patients will feel confident. That may not be replaced with the AI. They may do hundreds of things with AI, ChatGPT and all those things. What has happened to me? What is the correct treatment? Whether the doctor has followed protocol or all those things. Whatever.
Lot of emotional part of it, where we can read the anxiety and we reassure the patients. Or especially we cannot break the bad news in a very monotonous tone. We can't just tell in a very sing-song tone of the AI. We can't tell them you have cancer or you're going to die in the next this many months or something like that. So these are the things that still is in the human domain only.
That's a wonderful thing to put up. Any other different opinions? Anything you want to add?
I just want to thank the organizers for providing me this opportunity because I'm sharing the dais with my own UG teacher, Dr. Rekha, and I'm very happy. And what Madam said is very true. And we are very blessed that we learned from the best of the best teachers. So I'm not really sure how much our students will be having the same experience with the advent of AI and with the interest also. So to answer your specific question, like both of you have already mentioned, clinical care, patient care, human intelligence supersedes everything else as of today. Again, I'm adding as of today. We don't know what next or what tomorrow holds for, because there are a lot of ways that the LLMs are being trained. Dr. Prasad beautifully mentioned various models and how missing data can also be imputed. But still there is scope as of today for human intelligence. That's what I would say.
Thank you. Moving on, since morning we have been told that many models are there which can take clinical decisions. Sir, I would like to ask you this question. Which clinical decisions require human intuition despite AI recommendation?
Good evening to all. I thank Department of Anatomy for giving me this opportunity to be a part of this program. Definitely human intuitions are required. As you were only telling, current AI is only compares with whatever the data is already available. So many situations you may not get classical. There might be atypical presentation. If you feed that thing, the AI gets confused because there is no classical findings. So it may give you a different other manner. So in there, human intuition really comes into. You have to analyze even for the minute of the history or examination findings. In that situation, it comes. Another situation to tell is, suppose you make a diagnosis and you have asked for a lab reports, and whatever you thought of and the lab reports are entirely different. Then the AI cannot predict. AI only says if these reports are there, it is the diagnosis. If these findings are there, it is the diagnosis. But in human intuition, here also required, we thought of one diagnosis, but the lab reports are entirely opposite. Then we have to put in our knowledge and see why is the problem and what exactly happens. Another one, Madam was telling, suppose in an emergency, the AI will tell this patient are already having these features, he may not survive, he can end the supportive measures. That really we cannot go and take off like that. Just because the AI is told, we cannot stop. You have to, emotions are there, you have to talk to the patient attenders, you have to give time for them to acquaint to the situation, then slowly you can explain them, then slowly you can stop or whatever the patient attenders is. In these situations, human intuition is very much needed. You cannot just follow the whatever AI says. That's what I thought.
Thank you for your input, sir. So to summarize, largely the clinicians' decisions will stay largely, at least for time being, till the major leap in the AI happens. So thank you very much for the input, sir. I would like to ask Dr. Hamsavina ma'am, can modern AI recognize emotions, or is it only restricted to detecting the patterns in the data?
At the outset, I would like to thank the organizers for giving me this opportunity. My answer is no. Any modern AI or whatever large learning models might be developed, but they all still are based on, if they are recognizing, even though we feel they are recognizing the emotions, it is only based on the patterns. Maybe they might use different patterns to recognize. Some might use the voice tone, some might use the facial expression, or some other variables, but it is only the patterns the AI can recognize, because emotions are totally dependent on like whatever the experiences we have undergone. Based on that we will be recognizing the emotions, and since it is just a machine, it can never be able to recognize the emotion. I think that is where the human interference is required, and that is where we have a role to play in healthcare. That is because AI is not recognizing the emotions. And at the same time, another thing what we need to remember is the AIs are trained so well to be empathetic, and that voice AI chatbots and all so well trained to. They don't have fatigability, so they can show the empathy so very well. Even for the 100 patient they are facing, which is not possible because we can recognize the emotions, we get tired. So the junior or the upcoming doctors need to keep this in mind. The AIs cannot recognize the emotions. That is where we have our role, and that is where we need to conquer the AI. And the second thing is, if we don't like expertise ourselves in that empathetic part, and we totally depend on AI, definitely we will have to surrender to AI, because that part it is doing very well. There is no fatigability for AI. For any patient it can be very empathetic. It will not get aggressive. It will not get angry with. It will not get irritated with any patient, unlike the humans.
I totally agree. Each one of you might have clearly seen in the Instagram a small little boy, Gunda, coming and explaining so many complex philosophies of life, telling some small joke. Are you emotionally connected with that character? Correct, no. Like quite often we try to like it or try to repost it. The moment you do it, the algorithm will pick up the pattern and it will keep showing you the same thing and over and over and again. No, at least for such kind of emotional contact, it is still winning as of now. But definitely not when it comes to the patient care, especially in the OPD, crowded OPD. Or in the ward where there are different patients are there with the same in the ward, same ward. So it is quite difficult to emotionally master for existing AI models to win in such situations. So thank you very much for that insight, ma'am. I would like to ask the next question to Dr. Sudham. What exactly is algorithm bias? And can this biased AI become an ethical issue?
Okay, if I have to put it in a very simple form, I would like to say if your LLM models are trained, say for example, in US, with loading some images for identification of melanoma. Okay. So just by feeding or reading the images, you have trained the LLM to identify melanoma. It may pick up and it may be right also. But if you use the same model without any additional layers, or if you have not used it in a different population like in India, if you try to use the same model, because of our dark skin, it may not pick up. So, this is algorithm bias. It depends on many parameters. I've just simplified it to one parameter. For example, does it cause or need ethical dilemma? Yes, because we wouldn't know whether the AI is providing the right output or not. So clinically, we may be wrong. So we may miss out on diagnosis or treatment. So that would be my response.
We are happy to we are in the current situation where we are talking about algorithm bias sitting in 2026. Imagine the situation in 1956 or 1926. When West continuously kept on pushing their algorithms on us, that time we blindly accepted without even asking whether those algorithms, whether those data is rightly fitting to our scenario or not. That's why we are sitting in such kind of a thing, doing some panel discussions. These are imposed on us. At least now we are happy that when we are trying to adopt to AI, we are asking these right questions. Thank you so much. I would like to continue the next question to Dr. Rekha ma'am. Should hospitals test AI before deployment, if at all they deploy?
Definitely, there is no doubt about the answer. The same thing Dr. Sudha has told. There is going to be a bias. We don't know who has developed the AI. And also we need to audit and validate any AI that we are going to start using in a hospital setting. We need to have we need to know whether it is fitting into our hospital settings. And also the bias we were talking about, same thing like she told, maybe the older people, they start predicting that they are having a higher chance of having some serious illnesses because of the bias of the data which is there. And also the data privacy, whether the data privacy is maintained, or are we going to give the data to the AI and it is going to use it in what way is it going to use. And first and foremost concern for us would be when we are using it in the clinical setting, what is the patient safety. So these are all the concerns. So that pre-deployment we have to have this analysis whether it is going to fit into our clinical data. And also when we are using it, how is the monitoring going to happen? Who's going to take a call of when the things go wrong? Who's going to monitor it? What signals that a bad decision is taken, and when it is taken, how do you identify it, and how do you rectify it, and who takes the call? to ultimately terminate the use of this probably this AI, or are we going to change it in a way? It's a whole different panel discussion, I feel. So definitely we need to be very, very cautious, mainly because of the patients.
I totally agree, ma'am. This is for higher tasks. For simpler tasks like just summarizing. Say for example, one group of second year students have gone to a ward, and from one patient they have taken the history, and the same PG has to write the case sheet. Now is it possible that we take a summary from 4 students and feed it to AI and write a case sheet from the already taken data? This is the derived data from the primary one. So such kind of
I still feel as long as it is cognition, we can go ahead with it, but when it comes to the other thing, and also taking history for me is the most important thing, the first step, and this is where we miss out on the cues, we miss out on the data collection, and this is where we miss out on the diagnosis, or the misdiagnosis happens. So maybe the discharge summary, like my previous speaker was saying, maybe things like that where the data is already there and that has to be made into a format or something like that. You can use it in those things, and maybe for the coding and things like that. But other than that, I think we have some way to go, not a long way. I think we're going to conquer all the fields at the rate at which it's going, but we have some way to go. I wouldn't say history taking, I wouldn't give it to AI.
So next committee will be AI committee. Anybody interested? Yeah, AI governance committee. Thank you for the insights. Next, I would like to ask Dr. Kumar, should AI become a second opinion or the first opinion?
Of course, it cannot be a first opinion. It always be helping the clinician. What happens? Main AI is comparing the data. So even if you miss the minute details in the history or examination, the AI will not be a correct picture. As Madam told rightly, anemia and ascites, if you put it in AI, it gives so many things. And it can miss the actual diagnosis. With proper history only, Madam to diagnose the abrupt ectopic pregnancy. So similarly, minute points become very important. So what best can be done is, as a clinician, you take the history. There is no substitute for history. You take proper history, proper examination. Then you analyze the history and examine. That you come to a proper conclusion after your analysis. And you can add the same to the AI. AI can give you a differential diagnosis, or whichever point you have not may prop out. So then you can come back again and then analyze and compare proper.
So
always second opinion rather than first opinion.
So this is for the doctor, sir. For the patient.
For the patient. Recently we have seen that many people without going to doctor asking directly AI and treating themselves landed in hospitals for other reasons, having complications also. So better AI should be used in a proper way rather than thinking AI itself is not a physician or a clinician. It has to go through, it only should assist the clinician. It cannot replace the clinician. What's
So thank you very much. So take home message. It's always a second or third or whatever. It should never be the first. Complementary. Yes, thank you so much. Dr. Amsavina ma'am, who is responsible when AI makes a harmful recommendation?
I think answer was told in Dr. Sudha's session in the morning. It is definitely the primary physician or whoever is taking or employing that decision is responsible. Of course, when we go back and check the developers, the administrators or management, all those people might be accounted for the whatever mistake has happened, but still the main responsibility lies with the clinician. That is why in every session like which they were taken since morning, they were stressing on this point that human intervention is definitely required at any point, whatever might be, however sophisticated the AI model is, human interference is definitely needed, because they are the ones who are taking the responsibility finally, and they are accountable for it. So that is where we need to be very cautious when we are using AI for clinical decision making, even for academics, when we AI for preparing for the class, not just to take any material and present it as it is. We need to, like as medical teachers, we need to go through the presentation before presenting, because we have gone through the textbooks, and even while assessment, many a times we see that when we set the question papers, the MCQs are made just taken from whatever AI recommends, the MCQs are given. Half the time it is not you need to check for it, because you can't use it directly, and ultimately you are responsible, because as Dr. Tejasvi was putting, the AI will not sign, the signature will be of the doctor.
So the final signatories, whoever signing with the stamp, will be the responsible person.
Will be the responsible person
in the court of law. Story over. Thank you so much, ma'am. Continuing with that, suppose if a patient goes and buys a medical device and it shows something like totally abnormal, like heart rate 140, 160, and with that he lands up with stress or anxiety disorder or something, then who is accountable for that? Because now the patient himself has gone and he has taken no recommendation from anybody. He is over enthusiastic to try test something, and he has taken, and he landed up in having anxiety disorder or something. Then who is responsible for that?
Patient is solely responsible for such thing, because as of today we do not have any law or regulation not to sell these devices for or for the utility of it. If the device is purely mentioned for clinical practice only, then the patient was not supposed to buy the device or do whatever he or she was not supposed to do. So in the scenario you have described, I think it is the patient who is responsible or accountable themselves. Even if you go to the court of law, that will be the response, probably.
So before entrusting any work to the devices and their recommendations, patient need to be aware and is well educated about the outcomes or the process that goes through the device, how exactly it is testing out the heart rate or the steps for that matter. Quite often everybody is very happy that they have walked 10,000 steps or 8,000 steps. They have accomplished their daily targets. So they should be aware how exactly those steps or the heart rate is being calculated. So it is important that patient education is of paramount significance in this. Thank you very much.
Thank you.
For this fruitful panel discussion. With this, we come to end of this panel discussion. Thank you so much for having everybody on the stage. Thank you.
I request Dr. Shivalila ma'am to felicitate the moderator.
दुनिया में सब भी गिरा वाला
Dr. Rekha Gurumurthy, Dr. Kumar GV, Dr. Sudha MJ, and Dr. Hamsavina.
We have now reached the concluding segment of today's CME, the valedictory function. Thank you.
Thank you for all the guests. On behalf of the Department Anatomy, SIMS and RH, we express our sincere gratitude to all speakers, chairpersons and delegates for making this event a grand success, and the online viewers. Thank you for everyone.
We'll take photos. On behalf of Department of Anatomy, we would like to thank online, offline delegates, the supporting staff and IT department. Thank you so much. We'll take one department photo. All of you come.
Thank you.
ಬರ್ತಾರೆ ಅಲ್ಲೇ